معايا؟ تيست معايا؟ تيست معايا؟
الو، السلام عليكم. الو، السلام عليكم. بسم الله الرحمن الرحيم. يكلم. ها. قول لي عليه حاجة عشان أجرب الكيفة. هم؟ خلاص. جرب.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Good morning, everyone. Thank you for being here the early morning on Saturday. And today schedule is a little bit busy with very informative sessions and lectures. We'll start with so we have today the radiation oncology or the Saro here, related to radiation oncology, and the other room is radiation therapy. And at 11 o'clock, the medical physics program will start, also in the other program, in the other room. So today we'll have the toxicity session, the gynae, the pediatric and sarcoma, the breast, and one of the unique session today will be the Astro indoor session this afternoon, inshallah. So without further delay, I will invite the moderator for the first session, Dr. Rima Al-Imran, radiation oncology consultant at Al-Mana Hospital in Dammam. Dr. Hassan Al-Amoudi, he's a radiation oncologist at Eastern Jeddah Hospital. And Dr. Ziad Justiniya, consultant and assistant professor at King Abdulaziz University. The mic is yours, Rima.
Thank you, Dr. Yusuf. Assalamu alaikum, everyone. Good morning. Inshallah, without further ado, we'll start with the first session. It is with pleasure to introduce the first speaker, Dr. Reem Al-Imran, who is a consultant radiation oncologist in King Fahad Medical City in Riyadh. Dr. Reem, the mic is yours.
Thank you, Dr. Reem, for the kind introduction, and good morning, everyone. So today, I will be talking about the best practices and innovations to mitigate the risk of lymphedema. So I have nothing to disclose. So we'll start with basic fundamentals. Lymphedema is defined as a chronic and often progressive condition characterized by the accumulation of lymphatic fluid in the interstitium, leading to swelling, pain, and often fibrosis. And among cancer survivors, it extends the physical impact extend beyond the physical symptoms to encompass functional, cosmetic, and psychological dimensions, leading to substantial affection to the quality of life. The International Society of Lymphology provides a widely used clinical staging system, ranging from subclinical stage to more advanced stage, characterized by severe swelling, significant fibrosis, and skin changes. And stage 0 represent a crucial stage as it provide a window for early intervention and risk reduction strategies. Normal lymphatic anatomy is complex. It starts with the tiny capillaries within the superficial dermis, drain to the precollectors, and down to the superficial lymph collecting vessel within the subcutaneous tissue. That obstruction or damage to any of this pathway will lead to lymphedema. However, the body can adapt to this obstruction mainly by the dermal backflow, which is considered a specific imaging criteria for the diagnosis of lymphedema. It serves as a dual function, first by bridge the gap between the obstructed and the patent vessel, and also provide an alternative pathway for the lymphatic flow. Other response also include lymphangiogenesis by creating lymphatic vessels. So the lymphatic vessels has the ability to regenerate, overcoming the obstruction. Also, it can have an alternative pathway through the deep lymphatics within the lymph or into the lymphatics in the trunk. And this explains why certain patients might not develop lymphedema following extensive surgery. Radiation-induced lymphedema by several mechanisms, including damage to the endothelial cells and smooth muscle cells within the lymphatic vessel, leading to obstruction and reducing contractility. Also, radiation-induced fibrosis, acute and chronic inflammation exacerbate the fibrosis and impaired lymphangiogenesis. Identifying patients at risk is important for prevention. We have patient-related factors, which include higher BMI, history of pre-existing lymphatic issue like cellulitis, and genetic predisposition. Also, tumor-related factors when we have extensive nodal involvement or tumor causing direct obstruction to the lymphatic flow. The major drivers for lymphedema are treatment-related and include the extent of surgical resection, also irradiation of the nodal basin, which is dose-dependent and volume-dependent, the combined modality approach associated with the highest risk of lymphedema, and also some chemotherapy agents like the taxane. This was a comprehensive review of almost 500 breast cancer patients following regional nodal irradiation. They were classified into 3 groups based on the extent of nodal irradiation. Group 1 were treated with limited field, including axilla level 3 and supraclav, and group 2 and 3 treated with extended field radiation to the axilla using anterior oblique in group 2 and group 3 with parallel opposed field. And what they found that the incidence of lymphedema was remarkably reduced in group 1 with limited field, reaching to 7.7% compared to almost 40% in the other group, suggesting that modification of the field design may actually decrease the risk of lymphedema. Also, the timing of lymphedema varies, depends on the modality used. Early onset of lymphedema, less than 12 months, is associated with axillary node dissection, while the late onset usually associated with radiation. And the peak onset varies based on the treatment modality used. So in terms of the diagnosis, the clinical evaluation of patients with lymphedema requires a comprehensive approach, starting from detailed history taking, physical examination, and the use of the quality of life validated tools. Also, objective measures historically, the use of the water displacement volumetry. We have the perimetry and the bioimpedance spectroscopy, which provide assessment of the lymphedema. The advanced imaging modalities like lymphoscintigraphy and magnetic resonant lymphangiography, which provides high-resolution images, aids in the surgical planning, along with the ICG lymphography. Ultrasound also help adding in the assessing the skin thickness and the subcutaneous changes and the fibrosis. So the lymphoscintigraphy is a gold standard for lymphedema diagnosis. It's non-invasive techniques, involves injection of radiotracer to visualize the lymphatic flow and drainage. You can see here on the left hand, the normal symmetrical lymphatic visualization in both limbs. In the middle picture, you see the decreased function by decreased visualization of the lymphatics. And the image on the right hand, the obstruction, which basically characterized by lymphatic dermal backflow and also drainage to the cervical lymph nodes. Another method is the ICG lymphography. It's also a non-invasive imaging technique mainly used for the superficial, for the assessment of the superficial lymphatic vessels, highly sensitive for detecting early lymphedema before the clinical symptoms appear, which is useful in patient surveillance. And this table just compares the different assessment modalities. So for prevention and risk reduction strategies, we have key elements that is centered on the patient, which involves patient education, prospective surveillance, and early intervention, along with lifestyle modifications. So starting with education, the studies shown that there are gaps regarding the patient education. Almost 80% of breast cancer patients reported inadequate information provided by the healthcare provider. Also, studies have shown that patients have different preference in terms of the timing of receiving the information. So this is a proposed framework for lymphedema education, involve the concept that needs to be discussed with the patient at different time point during their journey. Prospective surveillance was proposed as a service delivery model for early detection and intervention. It involves patient assessment, education, and timely referral to lymphedema specialists. It starts at the time of the diagnosis of cancer and also continues toward the journey of the treatment until 5 years post-treatment. So studies have shown that prospective surveillance reduced the risk of lymphedema by almost 70% and also reduces the financial burden on the healthcare system. So the cost of lymphedema management is 5 times the cost of implementing the prospective surveillance. Lifestyle modifications include regular exercise and weight management, as well as meticulous skin hygiene, all shown to reduce the risk of lymphedema. The use of prophylactic compression have been studied in this randomized controlled trial from India in almost 300 breast cancer patients following axillary dissection. So they were randomized into post-operative care, which involves patient education versus post-operative care, along with the use of compression sleep for 3 months of the adjuvant therapy. Patients were assessed by bioimpedance spectroscopy along with arm measurement, and both showed decreased risk of lymphedema with the use of compression, suggesting this as a method to as a risk prevention. One of the emerging surgical approaches, the axillary reverse mapping, which basically involves the preserving the lymphatics that supply the arm by using dual imaging to identify the draining lymph nodes and using it during the axillary dissection. Research indicates that ARM significantly lowers the rates of lymphedema compared to the traditional surgical approach. Another emerging surgical technique also is the lympha, which basically involves the creating of anastomosis between the lymphatic and venous, as you can see here. The studies have shown reduced risk of lymphedema. However, the long-term results need to be validated. So with regards to the management, the multidisciplinary approach is still in the managing lymphedema. It involves the multidisciplinary team consists of certified lymphedema therapists, oncologists, surgeons, psychologists, dietitian, and nursing. Integrating all these specialties basically will provide a patient-centered approach in managing lymphedema, addressing both the physical and psychological need of the patient. Key components of patient education basically include the knowledge about lymphedema, recognizing the early signs and symptoms, risk reduction behaviors like skincare, weight management, avoiding infection, and the importance of seeking help when developing symptoms. The gold standard conservative management of lymphedema consists of the complete decongestive therapy, which involves 2 phases. The phase 1 will be the more intensive phase, typically range between 2 to 4 weeks, performed by certified lymphedema therapists, and consists of manual lymphatic drainage, the use of multiple layer compression bandaging, exercise, skincare, and patient education. And it requires compliance from the patient because it will successful completion of this phase will help in transition into the maintenance phase, which is mainly based on the patient compliance. Again, the exercise also improve the lymphedema is a core in lymphedema management. It improves the lymphatic flow, reduce the lymphedema volume and symptoms, helps with weight management, and enhance the quality of life. Different exercises available. The key principle is to start slowly, progress gradually under supervision. Emerging therapies include the advanced pneumatic compression devices, the TAVA, which is specific exercise program to reduce lymphedema, the use of BioBridge technology, and personalized medicine approach. So the radiation oncologist plays an important role in lymphedema management by assessing the patient, providing education, the use of modified radiation techniques to reduce the lymphatic coverage while balancing the oncologic outcome, and collaboration with the other multidisciplinary team, continue the surveillance and management, refer the patient timely basis to the therapist, and also contribute to research and guideline development. So key messages: cancer-related lymphedema significantly impacted patient quality of life, and radiation oncologist plays an important role in prevention and management. The risk stratification prevention strategies are essential. The optimal outcomes of lymphedema depends on multidisciplinary approach. We need a lot of research to advance the lymphedema management prevention in focusing on diagnostic tools, novel therapeutic, and refined radiotherapy technique. And at the end, it's a patient-centered approach, empowering patient through education, shared decision-making, and focusing on patient-reported outcomes will drive the improvements in lymphedema care. And with that, I would like to conclude. Thank you.
Thank you, Dr. Adim. It was very comprehensive and detailed presentation. We'll move to the next talk. I'm going to present Dr. Shakir Shakir. He's a consultant radiation oncologist at King Fahd Specialist Hospital in Dammam. And he's going to talk about the evidence-based management of radiation-induced toxicity in the upper and lower GI system. The mic is yours, Dr. Shakir.
Assalamu alaikum. Thank you very much for the nice introduction. It's my pleasure to be with you today with this wonderful group. Our talk today is about the huge generic topic of radiation toxicity in the aerodigestive tube. So as we know, it's essential for radiotherapy to be used for abdominal pelvic tumors. The GI tube in general is a radiosensitive structure and has acute and chronic toxicity. And it's variable, depends to the site, and each site has distinctive sort of management. So just theoretically, the mechanism of toxicity rely on destruction of mucosal layer, which is going to disrupt the mucus secreting function, as well as the normal flora. Usually the acute toxicity is reversible, and the mechanism behind it, it's rely on a lot of cytokines releasing the inflammatory effects with disruption of the mucosal layer. Could be translated to many symptoms, depends to the site. Regarding the chronic toxicity, it's kind of complicated because it's relied on the effect of radiation at long term by inducing endarthritis obliterans and chronic ischemia, which can lead to fibrosis, as well as neurotoxicity, which can be translated later on in a form of motility dysfunction and stenosis. The classification, as we said, depends to the timing, whether it's acute or chronic, location, and severity. The most accurate or practical toxicity classification of toxicity is CTCA version 5, and it depends on the grading. Grade 1 or just modified lifestyle, and grade 2 symptomatic treatment with continuation of treatment. Grade 3 severe, it might mandate stopping and holding radiotherapy for a while. Grade 4 stop radiation at all. So toxicity depends to many factors, intrinsic and extrinsic. Depends to the dose, whether it's a total dose or dose per fractions, the volume, the technique, which is going to rely on it, because radiation toxicity in general nowadays could be considered as a historical facts rather than major challenge given the new techniques. And for sure, presence of concomitant chemotherapy might expedite and enhance the toxicity. Other factors could be rely on the comorbidities, age, and genetic composition of some syndromes. In general, this is some sort of points to minimize the toxicity in general. We're going to pass through them later on. The incidence, this is in 1998, so it's historical, but we have to mention it just to compare what we have today. So if we start with the mouth, for example, mucositis has multiple grades of toxicity, incorporating the presence of mucosal inflammation, xerostomia, and the presence of fungal infection, and so on. The dysphagia provoked by radiations, as we said, is classified into 4 grades, depends on the tolerability and palatability of food, whether it is solid, soft, and liquid. Sometimes in grade 4, patients wouldn't be able even to swallow the saliva. Another toxicity is dysgeusia, loss of taste, which is temporary. So in general, the acute toxicity is managed by enhancing oral hygiene and utilization of magic mouthwash, consideration of some dosimetric parameters. Chronic, for sure, utilization of the new technology would be able to reduce a lot the future chronic toxicity. Some centers, they might utilize artificial saliva to keep the mouth wet always. Sialagogue, it's an historical utilization of factors that provoke secretion of saliva. The dysphagia itself and odonophagia is primarily affected due to toxicity in the oropharynx and pharynx. We have to make sure that our patients should clear themselves out from dental procedures before starting radiation therapy. If we are anticipating a lot of toxicity, we might be forced to install a tube feeding to assure proper nutrition before starting radiation. It's going to be temporary. Unfortunately, some toxicity might happen whether or not we took all these precautions. The esophageal toxicity in form of esophagitis could be translated into choking, foreign body sensation, pain, retrosternal pain, back pain, and for sure we need to manage it accordingly. Magic mouthwash is a nice mixture which is left for the discretion of the physician. I put for here some of the component that could be utilized in a mixture. It has to incorporate surfactant agents, antifungal, lidocaine, antihistamine. We might incorporate sometimes even prokinetic agents and PPI in form of solution. The stomach toxicity, the same mechanism, loss of mucosal layer, loss of secretory function, some distortion of the motility, which could be translated into nausea and chronic effect in the form of ulcer bleeding, which at certain point might require surgical intervention or endoscopic therapy. One of the most important things to alleviate nausea is to utilize antiepics, preferably citrons rather than metoclopramide. Pancreatic toxicity is diplomatic talk. It's not considered as an organ at risk when we are considering treatment of abdominal radiotherapy. However, it is there. A toxicity could be translated to secretory function distortion or endocrine function distortion, which might mandate utilization in the future, enzyme replacement, and insulin. The liver toxicity is not a major issue in abdominal radiotherapy because if you are treating, for example, esophageal cancer, pancreas, we're taking a small crust of liver to be a part of our PTV. It's not going to be a major issue, except if you are treating an SBRT. So in general, we have to maintain our dosimetric constraints respectful to save at least 700 cc of the liver to be touched with more than 15 gray with a mean dose of 30. I'm going to put a dedicated slides for all the constraints at the end of my presentation. Sometimes you might need to utilize some sort of short course corticotherapy to alleviate acute liver toxicity and enzyme disruption. Small bowel and large bowel are more or less the same, but it's different in terms of small bowel. that the effect might be need to be elevated with anti-flatulent agents, antidiarrheal agents, and the chronic toxicity, if there is a stricture or adhesion, might require surgical interventions. As we said, in general, prevention is better than treatment. The main function of large bowel is to resorb and formulate the stool, so resorb water. We need to encourage proper hydration and utilize antidiarrheal agents if needed. Chronic toxicity in form of ulceration and stricture could be managed either conservatively or with surgical intervention. Rectum is a common organ to get a toxicity from pelvic radiotherapy. One of the most interesting modality to alleviate proctitis radiation-induced is the proctoform, which is a steroidal form of enema, mesalazine, non-steroidal, and sometimes you might need even use morphinics because it's very painful, the false tenesmus. If the telangiectasia appeared at the chronic stage, endoscopic therapy with coagulation might be needed. Anus is considered as an organ in GI, like and treated as a skin. So with a skin toxicity, typical analgesics, flamazine, beta-sitosterol, and for sure, minimize the toxicity. So in general, I put a summary of all constraints for all organs of aerodigestive tube with the DMAX and other criteria. As we said, this is just a historical information. Most of our new technology by using spacer between the rectum and the prostate, for example, maintaining bladder full to push away a small bowel from the radiation field, is a lot of manipulations to minimize the toxicity. I think I'm approaching the end of my presentation. So in summary, radiation toxicity, it exists, could be managed with a lot of technique. Medications might be used to alleviate the symptoms. If the symptoms is severe enough, we might need to hold radiation for a week and reassess again. Presence of concomitant chemotherapy will aggravate a toxicity. We need to encourage our patient for a proper hydration always. Smoking cessation is very important for aerodigestive minimization technique. Some authors used antioxidants in the form of vitamin E to expedite regeneration of mucosa. Nutrition is very important. So we have to anticipate if my patients could have a severe upper GI toxicity to assure and secure tube feeding. Historically speaking, when I did the research, I found a lot of topics talking about utilization of amifostin as a cytoprotective agents for patients receiving radiotherapy, which is not practical in any place that I have been through, France, Canada, even Saudi Arabia, because the practicality of utilization of this medication, which has a very short lifespan, to be given by injection before each fraction. يعني just للأمانة العلمية, I need to mention it. So in general, we need to respect the constraints to minimize acute and chronic toxicity. Medications are there to alleviate the toxicity as well. For sure, we need to collaborate with all teams, gastroenterologist, surgeon, radiologist, to manage all these toxicities. Thank you very much.
Thank you, Dr. Shakir, for your excellent presentations. Now we will move for the last presenter. I would like to present him, Dr. Saad Al-Rashidi. He's a consultant on the radiation oncology in King Fahd Medical City and associate professor brachytherapy and lead radiation at Al Faisal University.
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Al-Amoudi. Thank you for the Saro organizer and Dr. Yusuf Katib for the kind invitation. Really, it's a pleasure to see all of you. This is a very boring topic, and I think Dr. Shakir and Dr. Reem will really cover most of it, but I'll try to take it from a different level. So this is not for you. So I'm talking about the bladder dysfunction post the radiotherapy. And really, when you talk about the bladder dysfunction, any radiation to the pelvis, not necessarily to the bladder itself, although when we focus on the bladder, we are nowadays more involved than ever because of the advancement of the technique, as well as the tri-modality therapy nowadays really taking off. And you will see more bladder preservation than before because now the systematic therapy, especially the immune therapy, are coming. And although this, I should not say that, but really in June, there will be a breakthrough for the immune therapy utilization for the bladder preservation. That will change the era for our practice. And I think we'll be seeing more bladder treatment with the radiation than even before. Also, the hypofractionation nowadays really shortening the radiation from the prolonged course, and it's becoming more appealing to the even to the surgical community that, you know, when you give less fractionation and for the patient themselves. I'll go through the acute effect. So the acute cystitis, although this is more for the resident than the who are practicing already, it's the transient mucosal inflammation with the radiation, and we define it if it's happening before 6 months from the end of the treatment of the radiation. Common symptom like irritative symptom to the bladder, urinary frequency, urgency, dysuria, and microscopic hematuria. Now, it's not gross hematuria that I will come later, and can happen 20 to 40% depending on the treatment where you are treating. Although, as my colleague Shakir is saying, it's really becoming historic, and you know, you see it in the textbook, but nowadays with the more evolvement of the technique, I think we see less and less. The pathophysiology known, and the timeline, the peak 3 to 5 weeks, although now we see it more with the hypofractionation earlier, and it can resolve within a few months from the treatment. The tri-modality exacerbate the symptoms, especially when you give more aggressive chemo, like with the cisplatin. We did some review when I was resident with McGill Group with gemcitabine. It's less toxic and more tolerable, and really the efficacy the same. So I tend to also push the group with me to give the gemcitabine if we are giving the tri-modality. That really lessen the side effect with the patient. The hydration is the key if you want to be encounter with that, and encourage the patient to drink really a lot. Although this will, you know, they are already an irritative symptom and it will cause more irritation, but also the lifestyle modification in our community encourage them to minimize the caffeine and the bladder stimulant in general. And the medical intervention, when it's necessary, you can give the anticholinergic medication, and it may control the spasm of the bladder. The late effect, which is more, I think, problematic than the acute effect, because most of the acute, we're lucky that we don't see it, and they may like go to some service and before coming to the radiation, and we don't really treat it much. So the long term, if this happen after 6 months, and the commonest that, you know, we may encounter, especially with the surgical community, if the patient land in the service, is the hemorrhagic cystitis, urinary incontinence, the overactive bladder, and the reduced capacity urethral strictures. If you are radiating, also the prostate, and the bladder fibrosis, and the secondary cancer. So the hemorrhagic cystitis, which defined by gross hematuria, not microscopic hematuria, with development of the new vascularization over years because of the radiation. And again, this becoming more historic and less seen than before. But with the old series and old radiation technique, it can happen up to 10%, and it can happen up to 20 years, although I would say, you know, this is not the patient who's with bladder cancer, but maybe with prostate cancer or radiated, and most of the senior radiation oncologists know that. And seen more with over 60 gray. Now, most of the radiation in the past given 70 gray or even more. And the treatment, it can be conservative like bladder irrigation. We encounter with that. The intravesical agent like alum, and the hyperbaric oxygen also can be effective, but the recurrence rate is high. one of the complications that can happen, the anemia and the bladder tamponade, as well as the renal failure. The renal incontinence, can happen, and we encounter it, I would say, more than even the hemorrhagic cystitis, which is, more for our community is really problematic because, they need to go to the mosque, and it's really an issue for them. And the prevalence can happen up to 20%, and we encourage them to do the pelvic floor exercise, as well as use some anti-muscarinic medication. And in severe cases, you may also refer to the surgeon with the artificial sphincter. I've never encountered that. The overactive bladder, the same eruptive symptom for the lower urinary tract system, and it can happen up to 30%. And again, the management also similar with the anti-muscarinic agent. Botox can help, but in severe cases also you need to do more aggressive maneuver like surgical intervention. The reduced bladder capacity also like an issue, and it can happen in less than 5%. Management also, you can do the some plastic augmentation and urinary diversion in severe cases. The urethra structure, which is more problematic to us, and especially with the prostate irradiation, it's the fibrotic narrowing of the urethra, and it can happen even with hypofractionation. It is reported up to 10% or 12%, especially after the LDR brachytherapy. If it's given boost more in the patient who receive over 100 gray, and the management, you start with the catheterization dilatation. Sometimes if I encounter a patient, I even put the catheter in the clinic, and it can help opening the passage. And urethroplasty in severe cases can help as well. The severely scarred bladder, especially non-functional bladder, they may do cystectomy. I think this is a case report. The secondary cancer also, especially with the survivor, again, with the prostate and also gynae malignancy, it can happen in long term, and it can happen up to 20 years. Especially it's attributed if you are giving more than 30 gray, and most of the radiation over 30 gray. Now with the helical therapy, if you push the dose around the all organs, also it can happen. And the management would start with the diagnosis and the treatment as any bladder cancer patient. Urinary fistula also a problem, and it's abnormal communication, and can happen less than 1%, but if you give a high dose over 80 gray, definitely you necrotize the tissue, and you can fistulize, especially if you are giving with the brachy and also gynae malignancy, high dose to the organ. Now I want to talk about the factor influencing, and really it's a summary more than detail. The modern radiation technique really influence what we are doing, and the strict image-guided therapy is the most important. And I emphasize that because you may have like center that not doing really strict IGRT. So the radiation dose and toxicity threshold, we say like, site by site, for the prostate, now we're not giving 70 or 80 gray, we're giving 60, the hypofractionation, but if you convert it really equivalent to what we've been doing before, if you give with the dose escalation with the brachytherapy, definitely with LDR, you may encounter this toxicity. However, if you do HDR, which we are doing especially with the ultrasound base, really it's not reported. And in fact, it's less toxic than even you do the hypofractionation with other LDR. The bladder, now we're coming to 50 to 55 gray hypofractionation, less than, when you're giving 65 gray to the organ. And the cervical cancer, if you give the whole 45, now 50 is really more complication than any benefit, and no one is doing the 50 anymore. But if you need to escalate, of course, with the cervix cancer, and now with the interstitial technique and more hybrid technique, we're coming into really less than the intracavitary system that you're giving the bladder 80 gray or more. You need to keep, like, this is again for the learner, you need to keep the V70 or the V50 less than 15%. The V50 less than 50%, you probably do less. And with the Dmax, you should not exceed with the converted equity to 80 gray. Although we gave before, like, implementing the interstitial technique over the 80 to the bladder, and, never seen, like, these complications. And keep it to 60, although practically not possible. The IMRT or the VMAT nowadays really less than when you are flashing the whole pelvis with the 4-field box or the 3D CRT. The again, strict IGRT. I'm also a believer that the particle therapy like the proton or carbon ion will reduce the toxicity even further. Although the data is mature and we need more data to compare. The dose threshold, as I mentioned, you should not exceed the 60 to the bladder as the whole organ, and you keep also really reproducible bladder. Anatomy matter because if you give the trigon, that will give you the more eruptive symptoms than the complication. You need to prevent, and the prevention is really what we are as radiation oncologists. We think about it, the bladder filling protocol. Now, which I really believe in the more involvement of the technology improvement that will help. And, Shakir mentioned the amifostine. I never did it, and it's there, but, I don't know if it's practical. As he's saying, as radiation oncologists, we barely approve the imaging, so you need to inject the patient every fraction. That's really not practical. The technology really more moving fast, and we're lucky, with industry partner that, there are improvement than before. The adaptive radiation, there are many vendor now do the adaptive radiation, Ethos or EVOS, different vendors. And the MR-guided therapy, like MR-Linac or whatever you call it. We know in the cervix cancer, when we adopted in the brachytherapy, the MR-guided brachytherapy really changed the whole what we are doing. We're giving less dose to the neighboring organs, and we're giving escalating in the target. And, I know the science has to do more than now, but I think the MR-guided therapy will be the future to reduce the toxicity and prevent really the further complication. The particle therapy also will be the era. I think Dr. Zainab, they have in Bahrain and also in Jordan. There will be like a MR-guided therapy. The proton hopefully will be soon in Saudi, and also the carbon maybe in Emirates will be. That's what I have, and thank you very much for listening.
Thank you, Dr. Saad, for this excellent presentation. And if anyone have any questions. Just I have a comment for Dr. Shakir. You mentioned the steroid foam for the rectal toxicity. Anyone know where we can find it here in Saudi Arabia? Because
Assalamu alaikum. Thank you very much. Actually, it's a challenge. I have been requesting a proctoform, which is a steroid form in the form of enema, more than 3 years. Unfortunately, it's not available. So what I'm using practically is his cousin, misalazine. Misalazine suppositories, 1,000 milligram is a good substitution for the proctoform, which could alleviate radiation-induced proctitis, especially from the second or third week. When tenesmus exaggerate to be so much painful, naproxen is a good choice. I could escalate it even to morphine and hydromorph if it's interfering with patients' normal life. But I hope that if we be able to bring it soon, a proctoform is very practical and alleviate a lot of radiation-induced tenesmus.
and thank you, Dr. Tamer.
Thank you very much for the great presentations. My question to Dr. Reem. So Great presentation, great comprehensive review of lymphedema for breast radiation. We know that we cure most of these women, so quality of life really matter. And I agree with you, reverse mapping is a standard in our institution right now. Decongestive therapy is a standard for all women when I treat regional nodal irradiation. One thing that is way underreported though is breast lymphedema, not only arm lymphedema. Some things that radiation oncologists and surgical oncologists interpreted forever as radiation changes, but it does impact the quality of life of these women. We did look at our patients, and all of these women I sent for decongestive therapy, massaging, because it impacts their quality of life, sexual life, everything. We presented our data in Astro last year, and we found out that actually the 30 and 40 gray V30 and V40 going to the breast of the skin with the only factor that correlated to the incidence of breast lymphedema. These women will come 3 months or 6 months out of radiation, telling you that my breast is heavier, the skin is thicker, I have this like discomfort, I'm not having the sensation I had before. And when we looked at our cohort, 20 to 25% of women, so almost 1 in 4. So it's way underreported. The paper is being reviewed right now, so hopefully it will come out soon. But that's some things that I wonder if you see in your practice and if you address it or not.
Thank you. Excellent point. I didn't came across, as you mentioned, like we have a lot of challenges in reporting the side effects of mainly like breast lymphedema, arm lymphedema in the literature. And that's basically, we need to come as a group in order to invest in research, studying all this concerns for the patients. The radiotherapy techniques, the doses, even it's underreported. And I think we can take the initiative in Saro today to probably examine the difference between 3D conformal radiation and VMAT, for example, in managing breast cancer, and looking for the risk of lymphedema in those patients. As you mentioned, also breast lymphedema and the arm lymphedema. How did you measure the breast lymphedema in your study?
So that was a good question. So we had a clinical definition and radiological definition. Clinical definition was any patient I saw and she came with complaints that warrant me sending her for certified lymphedema therapist. So skin thickening, pain, discomfort. And then we compared the pre-radiation mammogram to 3 and 6 months post-radiation mammogram. And we assessed the thickness of the skin in ultrasound and actually radiograph. I think it was like 30 millimeter or something that was the cutoff value when we ran ROC curve. So we did radiological evaluation, we did clinical evaluation. Now our second phase is assessing the outcomes after physical therapy. Maybe we can discuss with Saro some collaboration to do like a larger multi-institutional study between our institution and yours.
What you would add any point to?
Thank you. Thank you for this very important topic. Although we are seeing less toxicities nowadays with the modern techniques, but still when it happens, it's really hectic to the patient and to us. I want to mention our experience at King Hamad Hospital. We have the hyperbaric oxygen. We really see dramatic response for the late toxicities with the hyperbaric treatment regarding cystitis, proctitis, and even CNS after GBM radiation necrosis. But although we should be very cautious because the patient need to be disease-free, any metastatic or suspicion of microscopic like late disease can enhance new lesions. So we face that as well.
I have a question also for Dr. Reem. As you know, in the region here, breast cancer patients population mostly are young patients, 30 to 40 years of age, and with high-risk disease, locally advanced, and what I would call high-risk axilla, large number of lymph nodes, whether with upfront surgery or after neoadjuvant extracapsular extension. And as Dr. Tamer mentioned, we know these are gonna, inshallah, live for a long time. So we try to balance between the controlling disease and risk of lymphedema. So when you encounter those patients in the clinic with high risk axilla, how do you, after dissection, I would say, after axillary dissection, especially, how would you try to balance treating?
Yeah, so it all depends on the risk factors, taking decision to include the entire axilla. So if they are fitting the MRO's criteria, for example, if they had early stage favorable disease, then we can consider sentinel lymph node biopsy. Even if they have 1 or 2 positive lymph nodes, you can include regional radiation that will associated with less risk of lymphedema, reported, I think, around 11% on that, compared to if we use bimodality technique. Post-neoadjuvant therapy, as you know, maybe they presented the data from B51 trial, so we can de-escalate the regional nodal irradiation following complete pathological response in those patients. And I try to select the patient carefully till we have like the following publications. So patient, if they have complete response, good axillary sampling, and for example, older age, HER2 positive or AR positive patient, then we can omit radiation of those patients, taking into account the discussion with the patient. And I'm just wondering, just regarding the techniques, because what we use in our practice is the 3D conformal radiation, but I'm not sure with the VMAT, are you seeing more or less lymphedema in those patients, or because I'm not aware about any literature that published the difference between the two.
So if I may add very quick, and I promise I'll make it very quick. So I believe that the main factor for arm lymphedema is actually the surgical extent, which is definitely more contributing than radiation. I'm a big believer in radiation too, and the local control in these women. We're still waiting for publication of P51, but what we do is that in any node positive patient, we actually start with neoadjuvant chemotherapy, hoping that at least we'll go for targeted axillary dissection. We barely now do any comprehensive nodal dissection, 15 or 20 lymph nodes, unless it's a really very bad disease burden, bad response to neoadjuvant chemotherapy. The majority of my patients was node positive either will follow AMAROS, or even if they had advanced disease and they went to neoadjuvant chemotherapy, we do targeted dissection for the clips and sentinel lymph node, hoping for a good response. If they have more than 3 lymph nodes, we'll have completion dissection, and those are a minority. We have also a device in, I don't know if it's available in Saudi Arabia, it's called FlexiTouch, which is kind of a vest that the women wear, and it does massage their arm and their breast. We use it for both arm and breast lymphedema if they fail a physical therapy. So between upfront decongestive therapy for every woman, between this device if they don't respond well, and between the escalation of surgery and considered use of radiation based on the risk factor, I think we're doing a much better job now.
Assalamu alaikum. This is a question for Dr. Saad and the rest of the panel. Did you guys have any experience with pelvic physiotherapy? Are you aware of any pelvic physiotherapist? The only people I found were in the private sector. I didn't find any in like the big reference hospitals. What's your experience with biofeedback for patients after pelvic radiation and things of that sort? Thank you.
Sorry, could you repeat the question again? I was not like hearing, sorry.
So the question is about pelvic physiotherapy and biofeedback. Do you guys have an established program at KFMC or at any of the other reference hospitals? The only people I found who do pelvic physiotherapy were actually physiotherapists who are working in the private sector. I didn't find any in the reference hospital. Thank you.
I don't think we have like strict program. We refer the patient and they may train the patient, but also like the surgeon also they have like some collaborative service or ancillary services. So I found that helpful, especially from the gynae surgeon group, if they like give them like instruction, etc. But personally, no, I don't.
Any other questions? Dr. Noha?
Just 2 comments for the discussion. I will start with the last one. I think we have the same issue that pelvic physiotherapy is only available in like specialized trained physical therapists for pelvic physiotherapy. I think they're only available in the private sector. Uh, for the discussion about kind of IMRT or advanced radiation therapy techniques, modulated radiation therapy for patients with breast cancer. I think there was this large meta-analysis from the Korean group that looked at effects of intensity modulated radiation therapy on the late side effects of radiation. One of the risk, kind of the late toxicities that they've actually analyzed, they looked, I think, at lymphedema, cardiotoxicity, pneumonitis, and I think some also neurological, like brachial plexus effects. The only side effects that was statistically significant, lower with intensity modulated radiation therapy, was pneumonitis. There was actually a large difference between the two groups. For the lymphedema, it was there was no big difference, but that's I think it's important to note in that analysis, the risk of lymphedema was actually low on both sides. So probably was because these patients were early stage breast cancer. Thank you.
Any other question? So we can conclude this session. We have 5 minutes break until the next session. Thank you very much.
يعطيكم العافية. Let's start the next session. I think because the all moderator and the speaker are here. So the next session is the pediatric and sarcoma. Can I have the speakers from the previous session? Dr. Saad, Dr. Shakir, Dr. Reem Al-Imran for the picture. Dr. Zaid, Reem, and Hussein. يعطيكم العافية. يعطيكم العافية. يعطيك العافية يا أبوي. So the next session is the pediatric and sarcoma. I will invite Dr. Rolina Al-Wasiya. She is a professor and consultant radiation oncology at King Abdulaziz University. Dr. Ali Babed, consultant radiation oncology at King Faisal Specialist Hospital in Jeddah. Dr. Ghufran Jawi. She is a consultant radiation oncology at National Guard Hospital in Jeddah. The mic is yours.
كيف اموركم؟ والله الحمد لله قصرت معاكي. والله الحمد لله. عكست ولا قصة؟
Bismillahir Rahmanir Rahim. Thank you. for the nice sessions today. Pediatric is always one of the most challenging in radiation oncology field. I'm introducing Dr. Khalid Al-Rabia. He's a consultant radiation oncology at King Faisal Specialist Hospital. We'll talk about dose escalation in bone sarcoma.
Assalamu alaikum jami'an, sabah al-khair. Thank you so much for the organizing committee and the scientific committee to invite me to speak about this interesting topic. So I'll speak about dose escalation in bone sarcomas. This is the outline of the presentation. So primary bone cancers account for less than 0.2% of all cancers. Primary malignant bone tumors comprise 5% of childhood cancers. Osteosarcoma is the most common subtype, accounting for almost 35%. This is followed by chondrosarcoma, 25%, and Ewing sarcoma, about 16%. This is the incidence of bone sarcomas in Saudi. So it follows the same principles I mentioned in the previous slide. Ewing sarcoma is the most common that we face as radiation oncologists. You can see here the previous initial publication from James Ewing about review and classification of bone sarcomas in 1922. Most common sites are pelvis, rib, and vertebral column. So most of these Ewing sarcoma are treated with induction chemotherapy, followed by local modality, followed by maintenance therapy. And most of the time, we're not really sure about the best local control modality in this disease. They were never compared head-to-head in clinical trials. In previous studies, there have been trend about surgery being the favored option. There are all kinds of biases with that. We know that radiotherapy is associated with higher risk of local failure, with higher hazard ratio, especially for those more than 8 centimeters, and unfavorable sites like pelvis or rib. There was never a significant difference in event-free survival or overall survival or distant metastasis-free survival among patients treated with surgery, radiation, or combined modality after adjusting baseline characteristics. You can see here on the right hand of this slide, this study that involved more than 1,000 patients and compared all of those modalities. Radiation alone was always less than surgery versus surgery plus radiation. But why is that, and how can we improve these outcomes? So one of the things that was taught by previous authors is that radiotherapy was always used at a lower dose due to limitations in technologies, non-availabilities of BMAT, non-availabilities of brachytherapy, and non-availabilities of particle-based therapy. Evolution of radiotherapy technique in the past couple of decades, especially in the past decade, allowed us to give higher radiation and to address this question in a better way. So multiple cohorts were done, mostly retrospective studies that exceeded the dose recommended by international guideline groups. The usual dose would be 55.8 in 1.8 gray per fraction. They exceeded that to 60 to 70 gray and assessed the risk of local recurrence. This is one of those groups and used photon and proton in their treatment based on time of presentation for the patient. So they noticed improvement in local control with a higher dose. So doses above 64 were associated with better local control, less local failures at 5 to 10 years. And mostly those patients would face distant metastasis at the end if they fail rather than local failure. important to address local failure here because local failure usually means exenteration surgeries. These are really nasty surgeries that poses high morbidity in those patients. Now, all of that is retrospective. Is there any prospective randomized evidence? So there is this clinical trial that's published in the Red Journal by Tata Memorial Group in India. And it's one of the few trials, if not the largest one, that addressed this question. So this is a phase 3 randomized trial undertaken in a single institution from 2005 to 2015. Patients of any group were eligible, non-metastatic extracranial Ewing sarcomas, and unresectable after induction chemo. Most of those unresectable were those diseases that were encroaching over the neurovascular bundle, or those that were surrounding vessels where morbidity would be really high if resection is done. They excluded patients with chest wall Ewing sarcomas. Primary endpoint was appropriately local control. So all of their patients were staged appropriately, even from 2005. They treated patients as per protocol, COG and PSYOP, induction chemotherapy, followed by chemo-RT if they're not eligible for surgery. The radiotherapy dose was in 2 arms. One of the arms was the 55.8 that's commonly used, and we all use it. The other arm was the dose-escalated radiotherapy up to 70.2 gray in 1.8 gray per fraction. They used really good dosimetric criteria as well, good coverage in their CTVs and PTVs. They did not use very generous CTV, which seems to be the trend now in treatment of Ewing sarcomas with very good imaging and simulations. So their patients were balanced, except for the fact that there were more patients of head and neck that received dose-escalated radiotherapy, and that might be related to the reason that head and neck radoncs are more comfortable with those high doses. More patients in the dose-escalated arm had large tumors volume. And this reached its primary endpoint, and it improved local control, 76% compared to about 50% in standard radiotherapy arm. There was no overall survival change, nor there was any change in disease-free survival that was really significant. Grade 2 plus toxicity wasn't really that high between the 2 arms. Their main disease failure was distantly rather than locally with dose escalation. And as you can see, with regards to hazard ratio, those with arm site extremity benefited the most with this approach. So I'd like to bring a case that I treated 1 year ago in my clinic with Ewing sarcoma and use the principle of dose escalation. I want to show you what ended up with this patient. So Mr. M, who is a 42-year-old previously healthy male who in mid of 2023 developed severe right-sided sciatica-like pain with numbness and weakness over 3 months. No response to analgesics. MRI at private hospital showed this large mass in the sacrum going into the lumbosacral plexus. So for sure, not a surgical candidate. And this extended to the right pelvic muscles as well. So the patient underwent the usual Ewing sarcoma protocol with VDCIE with good partial response and slight improvement in symptoms. However, there was large residual disease. He came to our clinic and then was considered for dose-escalated radiotherapy up to a dose of 64.8 in 36 fractions. We kept the lumbosacral plexus and coda equina Dmax to be less than 66 gray. And those were contoured using MRI, special MRI series. He tolerated the treatment very well. No grade 3 or 4 toxicity. All of his grade 1 to 2 toxicities resolved. And at 1 year follow-up about 2 weeks ago, no evidence of disease and no lumbosacral plexopathy. Going into the next common bone sarcoma site, osteosarcoma, second most frequent primary bone cancer, comprises 4% of solid cancers in children and 3% in teenagers and young adults. Treatment includes chemotherapy and surgery. The role of radiotherapy is not as commonly used as with Ewing sarcoma, but used in unresectable cancers, as well as positive margins post-resection and palliation. Just general principles about dose escalation and doses in osteosarcoma. You would need doses of up to 70 gray conventional fractionation and to reach a good dose for unresectable disease. Positive margin is not the topic of this talk. In palliation, dose escalation can be utilized and used with use of stereotactic ablative radiotherapy, especially that they metastasize to lung and other sites, commonly in more than 20 to 30% of those patients. Using doses of 50 gray in 5 to 60 in 8 is really necessary when they metastasize. So in osteosarcoma, the external beam radiotherapy role is not as well established as the others, but are there innovative techniques or things that we can do where we can increase the therapeutic ratio for those patients without increasing side effects and without delaying their important chemotherapy and systemic therapies? So this group used intravenous radium-223, an alpha particle emitter with very high RBE of about 20. That's like 20 times higher than your usual external beam. They gave patients 6 cycles of this radioisotope and then assessed response. And they show really good principles and good outcomes. It's phase 1 still. But yet you can see this response with this patient with 1 cycle of radium-223. So this group with Erin Murphy and others used this principle, but combined it with external beam radiotherapy, especially using SBRT, for example. As in this patient, for example, 6 cycles of radium-223, the alpha particle emitter, were used. Good response. This was followed by SBRT with about 50 grays in 5 fractions to the lung lesion and 35 grays in 5 fractions to the pelvic lesions. And you can see the good response in this patient, as well as with this patient with this really nasty looking sacral mass. Same principle used, 35 grays in 5 fractions, and radium-223 6 cycles. So that might give us hope in the future for better local control for those patients with lower side effect profile rather than external beam alone. Going into an interesting other topic with the bone sarcomas chapter, chordoma develops from persistent notochordal elements, originates mostly from the sacrum, 50%, followed by skull base and mobile spine. Chordomas, unfortunately, there are no prospective randomized trials. It's not a very common disease, but there's this really nice analysis of National Cancer Database of more than 700 to 800 patients that showed, so when I was reading that, I was hoping for a good result with local control, but I was pleasantly surprised when I saw this chart that dose escalation not only improved disease-free survival and local control, but also overall survival. You can see here doses higher than 70 gray or 70 gray improved survival compared to those less than 70 gray. Also use of techniques like proton therapy trended in improvement overall survival. Now that has all kind of biases for sure, but that's one of the best data that we have until we have a more randomized clinical evidence. Again, another case, one of the patients that was treated in our clinic with sacral chordoma, really massive sarcoma. This is the MRI of the patient. She's a 50-year-old female, 1-year history of back pain radiating to the leg, misdiagnosed as spondylolysis. MRI showed sacral mass, biopsy confirmed chordoma. This patient was unfortunately did CT scan 1 year before her presentation, and the chordoma was really missed. It was 3 to 4 centimeter, where here you can see it's like 15 to 16 centimeters. She presented with severe pain, left leg symptoms, reduced mobility, ECOG-3 due to her nerve compression, not surgical candidate. When she came to our clinic, we counseled her about high dose radiotherapy and its importance in delivering good local control. She underwent curative intent radiotherapy with 2-phase treatment, 50 gray in 25 fractions to a large volumes. Those need really good coverage of gluteus muscles, sacroiliac joints, and sometimes a level above and level below. And then a boost, second phase with 20 gray and 10 fractions to her gross disease. The initial plan was actually for 78 grays total, and that's what we were planned for. But at 70 gray, her toxicity, especially grade 2, she was reaching grade 3, and she was really bothered by that. So she opted to stop treatment. 6 months follow-up, disease size decreased by 40%. Her motor function improved, and she's almost pain-free. So there are multiple techniques in dose escalation. One of them is, the most common is the external beam radiotherapy. It has its own limitations. We can escalate by using particle therapy like proton, decreasing the side effect profile. Radioisotopes is a good example that we saw in previous slide. Using IORT, intraoperative radiotherapy, is a good way in dose escalation. We do have a busy program in our center. However, using this technique has to make the radiation oncologist really involved with the primary surgical team, making sure that dose escalation does not happen to organ at risk rather than the disease itself. Grade 3 to 4 toxicities are really easy with IORT if it's not done the right way. Interstitial brachytherapy for sarcomas is a good way also of doing that. Using spatially fractionated radiotherapy like lattice or grid is another way.
Khalid, time is up.
Yeah, that's my last slide. So sarcomas like hypofractionation and respond to it. This is a really good figure from Eric Hall radiobiology that I like to refer to once trying to figure out those fractionations and AQD2 calculations. Thank you so much.
I'll introduce the next speaker. It gives me a pleasure to introduce Dr. Abdulaziz Al-Ghamdi. He's a pediatric radiation oncologist at King Faisal Specialist Hospital, Riyadh.
Assalamu alaikum. Thank you for inviting me to speak on proton therapy for children. This is a near and dear topic to my heart. So I was tasked with making a presentation about setting up a pediatric proton therapy program. There is only one pediatric proton therapy program, which is in St. Jude. So I had to look up multiple institutions and look at the key considerations that they looked into when they built their programs for pediatrics. So this is the outline of my talk. So why do we need pediatric proton therapy? The most common or the best reason to consider proton therapy is for pediatrics. Proton therapy has very favorable dosimetry. Can you see, as you can see on the left corner of the slide, we have the MRT, the 3D conformal distribution, and you see we still have low dose spillage with any photon techniques. And this is merely the physics of it. The real things are that we need to reduce the risk of growth and developmental issues, neurocognitive impairment, secondary malignancies, and other long-term side effects. And ultimately, our goal is improving cure and quality for life. So to set up a pediatric proton center, there are 4 core pillars which you can build a center on. The first one is the most important and the prohibitive pillar, where you look at the technology and the infrastructure. So if you think about a proton center, you have the requirements. You have the proton system, you have a gantry, and you have advanced technique where you can deliver intensity modulated proton treatment. Second is you can mount imaging on these proton machines. You have on the left, this is actually a snapshot from a commercial video from IBA, and you can see you can use cone beam CT. On the right, there is now a movement in the proton therapy with manufacturer. They're looking at MRI guided proton therapy, which is further precision. This is still in research, but it's coming down the pipeline. The third thing, when you talk about the building a proton facility for pediatric, is actually design. So the picture on the left is the proton gantry at St. Jude. And the one on the right is from the Children's Hospital in Cincinnati. And you can see for pediatrics, you have to have very spacious rooms because you have to anesthetize these patients. You have to have a large team inside the gantry. And this is where a lot of the proton centers, if you say decided to get a compact proton in a very small room, you won't be able to fit the whole team for pediatrics. So if you're going for a pediatric proton center, you have to put these things in consideration. The second pillar is the specialized pediatric team, which is, I find, something very interesting. We have a huge pediatric service in Saudi Arabia, but maybe half of this team is not present. So if one plans on building a pediatric proton team, this is how these are the stakeholders and the people that you need to involve. You have to have a pediatric oncologist, social worker, psychologist, dietitian, pediatric anesthesia, pediatric oncology nurse, and also child life specialists. So these are special trained, they're usually psychology major or social work, or they come from any background, and they do 2 years training. And their main goal is they will be with the child throughout their treatment. So they'll explain the treatment, they'll help them understand the prognosis. And I find this is something missing. Thankfully, there is now an initiative by Mr. Thnayan. He actually funded the first program for child life specialists. And I think the first batch of graduates just graduated last year. So if you guys want to look it up, it's affiliated with the Faisal University. The third pillar is you have to put your center with child and family centered environment. This is really important. So these are 2 pictures from King Hussein Center in Amman, but it's an animation rendering, which is very nice. So it has to be child-friendly aesthetics. You have to use distraction techniques. When I was at the University of Florida, they had a whole playroom with like all these things. You have these kids coming for treatments. It takes away some of their anxiety if they can be distracted until they get their treatment. Supporting services, as I alluded before, child life specialists, psychology support, accommodation. There is also school liaison. So essentially, this is what happens to me. I have to write letters for patients just to tell their school that this child is going through radiotherapy treatment. This is not my job, right? You have to have a school liaison, someone that coordinates with the schools. He tells them what kind of treatment, if they needed any special accommodation at school. The fourth pillar is research and collaboration. And I think this is the biggest thing. If you plan on opening a proton facility, you have to be part of a group. So there is you can be part of PSYOP, you can be part of COG, you can be part of the Pediatric Proton Photon Consortium Registry. The reason why you need to be part of these groups is you have to be accountable, you have to publish your data, and you have to learn from the best practices. The best way you learn about anything, if you're enrolled in a clinical trial, you will get people who are, you'll get auditors, you'll get people who will teach you how to do things. So it's very essential. If you commit and went through with doing a proton center, you have to put these things into consideration. This is where I did my fellowship. It's at the University of Florida in Jacksonville. And you can see it's the three things. You have, this is the Nemours Pediatric Hospital. It's the largest hospital in Northeast Florida. It's the biggest hospital between Miami until you go up to Atlanta, which is like a very large swath of land. It's linked to the UFPTI, which is the University of Florida Proton Center. And this Proton Center, albeit it's part of the UF group, it's actually, there is a private ownership, and it's affiliated with the University of Florida. So, and it's a COG site as well. So you have to have all these three to run a very good and excellent proton program. So I have two case studies. The first one is the University of Florida. You can see that you have a large experienced pediatric program. You need to have a comprehensive team, peds, radons, child life specialists, social workers. You have to be part of, as I said, collaborative research groups, either COGs, SIAB, or even your own institutional clinical trials. You need to have academic affiliation. The second case study is St. Jude Children's Research Hospital. St. Jude is a special case. If you see down on the right corner, this is a picture of Danny Thomas. He is a famous American comedian. He's of Lebanese heritage. He's the guy who established St. Jude. St. Jude is actually a foundation. So they don't take any money from the government. It was built from the get-go to be financially independent. And it's the only comprehensive pediatric cancer program in the world. They have their own proton facility. They commissioned their proton, I think, in 2016. And it's designed for pediatric patients. So St. Jude is the world's first pediatric-only proton center. They have their own research funding. If you see the governance of the research, there is like these steering committees, and it's very well organized institution. They actually run their own trials. If you look at most of the pediatric radiotherapy trials, which answers radiation questions, most of them come from St. Jude because they have this amazing structure. So key steps to establish a new center. So first step is you have to have a strategic vision. You have to have partnership. You need to do a needs assessment. You have to align with a children's hospital, like the case of University of Florida or St. Jude. You have to get a significant capital, right? This is Uncle Scrooge from Donald Duck. He has a lot of money. So you need a lot of money if you want to open up a pediatric programs. You have to carefully plan your facility with the things that we said at the beginning. You have to understand if it's for pediatric patients. You have to have spacious gantry rooms and whatnot. You have to recruit specialized expertise, right? You have to, this is one of the biggest problems with running very advanced radiation programs is you can't just hire anyone. You have to hire people who actually did proper training in radiation oncology, proper training in proton physics, or had a clinical training. You have to invest in building your own local expertise. So if someone wants to go ahead and go for this, they have to go with a care model where the child is the center of this service. This is a very nice care model. I think it was produced by the Sick Kids Hospital at Toronto. And it's a child-centric care. This is really important. This is really key. Research integration, as I alluded previously, you have to be part of an international group. You cannot run a very complex, intense service like proton therapy for pediatrics if you are not part of an international group. So navigating challenges, I think the biggest challenge is the high cost capital and operational cost. This is a very prohibitive cost unfortunately, for proton therapy, albeit this is something that we should, as a community, advocate for our patients. Our colleagues from hematology, they got CAR T cell programs where you pay 3 million riyals for one patient. It's a fourth line treatment, and they still advocated for a patient and got it. Khasusi, I think, spent 200 million riyals on CAR T cell. I think that's a very cheap cost for getting a proton. And I think this is how us as a community should proceed, is we should think about our patients and do what's right for them. The limited access referral pathway buildings, I think this is very challenging. You have to be integral to a large health system. I think if, say, Al-Haras got a proton facility or Al-Takhassusi got a proton facility or whatever, I think it will be limiting because it will be part of just one health system. I think if you guys would like to proceed with building a proton center here in Jeddah, you should consider building it as Jeddah Proton Institute, right, where it's integrated with other hospitals in the area. There is also technical complexity, RBE, motion management, a staffing shortage of specialized professionals. I think the number of Saudi medical physicists is, we have a good number, but we don't have enough of them doing PhDs or doing clinical training in the US residency where they do proton training. I think that's something key. If you guys are planning and going ahead with this in Jeddah, you have to consider, building the capacity while you're building the facility. Don't build the facility and wait for people to come. Future trends and advancements. This is what's coming down the pipeline. There is the proton arc therapy that's coming down the line. It's similar to VMAT, but for proton. It's a very nice, neat technique. You can reduce the dose swaths to very low doses. The one on the left is what we do now. It's IMPT, which is intensity modulated proton treatment. There is also flash therapy with proton. This is a big thing that's happening now in radiation oncology. People are doing cutting edge research with flash proton therapy. And also you need to be driven by data and late side effects. So pediatric proton therapy, it's a vital specialized service. We need this. I think Jeddah should be the site where you build the second proton facility. About 60% of Saudis live on the West Coast. You have referral from as far north as Jordan towards Yemen borders. It's a very huge, heavily populated. Most of my patients that come to Riyadh for treatment, they come from the Western province, and I think Jeddah should get its proton facility, and it should be done with pediatrics in mind. It requires a holistic approach, technology, team support, research. Collaboration is key. I cannot overstate this. We need to be part of COG, SIAB, the Proton Photon Consortium, and whatnot. It's a long-term commitment to quality and innovation. Jeddah has 3 universities. You're close by to KAUST, which is a leading university in research and science. And I think you guys should approach them if you ultimately decide on pursuing proton therapy here. Thanks so much.
Thank you very much, Dr. Abdulaziz. Next is our dear Professor Yasser Khafaja. He's the most senior pediatric radiation oncologist in the Kingdom of Saudi Arabia. Actually, I trained under him when I was still a resident, and he's going to talk about hypofractionation in soft tissue sarcoma. Fadal, Dr. Yasser.
Thank you for the introduction, Dr. Ali. Thank you for having me here. Especially thanks to my friend and colleague, Dr. Dahim, for inviting me. So I have no disclosure. These are the outline of my presentation. I read the available data on the outcome of SBRT in pediatric and area patients with sarcoma, safety toxicity data. So while SBRT has been well established in the adults, yet its potential application in pediatric and young adults and adolescents is a growing area of clinical research and interest. And the role of SBRT in pediatrics might become very relevant because of the relatively radio-resistant tumors dose escalation is needed in some of these tumor subtypes. But the major concern is about the normal tissue toxicity and late effects. So local control rates with SBRT exceed 90%. Survival rates are comparable to surgical series. In the adult series, actually, the toxicity reportedly recently to be minimal. The convenience also of hypofractionation in the pediatric age group will be also for the logistic, reduced treatment sessions, the requirements for daily GA. So it's a very attractive, actually, in terms of also of compliance for the peds and the familial disruption for the duration of treatment that extends over several weeks of daily radiation treatment. Also, it will be potential for treatment of recurrence and re-irradiation. But the fact that in our classic teaching in radiobiology, actually, as we go with hypofractionation, we expect the late toxicity would be much more relevant, especially in growing kids. And this is the main area of concern, that we, by using a large or a big fractional dose, we might anticipate much higher late toxicity. There is evidence, actually, that the local therapy to these metastatic sites help in terms of progression-free survival, overall survival in pediatric series. Whole lung radiation, for instance, for metastatic disease, whether in Ewing or rhabdomyosarcoma, there is a difference in terms of progression-free survival, overall survival in favor of whole lung irradiation. Also, for those who have residual gross metastatic disease, there is an incremental increase in terms of survival by using metastasectomy or local treatment to the metastatic areas. The same applies for rhabdomyosarcoma, and you can see here, again, those who received whole lung radiation versus no radiation, there is a significant and tremendous difference in terms of progression-free survival and overall survival. And this is the survival to the right in the colored graphs here that shows in terms of the number of risk factors, the less risk factors in terms of favorable histology or unfavorable histology, and the number of metastatic disease does count. This is one of the series 35 patients with stage 4 rhabdomyosarcoma, Texas Children's Hospital. 16 out of these patients received treatment to all metastatic sites, and you can see here the difference in terms of survival, 37% to those who received radiation to all metastatic sites. So both overall survival, progression survival were better in patients receiving local treatment to all metastatic sites. By the way, in the COG last month, that will be published very soon, they actually, they de-escalated the doses to the primary from 59.4 now back to 50.4 and 54 for gross disease, because they couldn't find any improvement in survival in terms of dose escalation for the primary. And what does count essentially and reflect on survival is this strengthen the intensity of the systemic therapy and the way you tackle the metastatic disease. So these are a few of the pediatric studies in SBRT, very few and a small number of patients. This is one of them, St. Jude, 55 patients with 107 lesions treated with SBRT. And you can see here in the graphs below that the progression-free survival or the local control mainly was in favor of the treatment of the bony sites rather than the soft tissue sites. And they concluded the toxicity were quite reasonable and acceptable, no grade 3, and most of them are grade 2 toxicity. And they concluded that SBRT is well tolerated and effective for local control in metastatic disease. This is another multi-institutional protocol, phase 2 study, expanding, the age less than 40 for non-rhabdomyosarcoma and bone tumors. Multicentric, Johns Hopkins, and Jude, Mayo, Stanford. And again, they assessing the efficacy of SBRT using 40 gray in 5 fractions with a BED almost equivalent to 72 gray. And you can look at the local control here at 6 months, 96%. This is a very important graph as well because it shows that those who receive a comprehensive treatment to all metastatic sites did much better than those who received partial SBRT, and of course better than those who didn't receive any in the literature. This is another study that shows actually the importance of the BED being above 60 gray results in better local control. And here in the middle, you can see that those with sarcoma versus non-sarcoma, so the impact is much better for the sarcoma counterpart. And this is again shows the local control spinal versus non-spinal lesions in favor of the non-spinal lesion. These are other studies, actually, osteosarcoma and metastatic Ewing sarcoma. These are the different dose fractionation used in different series. Also, the SBRT, I mean, will or stereotactic radiation might have a room actually in brain mets and as well as radioresistant tumors. Dr. Rabia alluded to this, and combining actually radioactive colloids and samarium, for instance, with the SBRT. And definitely it will have its place in re-irradiation. This is one of the series treating recurrent metastatic sarcoma in peds. Median dose to the lung regions were 50 gray in 5 fractions. And the toxicity only grade 3 intestinal obstruction, a re-irradiated field, no acute grade 3 or more toxicity. Now, this is the actually Saber systemic review and meta-analysis of different published studies, 9 published studies, 142 pediatrics and IA patients, 217 lesions treated with SBRT. And you can see here from the forest plot that there is a very good local control at 1 year, 83%, 72% at 2 years. And if you look at the 1 year overall survival and progression-free survival, there is a definite improvement with SBRT, and the toxicity is quite reasonable. Notably, most of these toxicities are grade 3 or less. Interestingly, when they looked in regression analysis and subgroup analysis for the sarcoma predominant cohorts in the series, they found that there is a strong correlation between the BED10 and the radiobiological effective dose and the local control, with an average actually 5% increase in local control per incremental increase 10 gray. So COG and the other and the PSYOP groups actually put now radiation guidelines for standard treatment for the primary and the metastatic sites. And this briefly, the SBRT eligibility mainly for bone mets less than 5 centimeter. The site has to be credentialed for SBRT. The doses are variable, but the recommended dose, at least by COG now, 40 gray in 5 fractions, and they keep measure of the toxicity by the CTCAE. And of course, all these centers has to be credentialed for the SBRT. These are again the COGD guidelines. You find it and you can access it easily. And these are the dose constraints with SBRT. They're working now as well to tabulate all the metastatic sites, whether treated or not, so to get pooled data and relevant information later on. And these are the guidelines for the stereotactic body radiation to metastatic bone sites. It's important here and to mention that SBRT is not used for the primary site. Unlike we yesterday in the ASTRO presentation, there is now a trend to hypofractionation for soft tissue sarcoma in adults. That's completely prohibited so far in the pediatric age group. And this is the PSYOP as well, a recommendation that we should maintain the standard treatment for the primary and avoid any hypofractionation for the primary unless in a very poor prognosis patients where systemic therapy is essential and you want just to give radiation to enhance the local control. Now, in order to, because of the many controversies in hypofractionation in peds, the National Pediatric Cancer Foundation actually they invited the panel of experts for the hospital affiliated to the foundation, and these panel key questions were addressed: what the best approach to treat metastatic sites, SBRT, is it the best modality, and the safety and the timing of metastatic site radiation and the optimum radiation dose. And the panel recommendation came up with comprehensive radiation therapy in patients with less than 8 metastatic sites, SBRT, the best approach for metastatic sites less than 5 cm, timing at the end of systemic therapy, usually at week 40, unless there is a dosimetric advantage of coupling the treatment primary with the metastatic because of the close proximity or better compliance. Multi-site SBRT is well tolerated, and we should maximize the number of sites to be treated to improve the PFS and overall survival. And this is the algorithm actually of treatment for the metastatic sites. As you can see, for less than 8 metastatic sites versus more than 8, and whether there is bone marrow involvement or not, that will affect your decision making for the treatment. And these are the different fractionation from the adult, safe doses, accepted dose. But because peds are not young adults, when you actually apply these doses to pediatric, you may get some unexpected toxicity, like this case, for instance, 30 grain infraction for metastatic progression, and because of the persistent disease, retreated with 27 gray in 3 fractions, which is quite safe for an adult. 3 months later, post SBRT, he developed severe right shoulder weakness and found to have grade 3 myositis. And by the way, this is the most common encounter toxicity in the ped age group, maybe related to recall phenomenon, interaction with the chemo. This is from Cleveland Clinic, and you can see again grade 2 toxicities, dermatitis, pneumonitis. By the way, in the Ewing sarcoma study 1-21, the monoclonal antibodies IGF ganitumab was prematurely stopped because of the excessive events of radiation pneumonitis when coupled with the ganitumab. This is another re-radiation with the SBRT, 45 grain, 25 fractions to the, this is the initial course using IMRT to the spine, and then re-radiation with SBRT, 18 gray single fractions, and then he developed later on small bowel obstruction that was pathology-proven radiation enteritis. One patient developed grade 2 sacral pain, one patient developed grade 3 toxicity. Conclusions: local ablative therapy of limited size of metastatic disease have shown event-free survival and overall survival advantage, and adequate local control is necessary treating the metastatic sites, and we need long-term follow-up actually to have a good understanding of the potential acute and late toxicity. Thank you very much.
Thank you very much, Prof. Yasser Khafaja. I would like to welcome the speakers up the stage so we can get some questions answered. إحنا نبدأ. We have a question, Dr. Abdulaziz.
Assalamu alaikum. Thank you all for this great presentation. My question, Dr. Khafaja, as the pro-gamma knife user, a lot of data from Europe, they start with the benign tumors for the kids for gamma knife, and they now start moving even for low-grade gliomas and some metastatic. So what's your opinion about this and using gamma knife for kids? I understand this COG is not really addressing the gamma knife for kids, but I found this discrimination between European side and North American. European more and more pro to go for kids. Now in Czech Republic, they have the youngest age treated in gamma knife was like 4 years old.
Yes, Dr. Hamad. You mean gamma knife for mainly brain?
For brain.
Yes.
Gliomas and also metastasis.
Okay, I'll leave this for the CNS because Dr. Abdulaziz is covering the CNS. But the COG and the SAUB, they're moving in terms of relevant to my topic to metastatic disease. Yes, they're moving now. Now it's credentialed for stereotactic radiation to boost the metastatic lesions. For the benign.
Thank you for question, Dr. Aziz. For CNS, for gliomas, it's not still a standard of care. However, there is good phase 3 clinical data coming from Tata Memorial Hospital, where they did conventional versus gamma knife for craniopharyngioma. And it can be done safely, and they actually proved that the neurocognitive outcomes were superior in the patients that were treated with gamma knife. As for gliomas, it's not established. However, for metastatic site, I use CK for pediatrics. Actually.
I have a question here, Dr. Abdulaziz. Just a comment and a question to everyone. You mentioned an example of the cost of CAR T cells as a fourth line, which costs 2 million or something, and how this has been accepted by hospitals and industry and the payers. And you compare it because of the cost of the proton. How can we address the importance of radiotherapy? Is it cheap? It's effective? How can we go outside and say, look, we have a very effective, cost-effective drug, which is radiation, compared to a very expensive drug, which is the fourth line? Just like, how can we address this as a community?
I think that's an excellent question, Dr. Mohammed. Personally, I think the way that we should be addressing this is first as a society. We have to have a consensus. A lot of the folks here, they don't believe in proton therapy. Some of my colleagues, they don't believe in proton therapy. They think it's an expensive, fancy treatment. It shouldn't be done. I think our problem is within our own community. So we need to address this first as a community. The second thing is we have to compare ourselves, benchmark ourselves to other specialties. So for robot versus laparoscopic, which is, there is the clinical data for robot versus laparoscopic is essentially non-existent, right? It's a very expensive treatment, yet major centers in Saudi Arabia are investing in building multiple robots, right? So what I'm thinking, and I think this is the first thing, precision has a price. If you want to be the second thing is we have to adjust the cost per fraction. So the cost of the fraction of proton is still cheaper than the cheapest targeted treatment, right? And I think this is really essential. We shouldn't be comparing proton with photon, we should be comparing a precise treatment with a more precise treatment. This is where a lot of people fail to make that distinction. And this is what is killing proton in our part of the world. So I think you're right. I think this needs to be addressed by our own society as a radiation oncologist. Thank you.
Thank you, Dr. Abdulaziz, for this answer. Let me ask the audience, how many of you is pro proton therapy? Huh? Pro or against? Who's pro? Raise your hand. Okay, well, that's a huge difference, huh? That's a huge difference, because I remember 5 years ago, we had a lot of criticism against proton therapy, but that's good. We have some change there. Now,
Good morning, Dr. Adub Hamadi from Bahrain Oncology Center. First, I would like to thank all the speakers for their valuable presentations. My question to Dr. Al-Ghamdi regarding proton therapy. We all know the impact of proton therapy in regards to local control and reduced toxicity to surrounding structures in a growing child. However, in a setting that you don't have a proton facility, but you do have advanced techniques of image-guided radiotherapy, In which cases would you consider sending patients overseas? Would you consider it like when you compare between standard risk medulloblastoma versus high risk, given the overall survival, or even like intracranial optic gliomas? I would like to know your opinion on that.
Shukran, Dr. Thank you for your question. Personally, I have, so referral, the process for referral takes a lot of time. So I usually only refer patients where if it's a low grade type of disease, I know I have time until I finish, complete their paperwork to send. I haven't sent anyone who had medulloblastoma. It's a very bad, nasty disease. I can't wait. I don't send patients with some of the sarcoma patients. If it's around due time for their local control, I don't send them. If I know before, I had one case who had a intermediate risk RMS. It was retroorbital, so it was in a critical location. That one I knew before, the pediatric oncologist was kind enough to tell me that she's coming my way maybe 6 weeks before. So I managed to arrange for her to go abroad. So it's case by case, but my general rule, if it can wait, I would send. The only people that I would fight to send them is and it's say anaplastic ependymoma. I try and send them, and what I do is I would tell the parents to reach out to the royal court themselves, because it's a faster process to get them abroad than initiating the paperwork for the تخصصي. So if it gets to the royal court, it's within, alhamdulillah, within 10 days, they get approved. So these are the only patients who have a high grade lesion that I send, are usually if they're a year and a half anaplastic ependymoma, I would send them abroad. It's savagery to give them radiation at this age with photon, to be honest.
May I add here, I agree with Dr. Abdulaziz. I mean, it's a balance here. When you have, again, medulloblastoma or high-grade ependymoma, you cannot just afford, the luxury to get a proton therapy, even if there is a dosimetric advantages, because waiting here is morbid to the patient. However, if as Dr. Abadi mentioned, low-grade things, they can wait and you can improve the neurocognitive and the lead toxicity. So again, it's great to have proton in Saudi Arabia. But again, before sending abroad, you have to think twice before sending. First of all, family segregation, visa issues, waiting time. I remember in the early years when we didn't have this IMRT and CK, and we have sent quite a few patients, maybe over the span of 30 years, we send skull-based tumors, chordoma, chondrosarcoma. And again, the results were not very encouraging. What they benefited there actually from having a skull-based surgery prior to proton therapy. And then they received radiation therapy. Proton was a small component as an add-on boost because of at the time, the labor intense thing of planning the whole treatment through proton. And we had, out of 6 patients, we have 2 who survived actually. 4 of them fairly rapidly deteriorated even after proton therapy. So I do believe that having proton here, that will be definitely a plus for all the pediatric age group population in the kingdom. But again, sending abroad, you have to be very wise in making a decision to send a child abroad to get a proton therapy. Thank you.
So again, for disclosure, I do not treat pediatrics and I do not envy you for your job. So thank you for what you do. Saying this, I think proton is a very controversial topic. And I do agree with Dr. Yasser. It's very hard to kind of say if you support or not support proton because every patient is different. Every situation is different. In Chicago, we have one facility. We will have another one soon in Peoria, which is like a couple of hours away, and a third one in Wisconsin. So it is increasing. It's like we're going to have more. But right now, we have long waits, at least 6 weeks before they start in Chicago. And my concern, at least in the Chicago facility, and I do not know what is your vision if you are to get one here in Jeddah, is the image guidance part of it. I think a huge limitation with the current setup of proton is IGRT. And it really concerns me coming from MR neck and how we can advance and see exactly what we're doing before turning on the beam. What are your thoughts about the limitation of IGRT and proton, and if there is any update now that it's better than what we have in Chicago?
So for the IGRT component, I think vendors, IBA, I think they've developed a very nice cone beam now in their machines. I think they're the biggest now, the biggest vendor for proton treatments. I did my fellowship at the University of Florida, Jacksonville, with Danny Delcato. He's a leader in proton therapy for pediatrics. So they rolled out their proton therapy program since 2006, and they incrementally improved their program. You're right. I think we have a problem with imaging. What University of Florida did, which is very smart, is they bought an old used open MRI machine. It's like a 0.23 Tesla, and they would use it especially for patients with craniopharyngiomas to like do the weekly imaging to ensure that the cyst is not growing. This is one of the things that they did. There is down the pipeline, there is talks about MRI guided proton therapy. It's the same concept as MR Linac, where you have a split magnet. That could be done. I understand that the imaging is an issue. And the other issue, Dr. Rafat, is in the US, as you're aware, you're practicing there, it's state dependent, right? In Florida, proton is compensated at a higher tier, right? Whereas in Oregon, it's not. There is no proton therapy facility in Oregon. California, still IMRT and proton are the same. All the proton facility in California, most of the patients that come, they'll pay out of pocket because California has the most billionaires in the world. They don't mind paying out of pocket. So I think that's where a lot of people saying, well, you don't see these proton facilities everywhere in the US. Well, the US, they have statutory laws. It's according to the state. But I think the biggest thing for us here in Saudi Arabia, I do see a large volume of diseases where proton is advantageous. There is a child I'm treating. Her disease, she has an RMS that's stuck on her heart, right? I have to treat to 41.4. I can't do that with the best technique. I can't. Her heart will see 30 Gray's mean, right? This was a patient that I would have referred abroad. She has a high-risk metastatic disease. I can't afford to send her abroad. I have to treat her, knowing that there is a huge cost to my treatment, which is something I struggle with on daily basis in doing pediatric radiation. Thank you.
I want to add here as well, very important, very relevant as well. When you refer a patient for a proton, which center you refer to? Because standalone facilities, proton for pediatric doesn't work. This is really money generating, and they don't have the expertise. It's not within the platform of expert pediatric oncologists and radiation oncology. It's a technique they applied, implemented, and I've seen kids treated there in a very bad way with proton. So again, when you do a referral, make sure that this is a appropriate center within the setting of pediatric oncology team and pediatric radiation oncology rather than a standalone proton facility.
Thank you very much, Prof. Yasser. I think we're done with time. We're going to have 10 minutes break and then we're going to come back, inshallah. Thank you very much.
عادي ولا راحة ولا شيء؟ عادي أي حاجة. خلاص يعني ما تقدر. هلا والله. في أحد كمان.
It's okay. Now I see it here. No. لا بالعكس I needed a full view لأنه في videos and with the full view presenter view هو اللي بيمشي.
Assalamu alaikum. We're done with break and we're going to start the satellite symposium now. Attention. Okay, so we'll move on to the satellite symposium. I'm presenting our lovely speaker, Dr. Noor Yuri, who's a medical affairs lead at the Middle East and Africa region for Varian. And today she will talk on hypersight imaging technology. Dr. Yuri, the floor is yours.
Thank you. So thank you, everyone. I'm really glad to be here. Thank you for the invitation. So hypersight is an imaging solution. As a radiation oncologist specialist, we know the importance of seeing what we treat, especially when you had already a first plan for the treatment and you do a CBCT, you have to be sure that you are exactly treating the tumor and sparing the organ at risk. And I remember in September, I was in Durban, and I was at the launch of a Halcyon with hypersight capabilities event, and I was presenting. And then the doctor came and he said, "Do you know what we cannot live without anymore?" And I said, no. He said, "The phone. We all are connected to our phones. We cannot live without our phones. But what changed each version and made us buying these phones is, of course, the quality of the camera and the images. So it's not only in the phones, it's even more important in our field of radiotherapy." So these are my disclosures. So these are the kind of things that we use to see in normal CBCTs and that are interfering with the treatment. So even with the advance of technologies of treatment, we see artifacts related to the motion of the patient, artifacts due to the breathing of the patient, and sometimes we need to ask for breath hold, which cannot be done with all the patient and can be a discomfort. We have metal implants that are a source of artifacts. As you can see, this is a very bad image of artifacts due to the metal implants. Imagine you have to treat here, you cannot see the anatomy well, you want to treat one vertebra, how you will do that. And then in our region, we know that sometimes we have larger patients, so there is anatomy cutoff. So with that in mind, Varian developed hypersight imaging solution, and it's a KV panel that was developed from scratch for radiotherapy purposes. It's the largest CBCT imaging panel in the industry. And if I take off the labels here, you cannot tell which one is the CT SIM, which one is the diagnosis CT, and which one is the CBCT with hypersight. So if I ask you and tell you which one is the CBCT with hypersight, which one do you think it is? This one? This one is the diagnostic CT. And then you have the simulation CT with injection, and then you have the hypersight with CBCT. And you can clearly see that with the hypersight, we have a better quality of imaging, almost like the CT SIM and the diagnostic CT, where you can see clearly the lymph nodes and the difference with the muscle. So what changed with hypersight? Hypersight is developed on all our platforms. So by this, we mean the C-arm platforms and also the ring platforms. So we have at least 50% faster imaging, which means less time on the couch for the patient and better comfort. We have high soft tissue contrast, which is very important for region like the upper abdomen. Accurate Hounsfield units value, I will come back to that. Larger field of view, so nothing can be missed. And even with that, they managed to keep a constant and even reduced imaging dose. And we added to that metal artifact reduction. So with hypersight, we are reinventing the CBCT with 3 pillars. First, the image quality, which is going beyond IGRT, precision. These images are images that we can plan on, and the speed. So coming to the quality of imaging, these are images where you can see clearly all the structure. This is a CBCT with metal artifact reduction. As you can see, there are fissures. So we can clearly see all the structures. So it allows us personalization of the treatment, precision, dose escalation if we want, organ sparing, efficiency, and cost reduction. Here are some cases that before we cannot use with a normal CBCT, like oligometastasis in this region of the abdomen is very tough to treat. So you can see on the simulation CT, that's what was contoured. And first day of treatment, they took the patient, they put it on an MR linac, and they saw a shift of 10 centimeters. Then they took the patient and put it on the machine with hypersight, and they saw exactly the same shift of 10 centimeters, which means that you can treat confidently now this kind of location with the hypersight. This is again to show you in the upper abdomen, the CBCT, you can clearly define the stomach, the pancreas. And these we are very proud. It's the first hypersight in the region in Qatar. So these are images from Qatar, where we can see clearly better quality of imaging. It's a video. We don't have it. Oh, thanks. So as you can see, this is a CBCT taken on ethos with hypersight at NCCCR Qatar. So what changes? So we have two different kind of imagers. We have a larger one on Halcyon because of the ring. So it's 86 by 43 centimeters, and it's just 6-second imaging acquisition for all locations. So any patient can hold their breath for this 6 seconds. For TrueBeam, it's smaller because it's a C-arm, so 43 by 43 imager, and the time is shorter, it's 14 to 23 seconds. And that's what you see. The speed of the gantry is much faster with hypersight. So with this imager that is bigger, you don't have the need anymore to do 2 CBCTs and irradiate the patient more and spend more time on the couch for the patient. With 1 CBCT, you can have an extended field of view. As you can see here, we can see the vessels, we can see the lymph nodes. Here are some images of CBCT without metal artifact reduction and with metal artifact reduction, which can change our lives. And here is the breath, the motion, that artifacts that we get because of the breathing. So this is what the images look like with conventional CBCT. With 6-second breath hold, these are the kind of images that you can see, where you can clearly define where is the tumor in the apex and to spare the rib and avoid any breakage forward. So these are images that were acquired on Halcyon. So it's bigger, the imager is bigger. So we can see in 1 CBCT the whole anatomy of the patient. Same for the pelvis. And with metal artifact reduction, you can see the development. So you have the conventional CBCT, the hypersight with CBCT-P feature, and the hypersight with metal artifact reduction. This is a very bad case. You see that the patient has a double hip replacement. So the artifact is really huge. And with the new CBCT, at least you can see much better the anatomy. So coming to images you can plan on. So as you can see, this is with conventional CBCT. You cannot clearly see where the tumor is compared to the cage rib. And also you have a cutoff of the anatomy. With hypersight, you can clearly define where you are and you can plan on these images of CBCT. So this is a study where they compared the house-filled units between a CT SIM and the CBCT. And as you can see the profile, they are going one on the top of each other. That means that you can absolutely use your CBCT as you use your CT SIM and plan on it. And this is just to show you the distribution dose on the CBCT, and you can compare it to the CT SIM. It's quite the same distribution. So on Halcyon, we developed what we call CBCT-P which means CBCT planning workflow. It's a workflow that is there where you can use and plan on your CBCT, and there is an interactive ISO center placement. You can mark the patient and you can verify the position of the patient. So in the clinic, what does it mean? In the clinic, you see here, we had a patient that has a lung tumor, and this is on the CT sim. First day of the treatment, we see a growth in the tumor, and we used the offline adaptive workflow. So before, if you see this kind of changes, you have to resim the patient, taken down from the couch, find an appointment, put it to the CT sim, take the CT, recontour, and do all this stuff. Now, with HyperSight, you take your image of CBCT and you replan on it. So you gain time. Now, about speed, sometimes a single breath hold is all you need. This is with conventional. Again, this is with just 6 seconds. Any patient can hold their breath for 6 seconds. So if we are talking about clinical value of HyperSight, first, you have the faster imaging, which means it's easier for patients to hold their breath, improved image quality due to less motion, and the speed of the gantry between field means that we have less time on the couch. Metal artifact reduction is improving the images where we have dental work or we have implants in the hips, which is quite often in the pelvis area. And then the high soft tissue leads to easier visualization of anatomy and faster online matching, of course. House field unit, I talked about it, how you can plan and facilitate this. The large field of view, you see the whole anatomy. You don't need to do a double CBCT, and you reduce the irradiation of the patient. So what about the clinical results, the studies? So we have these imaging capabilities that were demonstrated in several studies. This was in 2024, Q3. So I took some of them. So you have from Nova Scotia Health, from Mastro, and from UPenn. So if we go one by one very quickly, Nova Scotia study, it was the first peer-reviewed scientific publication. They studied 30 individuals recruiting for imaging of tumors, included very different locations, so like liver, lung, breast, abdomen, chest wall, and pancreatic sites, which are not the easiest. And they did it with HyperSight, and their conclusion was that HyperSight system on Ethos or Halcyon provides 6-second CBCT acquisition with image artifacts that are significantly reduced compared with the TrueBeam without HyperSight. This is the Mastro result. So they compared the dose distribution calculated on CBCT images with HyperSight to those calculated on the CT images. And with the results of this study was to open possibilities for offline and online replanning due to the enhanced image quality and accurate CT numbers. This is UPenn's study. So just to let you know, HyperSight and CBCT images, they passed the American College Radiology CT accreditation. So you can really plan on this, on these images, and HyperSight fared exceptionally well with pass rates comparable to that of the CT and much higher than the conventional CBCT. What about post-Astro updates? So in Astro, we had 12 abstracts about HyperSight, 11 digital, 1 oral, including 9 sites. 8 of them were variant-funded abstracts, and there were a lot of teams. Some of them were simulation, omitted spine, SABR workflow, direct-to-unit adaptive radiation oncology for celiac plexus radiotherapy, increasing performance efficiency for adaptive, etc. So these were the main presentation at Astro about the posters and the oral scientific session. And these were some articles and coming from different universities about the motion and the metal artifact reduction. So for UPenn, it was fast CBCT holds premises to significantly improve the image quality. For Washington University, it was improved image quality by reducing the bowel gas artifacts. And for Ohio State University, it was the metal artifacts was really helping in the fiducial markers. This, we already talked about this, passing the American College accreditation for CT. Nova Scotia, we have MSKCC that were demonstrating feasibility for treatment planning. And then you have University Hospital in Cleveland, where we met clinical objective with minimal dose differences, and over 98% of the organ at risk objectives were met. So these are other clinical studies that were presented during ASTRO. So we shortened the wait time for radiotherapy with accurate Hounsfield units dose calculation on CBCT. This is coming from Mayo, and UTSW, clinically acceptable plant quality generated by the online adaptation. We also have the possibility to do intra-fraction motion management, because we can do a 6-second, we can do repeated CBCT during adaptive workflow to better assess the intra-fraction motion, which was reported by Henry Ford. So now we can think about, this was presented, it wasn't me, it was presented by an oral session at ASTRO. So deliver, like we deliver quickly the radiotherapy. This one can be on one shot, 20 gray delivered, just with the CBCT of hypersite. So we use the diagnostic image, no need to go to do a simulation CT. You put the patient on the machine, CBCT, you plan, and you deliver 20 gray. So what are the key takeaways? So the likes. This is our customers speaking here. So we have high image quality with the reduced artifact, even under patient motion, which enhances the treatment accuracy. We have fast acquisition speeds, allow real-time adaptive radiotherapy, reducing the workflow delays, and reliable dosimetric accuracy, which it make feasible for direct planning and minimizing the need to do separate simulation CTs. The dislikes, though, we have some. So the motion artifacts can still occur in free breathing images, limiting some clinical implications, especially with patients that they cannot hold their breath even for 6 seconds. We didn't find any, but it can be a limitation. And in constant metal artifact reduction performance with certain metal implants. So this is also a paper that we had 5 abstracts combining technologies for online adaptive context with combining ethos with hypersite at ASTRO. This is one of them, Washington University. They compared 139 CBCT simulation before hypersite to 67 simulation after the installation of hypersite. And you can see that hypersite has led to an increase in the percentage of prospective adaptive patients that pass through the screening. So increase the number of patients that can benefit from the potential advantages of adaptive. And even patients with particularly difficult anatomy that may have been excluded before the upgrade are now eligible with improved image quality. And before I stop, just today I received 2 more publications that came. One from Ohio, where they studied 10 abdominal patients, and they deliver 1 fraction of 25 grays with the help of the hypersite. And this is for the celiac plexus pain ablation. And the other one was Washington University for online adaptive radiotherapy pancreatic patient, where they show that with hypersite, we are minimizing gas bowel artifacts, which can make a big change in the treatment. With that, I come to an end. Thank you so much.
Thank you, Dr. Yuri, for that great talk. It's really inspiring and very promising technology. We're just going to open the floor for questions. If anyone has.
You know, the source.
Exactly. So for example, what I'm trying to say that Be Big from Germany, they have for brachytherapy, you know, and especially in low-income countries like Yemen and others, we have a center there. And when we decide to buy a brachy, we will never think about radioactive source to be changed every 4 months. That will not be happening. So we approach Be Big from Germany. I think Elected, you have I think if some deficiency in brachy you can improve in is to add this cobalt 60 that can be changed every 4 or 5 years. It will be addition to us and to you as well.
You're absolutely right. You know, I love brachy. I've been practicing a lot of brachy, and this was one of my remarks to the brachytherapy team at Varian, where I told them, because even in my clinic where I used to work, we had BIBIG because of this issue, because of the issue of the radium sources and how they can be stuck at the airport. And when they arrive to you, they already lost half of their value. And I agree, this is an issue. And what I really advise all the doctors, if you don't have a smooth process to get the iridium sources, then of course go with the cobalt brachytherapy machines, because for example, in other centers like in UAE, they don't have an issue. It's quite smooth. So they go with the iridium sources. When I asked Varian why they are not going with this cobalt brachytherapy, they said it's a problem of disposal afterwards. So that's why they don't want to go with that field.
Yeah, actually, it's not a problem because the company is actually part of the agreement to take all the sources back. But you as a Varian, did you start and working on that in future or near future or not yet?
No, not yet. I asked for that, not yet. Let's see what the future holds.
I have two small questions. One about the 4D CBCT, if it's possible with Piper side. And the other one is about the planning part. Is it a separate license or is it integrated within the Hyper side workflow?
Okay, so the 4D CT, you can do it on the TrueBeam. There's no issue. It's the same process. The only thing is that you get better image quality with the Hyper site. So your second question was about?
About the planning part.
The planning. So the planning, there is a specific algorithm, as you saw, on Halcyon. It's the CBCTP. You have to ask for it to get it so that you can plan on this CBCT images. But you can do an offline process. Offline, it's doable, of course. You have your CBCT on ARIA and you can plan on it.
It's not a question. It's just like to comment because I am from Nova Scotia and we have very good experience with the Hypersite with Ethos. We started this in Dalhousie, Halifax in January last year, and we have been like using it in adaptive radiation therapy. So we are doing the Hypersite imaging for every session, and we are like doing this more and more in the SBRT prostate, and also now moving with the other parts of the like body SBRT. So, and we are also expanding. So we have now three machines of Ethos with Hypersite, and now we are expanding also to Sydney, which is another place for in Nova Scotia. So really we are like happy with the experience of Hypersite and imaging. Thank you.
Thank you. Thank you. Really appreciate the feedback. It's great. Unfortunately, Dr. Rabia, you were not there. I put the images of Qatar. We are glad to have it in the region.
Well, we want to say that we're fortunate, or unfortunately, we were one of the early adopter of this technology.
First in the region.
I think I can share the same comment, right? The image quality, major impact on the changes that we're seeing on the image quality between the CBCT, the iCBCT and the Hypersite, in addition to the acquisition time, which is play a major role in the reduction of motion artifact, which is also another major issue that we were facing with CBCT. Those calculation accuracy of Hounsfield units, all of that we're assessing. We're very happy with what we're seeing on the Ethos, on the adaptive platform. We're gonna go further and further to assess more in the GI, GU area to make sure that really are we able to do SBRT, hypofractionation, all of that with the Hypersite as compared to yesterday, Dr. Felipe on the MRI. There's definitely it's a promising. We're getting there, and I would like to thank you guys for the collaboration bearing with us.
Thank you. We want to thank you. You were always early adopters for the new technologies.
That's a great presentation. The other big advantage for Ethos that the radiation oncologists would love to hear about, that they have the AI component for the organ at risk delineation. So for the other adaptive machines, it takes you a long time to do the contours for the organ at risk online, but now you just press the button, everything will be fast. So that's a big impact technically.
Yes, absolutely.
Yeah, it was very gentle. Yeah, definitely.
Okay, I think we'll conclude our satellite session. Thank you again, Dr. Yuri. And we'll move to the next.
Assalamu alaikum. Now we'll move to my personally favorite session, the gynae session. It is my pleasure to introduce or to welcome our moderators for this session. Dr. Nasser Al-Deebani is a consultant, a radiation oncologist, and a brachytherapy lead in King Abdullah Medical City in Mecca. Dr. Abir Al-Suwailem is a consultant radiation oncologist from King Faisal Specialist Hospital in Riyadh. And Dr. Sameh Hashim is a consultant radiation oncologist from Al Musa Private Hospital in Al Ahsa. Thank you.
Assalamu alaikum warahmatullahi wabarakatuh. Thanks for attending with us. So today we have a nice and interactive GYN session, mainly addressing the cervical as well as the endometrial cancer. So our first speaker is Max Schmidt from Vienna University Hospital. He's an expert in GYN, especially cervical. And today he will give us an update on cervical cancer, especially the systemic treatment, neoadjuvant and induction and concurrent as well. Come, please.
Yeah, thank you very much for the kind introduction, and thank you for the invitation to the Congress. It's really a big honor and a big thing for us to come to your country. Thank you very much for that. So I would like to give you a brief introduction. I hope it works. Yeah. If we look at the current recommendations in Europe for treatment of locally advanced cervical cancer, we can see external beam radiotherapy, we can see chemotherapy, and image-guided adaptive brachytherapy as the new important aspect in this treatment. Just what is the principle of this? It means repetitive imaging, preferable with MRI. It means an adaptive target volume concept. It means adaptation of the application technique with combined intracavitary interstitial brachytherapy. And it means advanced treatment planning to really have individualized dose planning. The evidence for this comes from the EMBRACE-1 study, you probably all know, which represents the typical cohort of patients with locally advanced cervical cancer, reporting outstanding local tumor control in these patients. If we want to assess the impact of image-guided adaptive brachytherapy, I think it makes sense to compare with the previous study, the retro-EMBRACE study, which shows us data from centers doing less advanced image-guided adaptive brachytherapy. And here we can see that we have an increase in local tumor control, especially in the locally advanced tumors, the stage 3B tumors. Is local tumor control as such an important endpoint? I think we all know that patients who develop a local recurrence die very, very early after this relapse. But this is, I think, a very important endpoint, which we can see also here in this data coming from the EMBRACE study. And this impact, this improvement in local tumor control seems also to affect the overall survival outcome. So if we compare again EMBRACE-1 data with retro-EMBRACE data, we can see for the locally advanced tumors, we see an increase in survival based on this treatment. Now coming to the new studies which have been recently published. The one is the Interlace study. So this was a randomized trial from the UK. Or if you look at the patient cohort, mainly the overall cohort of patients with locally advanced tumors from 1B1M+, and then independent of the nodal status up to 4A. And they were randomized into two arms. One arm was the standard arm, chemoradiation plus chemotherapy plus brachytherapy, versus the experimental arm, where in addition, induction chemotherapy was performed with 6 cycles of carboplatin paclitaxel. And the results which you can see here is an increase, a significant increase in progression-free survival as well as in overall survival. And this increase comes mainly what the authors report from an improvement in the reduction of distant metastases. So this is the data which has been presented by the group. This comes at a certain cost, and this cost is side effects. So we see a substantial increase in G3 and G4 morbidity in the Interlace trial by the additional chemotherapy. On the other hand, we have the Keynote A18 study. And now the most important difference to the Interlace trial is that this is not for the overall cohort, but this is for a high-risk cohort. So we can see by the inclusion criteria, only node positive patients with small tumors, so 1B2 to 2B with node positive disease, or the advanced stages, stage 3 and 4A, were eligible for this study. And they were again randomized into a standard arm. This was radiochemotherapy and brachytherapy versus the experimental arm with additional pembrolizumab concurrently and in an adjuvant setting. And again, also this was recently published in 24, we can see a significant improvement in overall survival by the additional systemic treatment. Also, this comes at a certain cost. There's a moderate increase in overall toxicity, and especially in regard to immune-mediated side effects concerning mainly the thyroid, which is something completely new for us, which we have not experienced so far in this setting. Now, some considerations from our side on these new systemic treatments. If we look at the Interlace trial, this is the patient cohort. And we can see from this patient cohort that it's a relatively good patient cohort in terms of age, relatively young patients, very good condition, performance score, and the majority have a very high performance score, and not so many patients with advanced disease. If we compare the Embrace trial to this cohort, we can see that the Embrace trial had older patients in a poorer condition with more advanced disease, and including also para-aortic disease. So this is a big difference between those two studies. If we compare the outcome of these two studies, we can see that in fact the experimental arm in Interlace was better than the Embrace results. And this led to the conclusion from the authors of the study that this should be the new standard of care. However, I think it is important to have a more detailed look, and if we adjust the Embrace cohort to the criteria of the Interlace trial, so mainly reducing the patients with para-aortic disease, these are the very poor prognostic parameter, we can see that the results suddenly are almost similar without any additional chemotherapy. So just by adjusting the cohort to the Interlace cohort, we see that the results are almost identical. Another important remark is distant metastasis is the driving factor according to the Center for the Improvement in Interlace. I think we can look at the risk factors for distant metastasis in Embrace 1. The driving factors, as we all know, is nodal status, histology, and also what is new, the high-risk clinical target volume. And if we create risk groups based on these three parameters, the driving parameters, we can see that the group which was included in the Interlace study is actually a very low-risk group for distant metastasis. So with Embrace treatment, we see, or Embrace 1 treatment, let's put it like that, we can see an 8% risk for distant metastasis in this group. So the question is really, do we want to expose all patients with an additional treatment to have an improvement in a group which actually has relatively few distant recurrences? And then the question is, where are these distant failures? And there we see the locations of distant failures in Embrace 1, with lungs being important, but the most important location for distant metastasis is actually the para-aortic region. The highest incidence for distant metastasis in Embrace 1 was the para-aortic region. And I think this is a very important aspect, because this is something which we as radiation oncologists can deal with. This was actually investigated in the Embrace 2 study. So in the Embrace 2 study, we have a risk-adapted target selection for external beam radiotherapy with a low-risk group, an intermediate risk group, and a high-risk group. And the important part is the high-risk group. So patients with a positive node in the common iliac chain or more than 2 positive lymph nodes received elective periodic radiotherapy. So this was one of the major interventions of the EMBRACE-2 study. The EMBRACE-2 study was a prospective interventional multi-center single-arm cohort study with almost 50 centers participating, 1,500 patients recruited. Patient accrual was from 2016 to 21, and there were interventions on external beam radiotherapy. This included the elective target volumes as well as simultaneous integrated boosting for large lymph nodes and also interventions for brachytherapy. We were very happy to be able to present the results from the EMBRACE-2 study at the ESTRO meeting 2 weeks ago. And I'm also happy to share these results now with you. And what we can see is the main output of this study. So we can see really in this large group of 50, almost 50 centers, that the protocol from EMBRACE-1 transferred to the EMBRACE-2 with defined interventions is feasible in a multi-center study, leading to excellent pelvic nodal control, excellent local control, and these improvements also on the periodic side, leading to improved distant control. So I think this is really the major message, that this improved local regional control seems also translating to improved distant recurrences. And this comes at a very low rate of morbidity. So we had a G4 morbidity of less than 1% in the EMBRACE-2 study. And this brings us back to the feasibility of induction chemotherapy or neoadjuvant chemotherapy in a real world setting. So we saw, and the authors of the Interlay study clearly report, this is feasible. However, in a very relatively young and healthy population. If we look at consecutive patients, this is a study from Denmark, from Aarhus, looking at consecutive patients receiving concomitant chemotherapy. And this is the performance of concomitant chemotherapy in this cohort. And we can see that, of course, in different groups, we can see different fulfillment of the 5 cycles of chemotherapy. And patients which are not that fit, performance score more than 2, and comorbidity, very, very few patients even start with chemotherapy or fulfill even the 5 cycles. And this is, of course, this is the real world population we are dealing with. And this is, I think, very questionable that additional chemotherapy with neoadjuvant chemotherapy will be able to be done on a broad patient cohort. Then the other point is the impact of the increased hematological toxicity on the performance of brachytherapy. So what we experienced, and also in Vienna, we got patients from outside who received induction chemotherapy. This leads to delay of brachytherapy, in particular when it comes then to combined intracavitary interstitial brachytherapy, where we even have stronger constraints for thrombocytes to be able to do this. So again, this is a big question mark if this is really feasible in a broad patient cohort. When we compare to the Keynote A18 study, I think it's much more difficult because the study as such reports very few parameters. We have very little knowledge on actually this patient cohort and how it was treated. What we can see on the one hand, that in regard to those parameters which have been done, that this is a bit unusual what they report, total physical cervix dose, so we can not really say anything about that. The rate of interstitial brachytherapy was relatively low with approximately 20%. So I think what we can conclude at least is there's very limited data on that. And it's also a bit questionable that this is really comparable to the high standard of EMBRACE. Again, we did in principle the same exercise comparing EMBRACE-1 results adapted to the cohort of the Keynote A18 study. And here we see, in fact, looking at the 24 months results, that the results for this high-risk cohort in EMBRACE-1 are even better than the ones from the Keynote A18 study in the experimental arm. So again, I think what we can derive from this is it seems to be that there is an unused radiotherapy potential in the Keynote A18 study. And in the end, we have to admit, we actually do not know on which endpoint does pembrolizumab actually work. Is it improvement on distant metastasis? Is it improvement in local? We just don't know because the authors do not report that. And can we expect further improvement if we add pembrolizumab to EMBRACE-like treatment? I think these are just open questions we just do not know at the moment. What are our future perspectives? I think what we have to be aware of that we experience at the moment a diversification of treatment. There will be, based on very different arguments, centers following more embrace-like treatment. There will be centers following more the interlace type treatment and some following the keynote type treatment. This will depend on different factors, infrastructure, regional aspects. I think it's a very complex story. And I think we have to accept that for the moment, the question is also unsolved. We cannot give a strong recommendation. It should be the one or it should be the other. So I think what we need in the end is to put this together. We need a systematic data assessment and risk factor analysis for these different patient cohorts and different treatment concepts, and then analyze. And this is actually, and what I would like to introduce to you is the EMBRACE-3 PROMISE study. So this is the next generation of EMBRACE studies, which will be again prospective, non-interventional, observational, multi-arm cohort study. And here we allow for the different treatments. It should have the level, the EMBRACE level as from the radiotherapy perspective, and then allow for standard treatment without any additional chemotherapy, but also allowing for additional systemic treatment. But we need clear reporting on all the endpoints, and we need a high-level radiotherapy. And we will also allow, and this is not concerning the systemic treatment, also allow for non-standard treatment. So we are very well aware of that patients can be sometimes not be treated according to standard protocol for several factors. It might be that patients are elderly, are frail, are treated differently, and we have no knowledge on this. And we will also allow for this. So centers decide on their treatment, report systematically, and give us the opportunity to analyze this data. And with this, I'm on the end of my presentation. Thank you very much for the attention and looking forward to questions.
Thank you, Lord. And we'll now, we'll leave this question, Max, till the end of the session. We'd like now to introduce our colleague, Rakan Amjad from King Abdulaziz University in Rabat. Thank you very much for attending with us.
Assalamu alaikum. Good morning, everyone. Sorry, it's very small here. Sorry, I can't see it like the sentence. I want to read it again. Yeah, thank you very much. Thank you very much for having me. It's a pleasure. I'll talk today about updates on radiotherapy for advanced and recurrent endometrial cancer. Here are my objectives. Okay, understand the integration of molecular classification in guiding radiotherapy decision. Interpret key findings from major randomized trial evaluating the role of adjuvant radiotherapy. Review the role of radiotherapy in management of recurrent endometrial cancer, and discuss how radiotherapy fits within the current immunotherapy landscape. So as you can hear, and you might know, over the past few years, molecular classification has been a critical part of how we risk stratify endometrial cancer. We essentially have four subtypes: poly, ultra mutation, mismatch repair deficient, no specific molecular profile, and P53 abnormal. And as you know, poly mutation can be detected through next generation sequencing, while the other remaining can be detected through immunohistochemistry. And it's for the first time, molecular classification has been incorporated into the new FIGO staging 2023. To my knowledge, we have some limitation here in some centers in getting full access of molecular classification for each case of endometrial cancer. However, it's very important to note that in very small percent, which is around 2% of the time, patients can have what we call double classifier or multiple classifier. Classically or typically, you will have P53 with poly. And in this case, we follow the prognosis of poly as they tend to do very well. Very early, you might see MMR deficient with P53, and some guidelines suggest to assign the tumor to MMR deficient, as the patient can get some potential benefit from immunotherapy. This slide here illustrates the prognostic value of molecular classification that's been done retrospectively from these different studies. And as you can see, the patients who have polymutation, they have excellent prognosis regardless the stage or the other factors. While patients with P53 abnormal, they have the poorest prognosis. For those with MMR deficient and no specific molecular profile, they kind of fall in the middle area, depends on the other prognostic factors. When we talk about advanced endometrial cancer, we refer that to stage 3 and 4. However, when we say high-risk endometrial cancer, it's very variable and heterogeneous in literature. So it could be anything like FIGO stage 1A, grade 3 with excessive lymphovascular invasion, could be 1B, grade 3 through stage 3, and of course, any type 2 histology like serous or clear cell. Here I will review PORTIC3 and GOG 258. So starting with PORTIC3, as you know, it's a phase 3 randomized clinical trial that enrolled women with high-risk endometrial cancer, including stage 1 to 3 endometrioid with high-risk features and serous or clear cell histologies. Of course, all the patients had surgery, and the patients were randomized to radiation alone, which was the standard arm, versus concurrent chemoradiation with followed with adjuvant carboplatin for 4 cycles. The primary endpoint was failure-free survival. So at 5 years, the failure-free survival was significant at 76% in the experimental arm versus 67% in the radiotherapy alone. There was no survival benefit in the first report. So on sub-analysis, greater absolute benefits was seen in the patients who received chemo radiotherapy for those who had stage 3 endometrial cancer, or for those who had serous histology. As you can see here on the right side, the serous, the top one is the overall survival curves. The bottom is the failure-free survival. And on the left hand is for stage 3. They've also looked in post hoc analysis in PORTIC3 trials. So as you can see here, the benefits seen in both overall survival and recurrence-free survival in those who had concurrent chemoradiation for patients with P53 abnormal. Sorry, toxicity, again, anytime we're at treatment, as we expect more toxicity, things that the patient don't like from this treatment, like neuropathy, which obviously we can see it only present in the chemo arm. Moving to GOG 258, which was running at the same time as PORTIC3. However, the standard arm here was different. So they investigated chemo alone versus the experimental arm, exactly the same, concurrent chemoradiation followed by carboplatin. And in this trial, they included a little bit more advanced patient than PORTIC3. So they included patients with stage 3 or 4A, except for those with clear cell and serous cancer with positive histology. And patient, they had to have no residual disease after surgery. So they found no difference in progression-free survival However, there was a difference in pelvic and para-aortic recurrence. As you see here, it's doubled. It's 20% versus 11%. So of course, 20% in the chemo alone arm. Okay, now let's look at how the field is evolving through ongoing trials on focusing on molecular guided strategy, which I think will be a very helpful and answering lots of questions we have regarding high intermediate risk endometrial cancer in terms of escalating or de-escalating treatment. So this is for a randomized trial. It's a phase 3, 2-to-1. The standard arm is vaginal brachytherapy, and the primary endpoint is vaginal recurrence. So the trial has completed recruitment. However, we're just awaiting for the results, so hopefully soon. So for those patients with polymutation, they are going to get observation on experimental arm. And for those who, as they tend to do very well from the retrospective data we have, for those with MMR deficient, they will get vaginal brachytherapy on the experimental arm. And for the patients who have high-risk disease like substantial lymphovascular invasion, P53, or here they've added more than 10% LCAM expression, they will be upgraded to get external beam radiotherapy on the experimental arm. The other trial, which is very interesting trial, the Rainbow, which stands for Refining Adjuvant Treatment in Endometrial Cancer based on molecular features. It's basically 4 parallel trial, each color-coded and designed to target specific molecular subtype. So the red trial for women with invasive stage 1 to 3 P53 abnormal endometrial cancer compares adjuvant chemo radiotherapy versus chemo radiotherapy with the addition of olaparib for 2 years. The green trial looking for patient with MMR deficient and compares radiotherapy plus or minus chemotherapy versus radiotherapy plus concurrent and adjuvant durvalumab for 1 year. The orange trial, it's a treatment de-escalation trial for patients with no specific molecular profile with estrogen positive endometrial cancer stage 2 with lymphovascular invasion or stage 3, comparing chemoradiotherapy versus radiotherapy followed by progestin for 2 years. And last trial is the blue trial, which is a phase 2 in which safety of de-escalation of adjuvant treatment is investigated for female with endometrial cancer with polymutation stage 1 to 3, either no adjuvant therapy or de-escalation. The primary endpoint for the top 3 trials is recurrence-free survival at 3 years. However, it is pelvic recurrence at 3 years for the poly blue trial. This slide here summarizes a snapshot from the NCCN guideline for the current algorithm of recurrent or endometrial cancer. So basically, if we have local regional recurrence with no metastatic disease, if the patient had no prior radiation or only vaginal brachytherapy, then the patient can get radiation alone, which consistent of both external and brachytherapy, or a surgical resection if that's visible. If the patient had prior radiotherapy, then surgery is an option, plus or minus systemic therapy, plus or minus palliative radiation, or brachy plus or minus systemic therapy. This is the GOG 238 phase 3 randomized trial that evaluated the addition of weekly cisplatin to pelvic radiotherapy consistent with external beam radiation and brachytherapy for patients with isolated local recurrence of endometrial cancer in the vagina, plus or minus lymph node. And they found the adding cisplatin did not improve progression-free survival or overall survival and led to more toxicity. Therefore, pelvic radiotherapy remains the standard of care for radiation-naive patient for isolated vaginal recurrence. And both group actually had very good, excellent, actually, local control, more than 90%. Now, as you may know, few landmark trials have recently published investigating the role of immunotherapy in addition to chemotherapy in advanced and recurrent endometrial cancer. For the sake of the time, I'll just briefly review the RUBY and the NRG-GY018. So the RUBY, in terms of population, they included patients with a stage 3 or 4 patient or recurrent, but they have to be not amenable to curative therapy. NRG measurable stage 3, 4A, measurable or non-measurable stage 4B or recurrent, and they've excluded carcinosarcoma. The treatment arms, both trial compared chemo plus PD-1 inhibitor, dostarlimab in the RUBY trial, and pembro in the NRG, and both followed with maintenance. For the control arm, both chemotherapy plus placebo, and that when I say chemo, it's carboplatin. In both trials, patients were stratified by MMR status. So the endpoints, progression-free survival in both, plus overall survival in the RUBY trial. Note that 40% of the patients in the NRG, they had prior external beam radiation, while only 20 in the RUBY had previous radiation. So in summary, both trials demonstrated benefit from adding chemotherapy to both proficient and deficient MMR population. However, with a substantial benefit in the MMR deficient population, this curves for the RUBY trial showing the progression-free survival. And as you can see, on the right side, the proficient population, on the left side, the deficient. So at 24 months, for people with deficient MMR, the progression-free survival was 61.4 in the dostarlimab group versus 15.7 in the placebo group with a significant p-value. And for the proficient group, 28.4 in the dostarlimab arm versus 18.8 with a hazard ratio of 0.76. This is the progression-free survival of the NRG. Again, at 12 months analysis, progression-free survival for the MMR deficient cohort were 74%. In the pembro group versus 38% in the placebo group, with 70% difference in relative risk. Proficient cohort median progression-free survival was 13.1 months versus 8.7 months. So take-home messages, molecular classification is critical for guiding treatment decision in endometrial cancer, as it provides prognostic information and can be used to predict therapeutic response. The field is evolving, and we're awaiting results from ongoing trials evaluating molecular profile-based adjuvant therapy in patients with high intermediate risk endometrial cancer. In patients with isolated vaginal recurrence, the addition of concurrent chemotherapy will not improve outcome, and radiotherapy remains the standard of care for patients with radiotherapy naive. So, and last thing, the patient with MMR deficient, both dostarlimab and pembro showed significant progression-free survival benefit when adding first-line chemotherapy. And thank you.
Thank you, Dr. Razan. I'd like to invite you and Dr. Prof. Max Schmidt to the stage, and we're going to open the floor for questions.
Thank you very much, Max and Razan, for this excellent presentations. While I'm waiting for some questions, so I have just to start up and warm the audience. For both of you, Razan and Max, let's ask about the new uterine cancer cases post-hysterectomy, if there is an indication for external beam radiation, including, for example, cervical involvement, do you see any need to add vaginal vault with that external beam radiation with this current guidelines? What's your opinion, both of you?
Well, your question was post-hysterectomy to do additional radiotherapy, and if we need brachytherapy in addition. Yes. Yeah. In selected indications, if there was really substantial parametrial infiltration before, we consider also giving a brachytherapy boost, but this is like the only indication. Apart from that, we only give external beam radiotherapy and chemotherapy. As interstitial then, because I think with vaginal vault, we will not reach these parametrial areas. And if there was substantial parametrial infiltration before, I think this is more a logic approach than an evidence-based approach, and it is something to consider and discuss with the patient.
Thank you. I would just add vaginal vault, for example, if the patient has cervical stromal invasion, so for more local control. On top of that, sometimes with focal LVSI, I know not no much evidence for that, but definitely for any patient with cervical stromal invasion, I will add vaginal vault.
Thank you very much both for excellent presentations. I have a question about the cervix cancer. So when we talk about high quality brachytherapy, does this come more from the addition of interstitial needles, or does the addition of MRI on its own, the MRI guidance and the volumetric approach weighs a lot in this approach? Because we don't have interstitial everywhere, and I cannot predict ahead of time. If I have a large tumor to start with, then I can predict the need for interstitial. But if I cannot, or if it's not available, and I know I can do volumetric MRI guided treatment, probably giving a good dose to the GTV, but not necessarily to the whole high-risk CTV. Does this mean that this is a suboptimal brachy to the level that I should consider neoadjuvant chemotherapy if I don't have immuno and I don't have interstitial, or is it not?
Yeah, I think very good question and difficult to answer. I think what is important to mention is just doing MRI as such will not change the treatment. So I think this is I think very clear. But as we also saw in our workshop 2 days ago, I think we also have possibilities to improve our dosimetry with intracavitary alone. It comes at most likely in big tumors with a higher cost of morbidity, but I think we also have possibilities to optimize our treatment with that. I think this is a very clear approach, and to give a concrete cut of when we need interstitial, when not, I think this is very vague and not clear. The question, does neoadjuvant chemotherapy compensate for this? Maybe. So I think we don't know in the end. What we learn from the centers who are doing interlace, that yes, there is a lot of shrinkage, it gets smaller. So I think this might be a pragmatic approach to that. Personally, we feel if we have the possibility to go for interstitial, I think we reduce toxicity. I think this is in the end, and I think this was also the message I would like to give with my presentation. I think we have strong possibilities as radiation oncologists to improve the treatment. And we're very much driven also by pharma companies who tell us it's only distance, and distance is the only endpoint which counts. It seems that local regional control is extremely important. It's a stepwise spread of disease, and we as radiation oncologists can do a lot for that.
Thank you, Razan and Maximilian, for the excellent overview. We really enjoyed it. My question to the Dr. Maximilian for the cervix cancer. So it's always a dilemma, and we discussed it also yesterday in the brachy session for the Best of Astro. If you have a locally advanced disease with lymph node positive, let's say, how you stratify, what is in your practice? You go to the interlace or you go to the keynote?
I think this is the question we cannot answer at the moment. So it would be interesting to have to identify the subcohort which benefits from which treatment most. So just I think each center has to decide on its own what is possible, what are the financial restrictions, what is allowed to do, what are your possibilities. So we as a Medical University of Vienna, we decided to go for the pembrolizumab treatment. The main reason for that is that we have access to it. I mean, this is also a big aspect, and it is not delivering additional treatment to a big cohort of patients. So interlaced cohort, the study would mean to give this additional treatment to almost all patients. This is what we did not want because we see very good outcome in this more low-risk patients without any additional systemic treatment. However, for these high-risk patients, I think we're all aware that their distant recurrence is more important. And this is why we decided to go for this treatment. But this is our decision. I think this has to be done separately by each center. And hopefully the EMBRACE-3 study will give us some opportunity to learn from this and to understand that maybe we can come up with a final conclusion. Then for this situation, we would prefer this and for the other thing.
We have a question in the back.
Thanks for both of you for your excellent presentation. My question also related to the subject that for the patient that you believe they need interstitial brachytherapy, but the service is not available and the patient is not a candidate for the eligibility of other services. So what is the best approach for them? For example, one of the approaches that I saw and I did it for a few patients, and I want to hear from you about this. If we boost the GTV in the external beam up to 60, and then we keep the brachytherapy only for the GTV and the cervix, and try to make to reach up to 85 or 90, and we leave the intermediate or high risk volume to the boost of the external beam, and that's I try to overcome the absence of interstitial brachytherapy to the parameter.
Yeah, I think this was already in the past a common approach to give additional boost with external beam radiotherapy to this volume, to have a smaller volume there. I think it adds quite a lot of toxicity to do that because the high dose, the 60 gray volume, for example, which you don't have, is relatively big and will make it difficult. And the question is, if this adds so much more tumor shrinkage that you really can compensate for this, I'm a bit skeptical for that. I think as a practical approach, I mean, here in the country, you also have access with Dr. Noha, with interstitial brachytherapy. The question is how to select and when to refer patients. I think this is difficult to answer. We know for the very small tumors that they are very good treated by intracavitary alone. So let's say the 1B. For the big 3Bs, I think we're quite sure that interstitial adds a lot. I think I'll also show you this with the results right now. And in the big group of 2Bs, I think it's more difficult. And here might be an approach with an optimized intracavitary to make it a bit bigger, might be the optimal solution. So I'm a bit skeptical on the parametrial boost or external beam radiotherapy boost, because we know that this adds a lot of toxicity. And substituting brachytherapy completely by external beam radiotherapy, there have been trials in the US doing SBRT. They showed high toxicity and they stopped even the trial for that. So I think this is also to be taken into consideration for such questions.
I have one last question. So for endometrial cancer, a question for Dr. Razan and Dr. For those with the completely staged high-risk endometrial cancer who will end up receiving chemotherapy, what are the situations where you would give only brachytherapy and not external beam?
I guess for if they will get chemo, right?
They will get chemo when it's low stage. I mean,
Right.
what
So
stage
I,
one?
right. I mean, if 1A, no invasion, I think I would consider brachy.
But if it's 1B, you would definitely give external beam.
1B high grade.
Yeah. With
What's the other factors?
Well, high grade.
Lymphovascular invasion.
Let's say it's negative.
It's yeah. If everything is negative, and yeah, I think yeah, it's reasonable to give brachy a vault at this time. Yeah.
Any comment on this?
Yeah, I think it depends in the end on the factors. So I think I can just agree to your approach.
Thank you very much.
We have one more question.
Thank you, Dr. Max and Dr. Razan, for this amazing presentation. I just want to ask you about the patients who are endometrioid cancer diagnosed by biopsy, and then these patients are not eligible for hysterectomy because of any comorbidities, cardiac or whatever. So what is your approach for these patients? Are you treating them with external beam plus brachy? And what is your how do you see the outcome after these in comparison to the surgery?
Very good question. Thank you. Well, endometrium cancer, as you know, it's patient should have surgery, but sometimes, of course, patient for a few reasons she can't. So in that case, we will give external beam radiation and brachytherapy, but we'll do probably like a cervix, like interstitial. Okay, with a very high EQD dose. And then sometimes, like I've seen 2 cases like that, the problem was inoperable, but in those cases, they will have surgery, like kind of a new adjuvant, but then they will get surgery after. But to be honest, the surgery never happened. And they had pretty good control.
I have
like a curative intent. So we treat them as a curative intent, yes.
And you are giving the dose just like the cervical cancer
Yes.
regarding the external beam
Yes,
and the intracavitary
45, yes, 45, yes. And then, is either 8.5 times 3 for brachy or like cervical cancer.
And you find it's a good outcome.
My very short experience, yes.
Okay. And you, Dr. Max?
Dr. Max, I have a question myself, if you don't mind. I don't think anyone have any more questions. Do you have a question? Okay.
I think there was a question if
Oh, sorry.
I think again I can just agree. I think there is not as advanced data available on primary radiotherapy for endometrial cancer, but we have also good data. And patients who are inoperable with localized disease, I think they should be treated with radiotherapy and brachytherapy. And for the very small ones, so if this is really a stage 1 tumor, there's also possibility for brachy only. I think this is also important to mention. The big challenge, I think, here is the applicators in the end. So we don't have optimal applicators actually available, so we have to compensate a little. We have to be a bit creative. I think with intracavitary approach, usually it is possible to treat this appropriately. I think some developments also from the companies might be helpful, actually, because this is a growing there's also possibility. We also have good data for brachy only for stage 1 disease. I think, yes, this is I would not call it only interstitial. I think there are different approaches, like the Heyman capsules were a previous way to treat this. I think we need some developments there again, because this is a growing need, I think, and also for the companies to do something in this field.
Sorry, Maximilian, do you have also in Vienna also applicators for endometrial? But I didn't see in Germany. This is endometrial interstitial brachytherapy. Was the Dr. Noura said that we do it like cervix cancer. I didn't have ever seen this. Is, how can we do it? So endometrial cancer is very high.
Interstitial.
Interstitial for endometrium?
Yes.
Okay.
We previously had the Heyman capsules available for these kind of treatments. Nowadays, if we treat this, we would use the Venezia applicator with an intracavitary component and then add interstitial as appropriate. Yeah.
Okay, and you do restaging, then you see if it's applicable or not. While endometrial cancer can be very high or very, very top of the endometrial, you can reach it. Yeah. But if it is an endocervix region, we had it was as
also higher up. I mean, then the insertion of needles has to be longer than for cervix, of course, but also this is possible.
Yes, okay, this is logic. Thank you.
Okay, thank you everyone for your questions. I will just add one more question, if that's okay. So you mentioned the other day in the workshop that some of your patients do get induction chemotherapy. Who are these patients?
Patients from other centers.
Okay, okay.
We do not offer it in our department or with the gynecologist. We are working together, but we also do only brachytherapy for patients who are treated with external beam therapy somewhere else in a different center. And there we sometimes see patients also who get induction.
For those patients who are referred from other centers, do you see a gap between starting the chemotherapy and external beam, and how do you compensate for that in brachytherapy?
We have actually very good cooperation with these other centers. So they apply in terms of external radiotherapy, the Embrace2 protocol. They refer the patients very early, so they contact us when they start with the treatment. However, sometimes they get patients who already got somewhere else the induction part. Right. So this is why they could not control this. And we had, I would say, 3 or 4 patients in the last year which also get an induction chemotherapy, where we had a problem then in the end, that they had severe thrombocytopenia, which led them to delay of brachytherapy again.
Right.
Okay, thank you, everyone.
So it is my pleasure to welcome the chairperson for the Satellite Symposium. Dr. Sameh Hashim is a consultant radiation oncologist from Al Musa Private Hospital in Ahsa. Okay, then I guess I'll introduce the speaker for this session. Dr. Ahmed Al-Shahri is a consultant medical oncologist in National Guard Hospital, and he will be talking about individualized hormone-positive breast cancer management for post-CDK4/6 inhibitors.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Actually, it's good afternoon by this time. So I was asked to talk about individualizing the hormone receptor positive breast cancer management. So I'm giving this talk to radiation oncologists. So probably in the future, you will handle the management of hormone receptor positive breast cancer. And I want to show you that we have a lot of progress from medical oncology point of view. Is not only the radiation kind of techniques and all of these fancy machines. So I'll show you that we have a lot of fancy kind of medications that we can use now in the current practice. I'm presenting this talk on behalf of AstraZeneca, who's sponsoring this satellite symposium. So as you know, breast cancer is the most common cancer entity in Saudi Arabia, according to the Saudi Cancer Registry of 2022. Okay. Breast cancer was representing 18% of all cancer diagnoses of that year, which is a big chunk. The interesting part that you see nowadays that most of the patients are diagnosed in localized stage, like 52%. I remember when I first started my practice 15 years ago, it was in the range of 25 to 30%, the localized disease, but now is approaching 52%, which is a good progress in early diagnosis of breast cancer. Look at the distant metastasis, only 11%, which is again a good thing that we are now capturing more and more early stage breast cancer, as compared to 15 years ago, we're representing around 25% of all breast cancer diagnoses. If we compare our breast cancer diagnosis in comparison to other GCC countries, we are still reporting less breast cancer in comparison to the rest of GCC like countries, whether this is related to the capturing, whether related to diagnosis, whether related to registry, we don't know. But for now, the cancer diagnosis in Saudi Arabia is a little bit less than what had been reported in other countries in GCC. If we look at the hormone receptor positive metastatic disease, okay, the standard of care now is to use endocrine therapy plus CDK4/6 based on several clinical trials that have shown that addition of CDK4/6 to endocrine therapy has boosted the outcome with regard to progression-free survival. And at least one of the agents, the ribociclib, has also improved the overall survival. Now we are talking about 2 years, a median progression-free survival. Can you imagine? I still have some patients in my clinic now who have been on first-line endocrine therapy for the last 5 or 6 years. This was not the case a few years ago. So now we have a real progress with this regard. However, we still, with this kind of huge progress in management of advanced hormone receptor positive breast cancer, eventually all of these patients will develop some sort of resistance, okay, and they will start to progress. And this kind of resistance either related to the estrogen receptor itself, like kind of mutation in the ER receptor, or resistant to the CDK4/6 agents, or something related to a mutation to a pathway called AKT pathway. There might be one of these mutations which might boost a kind of resistance, which eventually lead to disease progression. So this is unmet need. Despite the huge progress in the first line setting of hormone receptor positive breast cancer, we still have some sort of resistance and progression and a challenge on what to do next. When we first have the CDK4/6 in practice, we didn't have available second line treatment. So it was only endocrine therapy alone. So if patient progress on aromatase inhibitor plus CDK4/6, we used to have fulvestrant only as the second line option. But now we have much more options that we can offer in the second line based on what we call predictive biomarkers or genetic mutations. These are the genetic mutations that we have to ask for any hormone receptor positive breast cancer. The BRCA mutation, the PIK3CA, the AKT pathway alteration, the ESR1 mutation. Most of these things are nowadays available in most of the tertiary cancer center in our country. And this will open the door to so many options, as you can see in front of you, as a potential treatment option in the second line and beyond. I remember, again, 15 years ago, we used to have only aromatase inhibitor and tamoxifen. These are the only two options. But look at this slide. Now we have so many options, endocrine therapy based, with a lot of biological treatment to be added. So if you take the first one here, based on the POLARI-2, there have been an improvement using everolimus, which is an mTOR inhibitor to endocrine therapy, which has boosted the progression-free survival. Here, just only 1 year ago, we had the option of continuation of CDK4/6 in the second line. This is basically for patients who fail palbociclib in the first line. We can switch to abemaciclib and switch the endocrine therapy. Here we have the EMERALD study, which have shown that those patients who have ESR1 mutation, they might get benefit of oral SERD called elacestrant. And here we have the CAPItello 291 clinical trial adding cabazitaxel to fulvestrant. And here we have the SOLAR-1 using alpelisib plus endocrine therapy in those who have what we call PIK3CA mutation. Here we can use PARP inhibitor, olaparib, or talazoparib based on the Olympiad study and IMBRCA study. And here, this is our very powerful hammer that we use for rapidly progressing hormone receptor positive disease, which is called TDXD, based on 2 clinical trials, the Destiny Breast 04, and more recently, the Destiny Breast 06. So this is just a kind of overview of what we can offer our patients when it comes to the second line options. I will focus on these 3 options with further details. When we talk about BRCA mutant breast cancer after failure of the standard first line treatment, which is endocrine therapy plus CDK4/6, if you have a patient who is a BRCA mutant, the standard of care is to start PARP inhibitor. And this is based on 2 studies, the Olympiad study and the IMBRCA study. We know that triple negative breast cancer, like 17% of them are BRCA mutant, 6% of hormone receptor positive breast cancer are BRCA mutant. But if we take, despite the fact that the proportion of BRCA mutant and hormone receptor positive is less than that in triple negative, but the absolute number of hormone receptor positive, it's much bigger than triple negative breast cancer. So there have been 2 clinical trials. The progression-free survival was the primary endpoint. Both of them showed olaparib or talazoparib is superior to chemotherapy if used in BRCA mutant breast cancer, whether triple negative or hormone receptor positive. Here, this is mostly hormone receptor positive breast cancer. You can see that progression-free survival has almost doubled by using PARP inhibitor in comparison to what? To chemotherapy. So it's even more powerful than chemotherapy to achieve a longer progression-free survival, which means longer time to receive chemotherapy in subsequent lines of treatment. Interestingly, the Olympiad study showed an improvement in overall survival in those patients who did not receive chemotherapy in the metastatic setting. So you have progression-free survival, overall survival by using PARP inhibitor in BRCA mutant hormone receptor positive breast cancer. And largely based on these two studies, the olaparib have been approved by the American FDA like almost 7 years ago or 8 years ago, and it had been in practice since that time. What about capivasertib? Capivasertib actually have been tested in a phase 3 trial. First of all, you know that those patients who have a mutation in what we call the AKT pathway, they have an inferior outcome when treated with endocrine therapy. And this has been shown in several clinical trials. If patients have any kind of mutation in that pathway, this will lead to an inferior outcome because of resistance to endocrine therapy. As you can see here, this is the down signaling pathway that will lead to breast cancer, carcinogenesis, and hormone receptor positive breast cancer. You can see there is like a specific molecule called the PI3K AKT mTOR pathway. And any kind of mutation, activating mutation in these molecules will lead to a resistance to endocrine therapy and progression breast cancer. So this is why we have the capivasertib, which is a specific AKT inhibitor, and it can inhibit all isoforms 1, 2, and 3. This is in theory. Can we prove it in clinical practice? Yes, we have a phase 3 clinical trial called the Capitello 291. They have included those patients with metastatic hormone receptor positive breast cancer who failed the first line treatment, and they have randomized those patients to receive fulvestrant alone, which is used to be the standard endocrine therapy in the second line, plus minus capivasertib, with progression-free survival as the primary endpoint of the study. This is the patient distribution. You can see that they are equally distributed between the capivasertib and the control arm. You can see that 70% of those patients have been treated with CDK4/6 in the first line. And those who have AKT pathway alteration or mutation are 40%. So this study did include all hormone receptor positive breast cancer. 40% of them, they have AKT pathway alteration or mutation. This is the primary endpoint. Progression-free survival in the overall population was superior in favor of the capivasertib, with significant improvement, 7.2 versus 3.6 months, hazard ratio 0.6 with a significant p-value, as you can see here. If they focus on those who have the mutation, the AKT alteration, you can see the magnitude of benefit was even bigger with a hazard ratio of 0.5, meaning 50% reduction in the risk of death or disease progression by having the capivasertib. And this is the overall response rate. Also, you can see almost doubled by having capivasertib. So if you are looking for a more response, capivasertib might give you this kind of benefit. And regardless of the type of mutation, because you know the AKT pathway, there are 3 mutations, PIK3CA, AKT, P10. Regardless of what kind of mutation we are talking about, there have been a benefit of adding capivasertib to fulvestrant. And regardless whether a patient received CDK4/6 or not, there was a significant benefit of using capivasertib. And this is when they excluded the PIK3CA mutant patient and they focus on the AKT non-altered patient. There was a trend towards benefit of having capivasertib on top of fulvestrant. With regard to the need for second-line treatment, it had been significantly prolonged, meaning that the patients who have been on capivasertib, they took longer time to need to start chemotherapy. This is a very important endpoint nowadays we consider in our clinical trial, especially endocrine therapy clinical trial. How much this patient need time to start chemotherapy, because we know chemotherapy, it does affect the quality of life of these patients. So the longer time patient need to start chemotherapy, the better the treatment that we can use. And you can see that the progression-free survival too was better for capivasertib, and also the need to start subsequent line of treatment was better for capivasertib. So it's an effective treatment at different kind of endpoints. And this is the overall survival. You can see there is a clear separation in favor of capivasertib. It didn't reach the statistical level of significance. However, this is immature data. We need longer follow-up. And many of these clinical trials with longer follow-up, we can see that the survival benefit. Yesterday, actually 2 days ago, there was the press conference, the ESMO press conference in Europe. There was a clinical trial which had been reported 12 years ago. Okay, the original interim analysis. Just only last week, they reported the overall survival. So after 12 years, they saw the overall survival of using such a treatment. So with regard to toxicity, you can see the capivasertib being associated with increased toxicity, as might be imagined. And most of these toxicities are related to GI and cutaneous toxicities. Most of the medical oncologists are well trained to look after these issues. So they are not dose limiting things, our problem. The quality of life, the functionality was better in favor of capivasertib. So based on all of these data, the capivasertib had been approved almost November 2023 to be used in clinical practice for advanced hormone receptor positive breast cancer who failed one line of endocrine therapy and they have AKT pathway alteration. So you have to use this medication, you have to have this kind of testing available in your center to consider such a treatment. Last but not least, the powerful hammer that we use for rapidly progressing hormone receptor positive breast cancer. Despite that, the beautiful picture I gave you about the use of endocrine therapy, biological treatments, we have category of patients who unfortunately progress quickly on endocrine therapy. Even within the first 6 months of starting endocrine therapy, they progress. And those patients are classified as refractory, like endocrine therapy refractory patients. So this is why this study was designed, the Destiny Breast 06, and to use what we call TDXD, which is a chemotherapy used for those patients. It's actually an anti-HER2 treatment, but there is a special group of hormone receptor positive breast cancer we call HER2 low. And now we have the new category, what we call ultra low. Okay, so this is the category of patients who have been included in the study. Hormone receptor positive, HER2 low, or ultra low. You can see that the HER2 low represents almost 713 patients, where HER2 ultra low, 150 patients. So the vast majority of patients were HER2 low. And they have been randomized to use chemotherapy, TDXD, or treatment choice of physician choice, which is another type of chemotherapy, either capecitabine, paclitaxel, or nab-paclitaxel. And the primary endpoint was the progression-free survival. There was a significant improvement in favor of TDXD, like 13.2 months versus 8.1 months, with 5 months absolute difference between the two. Remember, we are talking about a very endocrine therapy refractory patients, so they are very progressive patients. So to have a 5 months absolute difference, this is really important endpoint. The hazard ratio 0.62, meaning 38% reduction in the risk of death or disease progression with a significant p-value, as you can see here. And this is the different subgroups. This is in the HER2 low population. This is in the intention to treat population, which includes the HER2 low and the ultra low. And this is for the ultra low population, because the ultra low is a new kind of concept. Even most of the pathologists in our country here, they still exercising to define those patients, but still we still see this kind of benefit with regard to progression-free survival. The toxicity for TDXD is well known to all medical oncologists, is a nightmare to our radiologists, especially when it comes to interstitial pneumonitis. We have like at least maybe 8 to 10% of patients might develop grade 1 to grade 2 interstitial pneumonitis, which needs a special attention, a special recognition, and a special treatment from the beginning. The cardiac toxicity that have been reported is in the range of 7% and mostly grade 1 and grade 2. So based on that, just only 3 months ago, the TDXD was approved as a treatment, as a first-line chemotherapy in hormone receptor positive metastatic breast cancer after 1 line of endocrine therapy, especially for those rapidly progressing within the first 6 months. And this was in January 2025. So the guidelines, this is the ESMO guidelines that have included all these valuable treatment options that I was talking about. I like the ESMO guidelines because they are more friendly visually to us as medical oncologists. And this is the ASCO guidelines, the slide that I showed you about all these treatment options. And these are the NCCN guidelines, okay? Again, listing all these treatment options. The key message now that hormone receptor positive cancer, they have much more options ever than before. And we still have a lot of clinical trials coming. So probably if I give the same kind of lecture 6 months from now, it will be totally different than what we have today. With that, I would conclude my talk. Thank you. I'm pretty sure now that most of my radiation colleagues, now they are more competent to deal with hormone receptor positive breast cancer.
Thank you very much. This was a very informative presentation. Any questions for Dr. Rahman?
Thank you very much for the presentation. It's a good refresher to us. Quick question to you. In situations when you see only oligoprogression, so patients is on CDK4/6 inhibitor with hormone therapy, and you have 1 or 2 areas only that is progressing, everywhere else stable. What would you recommend in these situations? Would you go straight for second line or consider SPRT?
Excellent question. To be honest with you, this is a kind of situation that we face frequently in the clinic. And usually if there is an oligo progression, usually I will address that oligo metastatic disease. I will continue the same systemic therapy. I'm glad that we have Dr. Samaher here. Usually we have this kind of back and forth discussion about those patients who progress, for example, in the primary breast. We might consider palliative radiation to the site or toilet mastectomy if this is the only site of disease progression, while I keep the same systemic therapy, because that kind of oligo progressive disease might represent a resistant clone, while the rest of the body might be still responding. So I don't want to waste a very valuable endocrine therapy or a systemic therapy for that kind of resistance. But if I see, on the other hand, like a progression all over, this is the time where I switch to second line.
Thank you very much.
You're welcome.
First of all, thank you for the presentation. Wonderful. I would like to ask you about CDK4 inhibitor and radiation. Any in your practice guidelines, time frame? Do you use it all together? Is it contraindication in radical and metastatic?
In radical, if you consider the adjuvant clinical trials, they prefer usually to start after finishing the radiation. And if I'm not mistaken, they were talking about probably 4 weeks, 4 to 6 weeks of a washout time after finishing radiation to start the adjuvant CDK4/6. We have 2 of them, as you know, the ribociclib and abemaciclib now in clinical practice. For the metastatic setting, to be honest with you, I didn't come across any kind of trial which contradict the use of radiation while patient on this kind of treatment. For example, if I have a patient on CDK4/6 plus endocrine therapy, I refer the patient for palliative radiation, whether like a skeletal metastasis or primary breast. Usually I continue the same kind of treatment because it's going to be a very short time of radiation.
Unfortunately, it's very important. There is some review articles showing that it's safe to give both of them. But in real practice, this is not the truth. We have a very bad side effect. Maybe people here can share me using a CDK4 inhibitor with radiation, especially in radical, when you give it in high-risk patients. You start the adjuvant quickly.
What was it like in a certain kind of like organ, like for example, pneumonitis or?
Yes, most likely in respiratory. One of my medical oncology
because
he told me I'm going to stop doing that. Very bad pneumonitis.
CDK4/6 is being associated like in 1 to 2% of patients to have interstitial pneumonitis. Okay, so the real question, was it because of radiation in addition to CDK4/6, or because this patient was prone to have pneumonitis anyway? I have like maybe 2 or 3 patients who develop pneumonitis while in CDK4/6, regardless of radiation. So it is a well-known kind of problem there.
It's difficult. We need to focus more. That's why in Harvard, till this point, they are saying, watch it. Be careful to use it as a radical, because, you know, there is a part of lung in the field of our breast when you give. So is it because of that or that? We have to be very careful. I'm a person, I don't use both of them together in radical intent, but in palliative, we don't stop it really.
Yes. Yeah, definitely. We agree in the adjuvant setting. We agree that we have to allow a period of washout. The question about the metastatic setting. And to be honest with you, I usually discuss with my colleagues, whether Dr. Samaher or any other colleague, if they have a major problem going combined, I don't have a problem to stop the CDK4/6, continue the endocrine therapy meanwhile introducing CDK4/6 later.
We have no more question there.
One information to add also, with the combining the radiation therapy with CDK inhibitor, we faced a very bad later effect on skin reaction. So skin tearing and losing of the construction and the implant.
It's something to look at, yes, exactly.
Thank you very much for this excellent presentation. I think my question is a little bit of a follow-up on the previous question about SBRT with oligoprogression. You've actually presented an extensive body of data on improvement in survival in patients with many second-line therapies for this cohort of patients with many options of targeted therapy. Is there any evidence in patients with breast cancer that utilizing an approach of SBRT for oligoprogression could compromise that outcome? I think that's always my concern in these patients. You've got high level one evidence of subsequent lines of therapy versus very limited data on the utilization of SBRT for oligoprogression in the setting of metastatic breast cancer, especially if they're polymetastatic.
Exactly. Yeah, thank you. This is an excellent question. Once again, if you have an oligometastatic disease that's progressing while the remaining part of the body is under control, I don't have like a high level evidence to compare the SBRT in these patients as versus switching to second line. I don't think we're going to have any evidence to support that. But in clinical practice, what we do, as you correctly said, that we usually address this kind of localized progression by SBRT or sometimes surgical resection. Like, for example, if it was just a brain metastasis, we might go after that with surgical resection and continue the same systemic therapy, the first line, leaving second line for more like kind of advanced disease. Because remember, we have limited number of options, first line, second line, and probably third line. This would be the last one. So the longer patient will stay on one line of systemic therapy, the better the outcome. And the longer the time need to switch to second line or third line, the better the outcome for the patient. So to answer your question, I don't have any evidence to compare this approach versus the other. I don't think we will ever have an evidence to have this kind of comparison, but it is a common practice in many, many oncology centers here and internationally. If you have a localized disease, just address that localized disease by having SBRT or some local regional treatment, continue the same systemic.
Just want to add one point. I think there is an evidence regarding, if I understand the question very right, if you have multiple metastases and there is just progression in one side, you don't need to change your systemic treatment.
Yes.
There is a role of
exactly. We know that.
We have evidence.
Yeah, we know that. But I mean, using SBRT versus one of these second line options. Yeah. We don't have that one, but this is a common
Dr. Nahash is...
Can I comment? Or I actually, this is, there was a mention that it is a common practice, but I would actually disagree that this is a common practice in the setup of breast cancer. I think there's still a lot of controversy about that. I think there are 2 randomized trials in the setup of oligometastasis. So this is even a better kind of cohort of patients in terms of prognosis. There's the NRG BR002, and I forgot the name of the trial that combined both lung cancer and breast cancer. So both of them showed no improvement in outcome in utilization of ablative therapy, whether surgery or SBRT in patients with metastatic breast cancer. It did show a benefit in the cohort with the lung cancer, but not with the breast cancer. It tells me that this patients with breast cancer are a different way of disease behaving. Evidence is coming from all of these basket trials that throw a lot of patients in there. And then sometimes that benefit is driven by a different disease that has a different biology and a different natural history.
That's true.
So in the specific trials that looks at breast cancer, there was no benefit. And the question is, are we compromising the outcome of these patients if we delay the systemic therapy that has a high level of evidence of improvement in their outcome? And that's always my concern with these patients, is that, yes, SBRT sounds fancy and theoretically speaking, we're delaying, but we didn't know for sure. We didn't have data that tells us that delaying that systemic therapy does not negatively impact these patients, or if they're going to progress really soon afterwards, and we're going to switch anyways to second-line systemic therapy, but we've added the toxicity of SBRT. I think this is
it's well taken. Your point, it's well taken. To be honest with you, it's a very excellent argument. But as I mentioned, even those patients who are being included in these clinical trials, usually, even because we had this kind of discussion with some of the authors of these clinical trials, for oligometastatic disease, usually they address it with local regional treatments. They leave the second line treatment for more kind of systemic progression or something like that. So, and as we do in our clinical practice, we monitor our patients. Even if we do like local regional treatment, we monitor them closely within first 2 months or 3 months. If we see like further progression, either the same site or distantly, we start second line. So I'm not very skeptical about delaying, the systemic therapy, the second line, if I use the local regional treatments.
I just want to have one comment on this. I basically, this is my approach because of the lack of strong evidence for SBRT in this setting in breast cancer. So I usually give or recommend SBRT in the occasions where my medical oncology colleague tells me that this patient needs a break, or she refuses a systemic treatment, or it's not available for her. These are the situations where I think it's very appropriate, even if there is no strong evidence to offer SBRT.
Also, let's share what's happening in all institutes. In King Saud University, we are not pushing very hard to give second line and third line. They are coming to me. Legal invested. Yes, I'm working in SBRT more than the past. Maybe because of lack of medication.
Perhaps, yeah. I think that's probably a reason.
They're asking me more.
And it's going to be a cheaper option.
Thank you very much. Thank you. Thank you all very much for the discussion. We'll come back, inshallah, after the lunch and prayer break at 1:10, please. Thank you.
انا قصير ما بين.
حتى هذول مو موجودين محاضرتك. اي لازم يجوا. انت اعطيتيهم هي. مم. قالت 1:10. 1:10. كلام كبير. ها؟ قاعد احمسك. بس اتكلم. يحتاج بس يضبط لنا المحاضرات. We should start خلاص.
Ready? طيب. Welcome everyone. It's always difficult to have a session after lunch, but we'll try to do it. I would like to, me and myself will moderate this, myself and my colleague, Dr. Abdulaziz Hamad, will moderate this session, which is the breast session. I would like to introduce Dr. Samahar Al-Ashram. She's going to give us a talk, the debate role of SBRT in oligometastasis breast cancer. So welcome, Dr. Samahar. The floor is yours.
Assalamu alaikum. Good afternoon, everyone. So, question about this topic has been raised already before the break. It seems they're interested enough. طيب, Bismillah. Oh. طيب. هو بيرجع باكورد. أنا عارفة. حفظت السلايدات؟ يا لهوي راجع باكورد. لا إذنك. طيب. As we all know, breast cancer is one of the most common frequently diagnosed cancer and leading cause of death in women. Up to 30% of all patients with initially diagnosed with early stage breast cancer, they develop distant relapse. And about 5% of all patients at time of diagnosis, they diagnosed with or present with de novo metastatic disease. Historically, there was a sharp cut between localized and widespread disease. And metastatic breast cancer was originally considered as incurable disease, and the treatment option was only considered palliative care. 30 years ago, Hellman and his colleague described an intermediate state that exists between local and widespread disease. In this state, this kind of disease can be targeted with ablative therapy, and they have high chance to cure. And in that time, oligometastatic disease was defined. A uniform definition of oligometastatic disease is lacking. The diagnosis is currently based on the number of metastatic lesions found in the images, typically 5 or less. Here we have two consensus guidelines, one published by the ISTRO-ASTRO and the other one by the ISTRO and RTC. So this is a very comprehensive guidelines that classify the different state of oligometastatic and oligoprogressive disease. And eventually this classification helped to identify the best treatment modality for each group. This conclusion was taken from the ISTRO-ASTRO recommendation, which showed that based on available data, oligometastatic disease can be defined as 1 to 5 metastatic lesion. More important that all metastatic sites must be safely treatable. Over the past decades, advances in treatment planning, images guidance, tracking, radiobiology rationale, all of that together have led to the implementation of SBRT. And SBRT become a valid option for oligometastatic patients. However, there are still concerns about which patient benefit the most from ablative treatment. The aim of MDT is different in oligometastatic setting versus in oligoprogression. In oligometastasis, we treat patients with MDT to prolong local control and potentially achieve cure. However, in oligoprogressive disease, the aim of treatment is to eradicate resistant disease and to prolong time on current chemotherapy or systemic therapy. So if you want to classify the metastases, I usually put them by site in intracranial versus extracranial. Regarding intracranial metastases, local therapies, surgery and radiosurgery, have previously demonstrated improvement in overall survival and local control of disease because most of the chemotherapies, they have low penetration through blood-brain barrier. and by default, MDT become the standard treatment of care. More recently, select molecular targeted therapies, mainly for patients with HER2-positive breast cancer, have reported the variable penetration into CNS, and thus they have ability to control disease within and CNS and extracranially. For extracranial metastases, we have a good number of observational and phase 2 studies involving multiple primary histology, and this studies showed excellent outcome with good disease control and survival with SBRT. This is only examples of some of the trials that have been published in SBRT for oligometastatic disease. As you can see, the benefits here listed either overall survival, progression-free survival. We have actually more trial in non-small cell lung cancer, prostate, colorectal, and the landmark trial, the Saro Comet, which included multiple or different primaries. Quick review on the Saro Comet trial. So this is a randomized phase 2 trial, including 99 patients with oligometastatic disease up to 5 lesions. Patients were randomized 2-to-1, either standard of care plus minus ADT. And it's important to mention that about 18% of the patients in this trial had breast cancer. So after 2 years of follow-up, there was significant improvement in overall survival and doubling time of progression-free survival with adding Saro. With the long-term follow-up, after 5 years, the positive result was possessed with a significant improvement in survival and median progression-free survival. But we have to keep in mind, on the other hand, we have a toxicity with about 4.5% of the patients, they develop grade 5 toxicity. Focusing on breast cancer, literature report controversial data. Many observational, single-arm, and retrospective studies showed benefit of SBRT in oligometastatic and oligoprogressive breast cancer, while randomized trial did not show any significant result. In this table, we have summary of the published trial. Some of them retrospective, prospective, they all show very good outcome with SBRT and oligometastatic breast cancer, with the excellent results regarding local control, progression-free survival, overall survival, and no grade 3 toxicity was found. The last 2 studies, those are the randomized trial, and unfortunately, both of them were negative, and we're gonna go over them. So the first randomized trial, NRG-BR002 trial, that enrolled patients with oligometastatic breast cancer with up to 4 lesions. It indicated that the patient, they have no progression on systemic therapy within the last 12 months. Stratification was based on the number of metastases, hormonal status, HER2, and the type of chemotherapy, and the same randomization, a standard of care with systemic therapy plus minus ADT. And 93% of the patients in the MDT arm, they receive SBRT. It's important also to notice that, to mention that about 70% of the patient, they have luminal disease. With the follow-up of 35 months, the trial was negative. It showed no statistical difference between both arms. The median progression-free survival was 23 months in standard of care and 19.5 months in ablative treatment. Similar 2-year progression-free survival and no difference in 3 years. For the second primary endpoint, the overall survival, again, there was no statistical difference. There was about 70% in both arms at 3 years. As expected, local control rate was very high, with the local failure about 6.7% in the MDT versus 30% in the standard of care. There was no grade 4 or 5 toxicity. Grade 3 was doubled with the systemic therapy. So they concluded that the addition of SBRT to standard of care did not show a signal of improved progression-free survival, overall survival in patients with oligometastatic disease. But we have to mention that it's notable that in the standard of care arm at this trial, they have the median progression-free survival was better than expected, comparing with the published studies. And the reason is most of the patients in the standard of care arm in this trial, they receive targeted molecular therapy compared to palliative systemic therapy in the other published studies. The second trial is the EXTEND trial. Again, same patient population with a small number of patients, 43 patients, and primary endpoint progression-free survival. randomized or standard of care plus minus ADT. Again, a negative trial, no improvement in progression-free survival with the follow-up of median follow-up of 2 years. Same thing for the secondary endpoint. There was no statistical significance in overall survival, time to change systemic therapy. And on the other hand, the MDT did not add any additional toxicity, and there was no local failure occurred at the MDT arm. So we just mentioned or discussed the trials published in oligometastatic disease. What about the oligoprogression? So patient with or multiple metastatic lesion, they may initially respond to chemotherapy. However, some of those lesions with time, they may get resistant to the chemotherapy and they may need to have intervention. So same questions over and over. Should we continue in the same therapy, switch to the second line, or add MDT or another kind of treatment? So we have two trials published in this regard for focusing on oligoprogressive breast cancer, randomized trial. The CURB trial. So the CURB trial, they included not only patients with breast cancer and non-small cell lung cancer with the same randomization. The primary endpoint was progression-free survival. So there was overall statistical significant improvement in the median progression-free survival in the patient enrolled in the trial. However, breast cancer patients, they did not have significant improvement with adding SBRT. Toxicity was acceptable for all groups. It's important that most of the patients in breast cancer patients in this trial, they had triple-negative disease. The second trial, AVATAR trial, again, a phase 2 trial for oligoprogressive breast cancer. All patients, they have luminal disease in this trial. Okay? So those patients were in aromatase inhibitor or anti-CDK4, and the hypothesis was SPRT to oligoprogression progressive lesion would delay change in systemic therapy by at least 6 months in more than 25% of the patient. The result of the study was positive. 47% of the patients remained free on the same treatment more than 6 months, and there was no grade 3 toxicity. So what are the major differences between the two trials that I just discussed in regard to oligoprogressive? One of the trial was negative and the other one was positive. So the main difference was in the tumor biology. The AVATAR trial, they included 100% of the patients with the exact same molecular subtype, luminal disease. The CURB trial have more or larger number of triple-negative disease. The second thing is the intervention with the MDT. The earlier we intervene with MDT, the better result. This is a very interesting review article published just a few months ago, talking about the treatment of oligometastatic breast cancer and patient selection. So in this table, they summarize the variable that can have an impact on the outcome for oligometastatic breast cancer. And this picture summarizes everything. So green is good, red is bad. Patient with chemotherapy naive, patient with bone site of metastasis, they have better outcome, of course, and patient with hormone receptor positive, they have a better outcome. Disease-free survival interval to time they develop the oligometastasis, the longer the better, and the cut-off point here is 24 months. Good performance status, smaller lesion, single lesion, all this together, those criteria provide better or more benefit to treating with SPRT. Several ongoing trials they're looking at the benefit of adding MDT to oligometastatic breast cancer. Some of them just already published and we discussed it, but we have so many trials coming. So in conclusion, oligometastatic disease is a spectrum of disease that include highly heterogeneous population of patients with different prognoses. From the literature, it's evident that SPRT could be favorable approach for metastatic breast cancer, but the best scenario for its application must be clarified. Current data show excellent results with local control and mixed results for progression-free survival and overall survival. Patient selection is a key. And this is very crucial to maximize the benefit of ablative treatment. Larger studies with homogeneous participant can identify the best patient for MDT. Survival of patients with metastatic breast cancer is continue to improve over time, and this is likely due to advances in systemic therapy. Thus, an important future direction for research would be carefully examine the utility of MDT in the era of more effective systemic therapy. Thank you.
Thank you very much, Dr. Samahar, for this interesting talk. We'll keep the question till the end of the session. It's my pleasure now to introduce Dr. Atlal Bousanad. It's attending professor at King Abdulaziz University, Medical Oncology. She will give us talk about the update and the systemic options, the treatment options for metastatic breast cancer.
Thank you very much. I'm truly pleased to see this manifestation of inclusion and empowerment. I would like to congratulate Dr. Majid Al-Ghamdi, my dear colleague, Dr. Rima Ajami, also on her promotion to associate professor, and the head of the organizing and scientific committee. You've done an amazing job, truly, and I'm very pleased to be here with you today. This is the disclosure. As you all know that when we face a patient with triple negative disease, we feel bad for ourselves and for the patient as well, especially when it's metastatic. As Dr. Samahar just mentioned, breast cancer is the most common malignancy in our country. And not only that, but also we see younger patients than what we saw in the Western countries during our trainings. Based on the hormone receptor status and HER2 status, we've been classifying traditionally breast cancer into 3 different or 4 different subtypes, but currently we have an emerging, let's say, designation because they say it's not a separate entity, it's just an extension of the spectrum of HER2 expression. We call it low HER2 or ultra low. That means a tumor expressing HER2, but not reaching up to the definition limit of overexpression or HER2/3. What we see in triple negative, at least 1/3 of those patients are HER2 low, and this is associated with significant therapeutic implication as we are discussing shortly. The triple negative breast cancer, although it is associated with poorer prognosis, it carries the ability to respond better to chemotherapy. I use this always to discuss it with my patient. I tell them, okay, you have an aggressive disease, but think of the other side, which is it's most likely to respond better to treatment. Triple negative, as we all know, has the worst prognosis among all the subtypes, including also the stages of breast cancer. It's usually, if recurs, goes back to the vital organs, liver, lung, unfortunately brain, less likely to the bones. What do we have right now in terms of guidelines? As you see here, not far away from chemotherapy. The chemotherapy is still embedded in the management of triple negative very much. If our patient is the expressor of BDL1, then we add BDL1 or immunotherapy inhibitor, BDL1 inhibitor or immunotherapy to chemotherapy. Germ BRCA mutation, germline specifically, we add PARP inhibitor if we don't need an urgent need to start chemotherapy. Then after progression, again, we will provide or offer chemotherapy. Not only that, but we have another option, which is sacituzumab govitecan, or as we have a nickname for it in oncology, we say SASI or SG, just to abbreviate the long name. This medication has moved from the second, third line into the front line, especially in the patients who has no pointer. Okay. Especially in the ones with metastatic triple negative that recurred within 6 to 12 months from adjuvant treatment or neoadjuvant treatment. It's a good medication, but as you see, again, accessibility, availability is an issue for us in medical oncology. So the algorithm still more or less the same. If your patient is BDL expressor, then you will use immunotherapy. You add it to chemotherapy. If it's BDL negative, you have to test for germline, BRCA. Positive, you consider olaparib unless there is an urgent need to start chemotherapy. If your patient has recurred within a very short period from receiving adjuvant or neoadjuvant treatment, you have the option of SG. Later on, of course, we have to introduce chemotherapy. This is the guideline as well from the NCC stating that SASI is a second-line chemotherapy or antibody drug conjugate that we use in metastatic triple-negative progressed on at least one or two chemotherapeutic agent. I'm sharing this with you. It's a very interesting case I saw in my clinic. She's an exceptional responder, which is a good news. She presented to my clinic when she was pregnant in 24 weeks. Unfortunately, she was told she has to abort the fetus, though at 24 weeks, you don't abort, you kill. But I told her we can save this. We can start with neoadjuvant chemotherapy, adriamycin, cyclophosphamide given while she was pregnant. She almost completed the pregnancy. We had planned delivery, and postpartum, we started carboplatin plus paclitaxel. She underwent modified radical mastectomy, and this typo is not my fault. It is the artificial intelligence fault, okay? So they're saying it's gonna replace us. I don't think so. Not gonna happen anytime soon. Anyway, after the completion of chemotherapy, she had adjuvant radiation. Of course, she had MRM to the chest wall and to the axilla. The tumor was sizable. She has a residual disease, so we initiated Xeloda or capecitabine after the adjuvant radiotherapy. Unfortunately, she recurred within only a period of 6 months. This story goes back to 2021, okay? We started her on another line of chemotherapy. She's been on gemcitabine, Halaven, which is erbiulin, and unfortunately, she keeps progressing. It is definitely chemotherapy refractory disease. And at that point, the SG approval came out, and I told her, okay, we have to try this because we've exhausted all our lines. And by the way, she's BRCA negative. I started the SASI, and to my surprise, after the second dose, these lesions you see in the skin completely disappeared, which is something remarkable. We don't see commonly, but this is definitely a success story. Why it's a success story? Because this patient recurred in the chest wall. Chest wall recurrence is extremely morbid. She's been already irradiated. She doesn't have metastasis anywhere, and she has a new baby she has to take care of. My patient is alive, well, in full remission. Role of antibody drug conjugate in managing breast cancer, as you've heard from my colleague earlier about TDXD, it's been a new formulation of medication that connecting antibody to chemotherapy, aiming for precise delivery of the treatment to the cancer cells. Right now, we have many of them already approved for clinical practice. The one we're discussing here is SG. We care about the payload. Interestingly, both of them has the a broad drug for SN38, which is irinotecan. TDXD is coupled to deroxitecan, and SG is coupled with govitecan, which is topoisomerase 1 inhibitor, causing DNA damage. SG is a TROP2 directed antibody drug conjugate. It targets a receptor that is called trophoblast receptor. Usually it is expressed in about 90% of triple negative breast cancer and in about 40 to 50% of hormone receptor positive breast cancer. The drug is delivered through the conjugation of the antibody to the corresponding receptor that will result in internalization of the antibody, release of the chemotherapy inside the tumor cell. Not only that, but also in the microenvironment resulting of what we call bystander effect. The trial that showed us how we use and how we apply this treatment in clinical trial is called ASCENT trial. And it included triple-negative patient, metastatic locally advanced, who had been on prior treatment, at least 2 lines of chemotherapy. And the primary endpoint was progression-free survival. Overall survival was assessed among other endpoints as secondary outcomes. It was compared against the treatment of physician choice, and the list is here. These are tools that we usually use: erblin, capecitabine, gemcitabine, and fenuralabine. There is nothing standing out from this table. Basically, the characteristics were balanced between the 2 arms of the trial. But here we see how beautifully the separation of curve in terms of progression-free survival and overall survival. And usually we see this in medical oncology, and we celebrate, especially with significant hazard ratio for progression-free survival, 0.4. It's definitely profound. Similarly for overall survival. And remember, those patients already, you can consider them heavily treated because they received at least 1 line to 2 lines of chemotherapy. All subgroups benefited, even the elderly one. If you look at the age group stratification, the ones who are at 65 or older also benefited from receiving SG. Quality of life improved as well when it's compared to the standard or treatment, the physician choice of chemotherapy. Side effect that we've been facing and managing in the clinic is not new to us. It's chemotherapy at the end. So we've been dealing with neutropenia. It's seen in up to 70% of the patient. We've been dealing with diarrhea. We've been dealing with fatigue, but all can be managed. The dose reduction was only in 20%. Dose delay occurred in considerable number of the patients, up to 63%. But it is not associated with interstitial pneumonitis as with the other ADC, trastuzumab deruxtecan. This is another very important point for us because we always ask our radiation oncologists, do I have to give radiotherapy? Can we delay it a bit? Can we do systemic therapy for brain metastasis? And the evidence says that the subgroup analysis of the patient who is with brain metastasis in the ASCENT trial benefited from the use of SG. Their progression-free survival was longer than the ones received the treatment physician chemotherapy. But I have to say that all were pre-treated and stable brain metastasis, okay? This is a very important point. The responses is as detailed here, mostly stabilizing the disease, and a few manifested partial response. Again, it's a numerical, it's an exploratory analysis, so you cannot have a solid conclusion, but it's just for exploration and basically later on perhaps designing a specified trial. There is a numerical improvement in the outcomes in the ones who received SG with brain metastasis. Likewise, for overall survival. How about real-world data supporting the use or the benefit, let's say not the use, but the benefit of SG in brain metastasis from breast cancer? There are multiple, but very small cohorts examining the application of SG in this subset of patients. And you see here, it has definitely an efficacy in patients with brain metastasis, but again, those who are either pre-treated or with stable disease. None of them has examined the ones with progressive disease. But again, benefit was seen in terms of progression-free survival and overall survival. It's mainly German, from Italy, and from France. So SG shows clinical activity in patients with brain metastasis and mostly stabilizing the disease, and some responses were reported as partial. Real-world data, as I showed you, confirms its beneficial use in this subset of patients. And we still need larger trials to confirm its efficacy to treat perhaps unstable or progressive brain metastases. Thank you very much for your listening.
Dr. Reem, how much time we have for discussion? Because you know it's موجودة Reem. How much time عشان بالدقيقة. I know we didn't start on time. We don't want to mix the program. 10 minutes? So we have 10 minutes for discussion. It's 1:50, so till 2 o'clock. Any question? Thank you so much for the talk. Any question? Nobody has question?
Just would like to know if what's the timing you would like to interfere with SBRT mainly? Is it at the time of diagnosis of oligometastasis or if this lesion sustained systemic therapy for a while? What's the better treatment, especially if the patient is asymptomatic?
So it's different from patient to patient. Usually, it's a matter of discussion. Every single patient with oligometastasis or oligoprogression, we discuss it at the tumor board. The impact from the medical oncologist is very important. So regarding the benefit of the chemotherapy or the systemic therapy, let's say. But usually, the earlier intervene with the MDT is better outcome, especially if those patients, they chemo naive, like they didn't receive any systemic therapy before, and they presented only with a single or few number of lesions, single 1 or 2 lesions, bone metastasis, let's say. So MDT is a very good option to treat, or this will give a chance to delay the time of starting chemotherapy.
Any questions? Yeah, please. So till they get the microphone, I would like to ask you a question, Prof. Atlal. Really, it's a wonderful case that you present. But a small question, quick question. Always we have a problem in pregnancy, breast cancer and pregnancy with the staging. And usually, you know, the metastatic chemotherapy is different than the radical chemotherapy, and you need to have this answer. What did you do with this case in particular? How do you know what's the staging of this patient with this?
Usually I do MRI. Yeah, I use MRI. And actually the literature tells you can do CT scan with abdominal shielding, especially for the chest. If the patient already passed the first trimester.
What about the body? How do you know the bone metastasis? You need a PET, you need a...
I tell you how. I do MRI diffusion, of course, in the private practice. Okay.
This is the problem we are facing mostly.
All right.
Okay. Any other question?
Yes, actually, my question is...
MRI diffusion, by the way, it's very accurate.
For
whole body. Yeah, whole body MRI diffusion, yes.
Thank you for the nice talks. My question is, Dr. Samar, about the SBRT in breast cancer. So recently, PET scan has been incorporated so much in breast cancer, even in initial staging. So are there any analysis or any data about incorporating PET scan, the result of PET scan in staging for breast cancer, about the results of SBRT?
Where the center they have PET scan, we usually recommend that those patients that go through the PET scan for better or for accurate information. They give us about the number of lesions, how active is the disease, but only when it's available. Asking about the, data that looking for this question in particular, from my knowledge, I don't know honestly if there is anything published in this regard. I don't know if anyone else know. If PET scan can exactly.
Assalamu alaikum. A question for Dr. Samahir. We have some prognostic scoring modalities to test, for example, for brain metastases, like the DSGPA and so on. Do you use something like that, like similar like that for extracranial oligometastasis disease? Because you said choosing the right patient is the key, but how do you use this key? Do you have a tool or something, or it's only discussion? Because today we are going to discuss a patient. Tomorrow we are going to discuss it with a different medical oncologist that have a different perspective. We are going to change the decision according to this discussion. So do you have a tool or a scoring system that you use?
Okay, so most of the trials that I discussed today, it was focused on the extracranial metastasis, right? So there are another trials for brain metastasis from different sites. Personally, I always send the patient with brain metastasis to my CNS colleague to treat those patients. Myself, I don't treat those patients.
No, I'm talking about the extracranial disease.
Extracranial, yes.
Do you have something similar to what we do with brain metastasis or not?
No, just if we want to follow a trial, we just look at the inclusion criteria of those patients, but we don't have something that exactly to follow. That's the patient age, the performance status, the number of systemic chemotherapy, the type of or submolecular type. It's very important because as just mentioned Dr. Prof. Atlal, there is some type of systemic therapy that across the brain barrier, like in triple negative and HER2 plus. But it's a matter of discussion. And again, it's just if we follow a trial, we just follow the exact selection criteria.
This is the issue with the trials because they are all negative. That's you don't have like a level 1 evidence to convince the medical oncologist that you have to pose the patient for systemic therapy to give him like an SBRT for 2 weeks or so on. So that's why I'm asking, because this is a discussion of every day.
You have your question means something. Dr. Atlal, can you help him? Do you go if you have oligometastasis outside the brain? The brain, I think we are all agree. If there are symptoms, you should treat. If not, you can give. If you have a treatment crossing the blood-brain barrier. But what about extra? I think he means something.
I don't know. Well, Zaid, what are you thinking? Because we've done this in the King Abdulaziz University many times for breast cancer patients. So he's, I think, trying to tease you.
Maybe he wants to see what's happening in National Guard.
In some other hospitals, they don't believe in treating stage 4 cases. They believe, medical oncology, they believe once it is a stage 4, it is a systemic disease. There is no benefit of chasing the oligometastasis or whatever. Lymph node, bone metastasis, whatever, unless it is symptomatic. I'm talking about PFS or local control. And this is an everyday struggle that I face, not in King Abdulaziz University.
I believe that most of the medical oncologists, they're aware now of the rule and the effectiveness of SBRT. And I'm lucky enough that the medical oncologists in my center, mashallah, they sometimes they present the cases and they offer like a discussion about SBRT. But the awareness about this kind of treatment, mashallah, is good.
I think there is no, yani, as Dr. Noha Justania mentioned, there is no strong evidence comparing systemic therapy to local intervention. But again, whatever you can do to delay the use of chemotherapy or give a better quality, or as we say in medical oncology, we squeeze the chemotherapy or whatever agent you're using to the maximum. That's our strategy usually. Because you don't know if the other line is going to work or not.
She's believing that breast cancer, the
is a systemic disease.
Yeah, she thinks that it's a systemic disease. You're going to delay for nothing.
Ultimately, I think it has to be individualized and the discussion has to be addressed specifically per patient.
Yes. So we have a time for one more question. Any questions? Or we can conclude? I think everybody is satisfied. Thank you so much for all of you.
Assalamu alaikum wa rahmatullah. We will start now with the industry symposium, and it's my pleasure to invite to the podium my friend Professor Thierry Givart, who is a professor of medical physics at the Vrije University of Brussels. And he is the head of department at UZ Brussels Cancer Center, the head of medical physics department, and he is overseeing one of the most impressive technical platform in Europe and involved in many research projects. Specifically, he is very involved in image guidance, in MR-guided radiotherapy, and very recently, and I congratulate him for that, in flash therapy also. He will talk to us today about the role of image-guided radiotherapy in, about surface-guided radiotherapy in breast cancer. The floor is yours.
Thank you for the introduction. I'm very pleased to be here to present a little bit our data regarding what we do in Brussels. So I was asked to speak a little bit about breast cancer and about surface guidance. Yeah, in my opinion, when you look into literature, you have surface guidance, but a lot of publications and like also recommendations are showing that you also need to have IGRT. So image guidance is also important. So I believe that you need to have a combination of the two in order to be able to go to a certain strategy in order to treat your patients. And when you also look about data and about the survey in Europe, you see that most of the centers, they use surface guidance, but in combination with image guidance. So you could go to surface guidance, but yeah, as I was already introduced, we do a lot of imaging into our department. So I believe that, as you can see over here, most of the time, there is also image guidance that is important. And the goal in our department is really to deliver patient individualized treatment. So we try to implement the most modern techniques and also look about biological concepts. And to achieve this, we look about positioning accuracy, motion management, and also we try to always use the smallest PTV margin. So we aim, together with my head of department, we aim to look into the margins and to reduce them. And for that, we have a kind of dedicated machine park. So we have 2 true beams with Exatrack Dynamic for surface guidance and image guidance. We have a Radixact, a Halcyon, and an MR-Linac. And so everything which is brain, spine, and thoracical region, we try to do on our true beams. Everything abdominal, we try to tackle with an MR-Linac. And recently, as it was already introduced, we also will look now into flash radiotherapy because our objective is really to implement the most modern and dedicated techniques. When we think about surface guidance, yeah, what is sold and what the vendors are trying to say is that you want to avoid radiation dose and you're accurate to position. So I believe that you will improve your accuracy in terms of positioning and so on. You can correct the posture, so the camera will see and will adapt regarding to what you want to, how you want to position your patient. And I think the most important one is the emotional burden of our patients, so that you don't need tattoo points, you don't need all those kind of points. You just lay the patient on the couch and you can position the patient accurately. So I believe that's really the strong point, is for our patients, that you don't have that kind of emotional burden anymore. But for the RTTs and the nurses on the machine, I think it's really important. It's really difficult because it's a paradigm shift. They are used to use tattoo points in our department. For them, it was like, okay, now I just need to look about the camera and the camera will tell me how to do. So that's, I think, the most difficult to implement. And then for breast and so on, I think you can, as it's already on the surface, it's a good surrogate to position your patient. When you go to abdominal cases and pelvis case, I think that there you have a reduced accuracy of surface guidance. So therefore, sure, you need to combine it with image guidance. And then the most important one is when you think about all kind of surface guidance technique on the market, it's really the reduction of positioning time. So it's more easy and adequate to position your patient prior to treatment. And so as you reduce the time, we all know that a reduction of time will also be dedicated with a reduction of PTV margin. So the faster you go, the less chance your patient will start to move. So I think there is a clear benefit in pre-positioning purposes to go for those kind of surface guidance solutions. But the question is then, of course, and that's something, yeah, it's up to you also, the philosophical question into your department is how do you cope with surface guidance and image guidance? So a lot of centers, they have a cone-beam CT, for example. So when you look into literature, some are saying like, okay, I'm accurate with my surface guidance. So if I start to do less CBCTs, I will maintain the same accuracy than when I didn't have my surface guidance solution. The only problem with that is that you will again need to readapt your margins. So for me, but that's my opinion in Brussels, of course, and our philosophy, as we have more accuracy with surface guidance, we maintain the image guidance solution. So it's the two of the best worlds. So we can reduce the margins and we can again go to a more aggressive treatment strategy with less fractions and a higher dose. So that's my opinion. So when you look into literature, it's important to say what they do. If you go to less image guidance, they will adapt the margins accordingly, and that's maybe not where you want to end up. And so that's why, again, some other literature, and that's where we found ourselves in, is that we combine surface guidance together with image guidance. And for example, for breast cancer, we could increase the accuracy and we could state that we are within 2 millimeters, we will accurately position and treat our patients. So that's a bit a thing that you need to think into your department. So you can go to a surface guidance only solution. Yeah, we have Exatrack Dynamic, but you can also go for a strategy where you add also the image guidance. And so that's a bit what we do. We have already 20 years of experience with BrainLab. We are a beta center to implement new technologies and strategies with them. So that's a bit where we believe it's for us the right step to do. And so you can also go for surface only. So patients where we only want to use cone-beam CT and so on, we can go for surface guidance. For example, for brains, we like to adapt as we treat multiple brain mets. We like to do non-coplanar solutions. And so there, yeah, what is happening is that on the right, you see the surface guidance, and on the left, you will see directly that we also take image guidance during the treatment. And so why do I show that? It's just the same story. So we cope with the accuracy of the surface guidance together with image guidance. And we recently published into literature in the Green Journal that we can go again to a 0 millimeter margin strategy. So as I said, we try to have dedicated machines. And in my opinion, our opinion, into our department is that we can go to a same solution like a gamma knife solution because we have the accuracy to go to 0 millimeter strategy like the neurosurgeons wants to do. And the same for spine. So dedicated treatments where you want to spare the spinal cord. Well, again, we like to combine surface guidance together with image guidance in order that we see what we treat. For breast cancer, there, yeah, my head of department, Professor De Ridder, published quite a lot about toxicity and so on. So we try to look about the balance between what we want to give to the breast and how we can avoid long-term events. And for that, yeah, we all know that there is a risk of lung cancer according to the estimated radiation dose, and there is also a linear effect between the mean heart dose and the cardiotoxicity. And we published also something regarding this. So we look not only about the mean heart dose and so on, but we also look about the smoking status, the age, and so on. And then we look about the dose that we will deliver to the heart. And from there, we will try to see whether or not there will be a mortality. The same we also published for lungs. So again, we not only look about the mean lung dose, but we also look about other historical things about our patients. And in order with that, we stratify whether or not we accept the dose that we want to deliver to the lungs. And so therefore, again, as I said, the full story of our department is really to look about patient-tailored treatments. Here, the case is to prevent the cardiovascular mortality. And so we want to go to individualized prescriptions. And then, of course, we evaluate also new techniques. And there in our department, that's where Exatrack Dynamic came into the picture, because you can combine surface guidance, image guidance, and you can go for deep inspiration breaths. And as we all know that, again, we ask the patients to do breaths. So the longer and the more they do breaths, because we go to a 5-fraction course. So we deliver 25, 31 gray in 5 fractions to our patients. So it's a higher dose. So the patient is laying down longer on the couch. So it means that they will need to perform more breath holds. So again, the more breath holds they perform, the more they will start to move because of the fact that it's time consuming. And so there, yeah, we installed it in 2021 and we looked about the benefits of applying it. So first of all, the only thing regarding purely dosimetry, as a physicist, what I need to do is just I need to have a contour of the free breathing and a contour of the breath hold. And from there, you see the purple and the yellow one. The system will calculate how deep my patient needs to perform the breath hold in order to reproduce what we were performing at the time of the treatment. Prepositioning wise, as I mentioned, it's a surface guidance solution. They show that you can use it in order to preposition your patient and to align it correctly with regard to your planning city. And then the nice thing is then second step is then that that you will go for a point. So you can place that point whenever you want on the patient and he will calculate directly the breathing pattern of your patients. And from there, then we ask the patient to perform the breath hold on the left, and then we acquire the X-rays. And from there, once you have the X-rays, you can align it. So you can use contours like the lungs and the heart in order to see whether or not you are on the thoracic wall. Or you can also ask an image registration with respect to the bony anatomy. And I think for centers that are using APIT imaging for breast cancer to make the positioning, that's something in our situation, it was the case, of course. When you see this and you know that an APIT looks like that, I believe that once you have this in your department, you will be more accurate because it's not only a 3D evaluation, but you have a 6D evaluation of your patient positioning. So you can see whether or not you are well aligned. So it looks like an APIT, but you have 6 degrees of freedom information. So you can also correct for rotations, not only translations. As we perform and align and we perform integrated boost, I think this is important also to correct for rotations in order that we can go for a good treatment. So I think for the ones that use APITs, that's something a next step to be more accurate. And in our institutions, as we like image guides, we'll also like to have co-beam CTs. So we were also imagining like, is the right one the way to go, or do we still need the volumetric imaging? So again, we ask the patients to perform breath holds. And regarding residual errors, you see left, right, you see that whether you use Exatrack, so X-ray images or the CBCT, you see that the error is exactly the same. So we make now the step that we do X-ray images on a daily basis and every week on a weekly basis for the 15 fractions and for the 5 fractions on a daily basis. We also use a co-beam CT just to see if the breast is not swelling and so on. So that's a bit the concept that we had in mind. But we know that we are accurate. So that's also a next step for you if you want to go for that, is that, the Exatrack can also replace sometimes the co-beam CT. And then the best thing of the whole story about what we do in Brussels, I think for breast cancer is, as I said, we have the 2 contours that we are using at the time of the planning. And so it will reproduce it all the time once you ask your patient to perform a breath hold because he knows the amplitude. And on the right, you can see that with our Exatrack system, the stability of reproducing every time a breath hold is very stable. We also use the RGSC. I have nothing against RGSC, but we saw that there is more amplitudes and more uncertainties because of the fact that you will just use a respiratory block. So I believe that with that kind of technology, you are more stable. And what does it mean for our patients, of course? Well, on the left, you have the planning, how we want to avoid the heart with the breath hold. If the patient is not reproducing well the breath hold, you see that the dose can be delivered to the heart. So that's why I think stability-wise, it's a nice feature to have. And so that's a bit how we want to go into our department with that. And then during the treatment, what is happening is that we ask the patient to perform the breath hold. On the right, you see the surface guidance, and on the left, you will see that we can take imaging. And so you can directly see whether or not the patient is well aligned or not. So that's a bit our strategy. And again, as we use integrated boosts and so on, we want to reduce our PTV margins. And that's why I think that's our way or our vision, how we want to go and to move forward. And then as a next step, just to show you a little bit and to trigger you also that we do also some other nice stuff in Brussels than only breast cancer, for example. So we are now looking together with them as we are a research center for them. So about lungs, what can we do and how can we treat? And so what we are doing is that we are looking about a 4D CT about the motion of the lung. The physician is drawing the lung tumor, and on the right you see the DRR of that lung tumor. And from there we try to understand how the lesion is moving and which surrogates we can use into the lungs. And so we look about bronchi and so on to use as surrogates. And from there, that's something that we are doing a prospective study on that right now. And so from there, what we do is we try to align the bronchi and so on within the X-rays. So you can have more information or less information. And from there, we align in this way, and then we check whether or not with 4D CT, we can go for something next. So that's a bit the idea. And so what we do right now into our institution is really to look until where the limits are with Exatrack Dynamic. And so the idea is now that we are treating our lung lesions not only with a CBCT, but we are also using the X-ray images, as you can see on the right. So you can take X-ray images during your treatment, and in this way you can visualize intrafractionally also if the patient is not drifting and so on. So this is the next step. This is a bit in progress what we are doing. And so that's the journey that we do. As I said, brain, spine, lungs, and breast, that's something that we do with Exatrack. And so I think surface guidance, it's efficient. You can go for a tattoo-free positioning. You can correct for the posture. But in my opinion, you also need to look whether or not image guidance is needed. And again, as we want to reduce the PTV margin and so on, for us, we try to combine the two in order to have the best of the two worlds. And for Exatrack Dynamic, you could also use it for prostate, but we have an MR Linac. So I think for brain, spine, breast, lungs, there is something to do with that kind of technology. But again, for me, the most important, the key conclusion that I want to make today is surface guidance is nice. Every vendor is giving to you, but you have to look about what you want to do into your department and how you want to treat our patients. Our philosophy is really to reduce PTV margins, to go to less fractions and higher up the dose. And that's why we want to combine the two. If you want to do another strategy, it's up to you, but keep in mind that surface guidance, it's not enough if you want to go for some kind of SBRT technique or so on. So I thank you for your attention. And yeah, Professor Dreder and myself, if you would like to come or something else, you can always join to me, and you are more than welcome in Brussels. I thank you for your attention.
Thank you, Professor Gerhard. We can take one or two questions if you have questions. Yes, there, please.
Thank you for the nice presentation. One question, are you like now practicing tattoo-free for the breast and for all other sites, or just for the breast? Just want to make sure.
Yeah, for all sites.
For all sites?
Yeah. We started directly for all sites. We did a comparison with our RTTs, and they adopted for all sites. Yes, we don't use tattoo points anymore.
Thank you.
You're welcome.
Thank you, Professor, for the great presentation. Did you look at the time used for positioning while using the surface-guided plus X-ray versus one technique? Did you look into this?
And what was the last surface guidance with?
Time.
Yeah, time between. So yeah, I looked at time. So when we make the switch from surface guidance and RGRT and no tattoo points anymore, we gain that 3 minutes. About imaging, it will depend on what you do. Like brain and spine, I'm sure we are faster than any kind of other strategy. For breast cancer, sometimes it can take more time because you need to look about the imaging. So for breast cancer, I would say sometimes you are less fast than a CBCT because of it's more difficult to find the right position. So for breast, I would say it's more or less the same or a bit longer. For brain and spine, I know that I will be faster.
And the learning curve for the RTTs, how was it?
That's I don't know who's talking, but it's a very good question. The learning curve is that it depends. You have two situations. In our situation, we were using brain and spine already a long time into our department. So they were used already for those X-rays. So the learning curve was quite fast. It's just to look about thoracic wall and so on. If you start from scratch, it takes a little bit more time. What we do into our institution, we do academies in order to, people worldwide, like people also from US and so on, they come to us for 1 week and they are trained together with our TTs to see and to learn how to use the system. So I think the learning curve would be 2-3 weeks in order to really understand and to adopt the technology. That's what we hear from other centers.
Hello. We treat a lot of breast patients, but due to the nature of the culture here, it's very difficult for us to adapt surface guided. And because the nature of that technology means the patient has to be fully exposed during the entire treatment. They're very modest, most of our patients. So even just setting them up with the tattoos, they're very reluctant to expose themselves. With this treatment that has thermal imaging, does that mean we can cover them with a sheet and still have no tattoos and still have good treatment setup?
It's against to say it because I know they don't like to hear it. But if you ask a patient to have to have a T-shirt, but that is quite close to the skin or something like that, you could use it. It's against what companies will tell you, but sometimes into our department, we have patients that don't like it, but to put something on the patient, that's not working quite well for surface guidance. But like a T-shirt that is quite close to the skin, you could use it and it will recognize it, yes.
What about the thermal imaging aspect of it? The thermal imaging.
The thermal imaging, it will also work. Yeah. The thermal, it's no problem. It's the thermal is purely on the temperature of your patient. So if you ask to put a T-shirt or something like that, the thermal imaging will work. Yeah, we do that sometimes into the institution.
Okay, thank you very much, Professor Givart, and pleasure to have you again in Saudi Arabia. Thank you.
Thank you to the speaker and moderator of this Enlightenment Symposium. We'll move to the next session. So it's a GI Astro endorsed session. I will like to invite the chairperson for this session, Dr. Abdullah Saibani. He's a radiation oncologist, consultant radiation oncology at King Saud University, and myself and Dr. Ihab al-Naquri. He's a consultant also radiation oncology. I think Dr. Abdullah will start with the first.
Okay, thank you. So it's my pleasure to introduce our first speaker, Prof. Tamer Rafat. Prof. Tamer is the Director of Clinical Research and Director of Adaptive Radiation Therapy and IURT Program, lead of the GI and Breast Radiation Oncology Program at Loyola University Medical Center at the state. He will talk to us about evolving role of radiation therapy in pancreatic cancer.
Good afternoon, everybody. Assalamu alaikum. Thank you very much for the invitation. I will try to cover the radiation for pancreas cancer in 15 minutes, which is almost impossible. I will try to explain why radiation will be helpful in different scenarios in pancreas cancer. Okay. So pancreas cancer is a highly lethal malignancy. It is the third leading cause of cancer deaths in the US and fourth in Europe. We assume that surgical resection is the main potentially curable treatment, which is, I believe, is correct. Only 15 to 20% of patients with pancreas cancer would be candidate for surgery upfront. Most patients will be either borderline resectable or unfortunately locally advanced. Distant metastases happen in more than 70% of patients, but still local progression is a problem. In an intriguing study from Johns Hopkins, there was like 30% of patients with locally advanced pancreas cancer did not develop any distant metastasis. They died from local progression, and it is a tragic end-of-life situation. Most of the pattern of failure studies showing at least 50 to 60% of local progression in pancreas cancer. I'm going to divide my presentation for resectable, borderline resectable, and then locally advanced and metastatic. In this NCDB analysis, as you may see here, 1, 3, and 5-year overall survival were significantly correlated with achieving R0 resection in pancreas cancer, which is negative surgical margin after surgery. R1 resection was a surrogate for poor survival, regardless of the stage or receipt of adjuvant therapy. Neoadjuvant chemotherapy and treatment at academic centers also is important. Our very own Dr. Bill Small ran this study back in the early 2000s, phase 2 feasibility study for neoadjuvant chemoradiation with concurrent gemcitabine. The whole purpose was like, are we able to safely deliver radiation, 36 gray in 15 fractions? The brief outcomes that it was acceptable with reasonable outcomes. In a meta-analysis, neoadjuvant therapy is trending. It is beneficial. Median overall survival by intent to treat was 18 months for any neoadjuvant chemotherapy compared to 14.8 in upfront surgery. Difference was larger in patients who actually had surgery, and R0 resection was higher. So is node-positive disease. Now, there are many studies exploring the neoadjuvant therapy, either chemotherapy or chemotherapy followed by chemoradiation. That's a summary of them. We are achieving great results now with systemic therapy, which I believe pancreas cancer is a systemic disease as well. It is unheard of having a median survival of more than 50 months in the PRODUCE study, which increased the importance and the value of local control. Local progression has consequences, and unlike any other tumor site, I cannot quote any other tumor site when you would expect an incidence of R1 resection of more than 40 or 60% in modern era. Like you take the patient to surgery and you expect 1 in 2 will come back with positive margin. Pre-OPANC study was the preoperative chemoradiation versus immediate surgery for resectable, borderline resectable pancreas cancer. They adopted the protocol of Dr. Small, so either upfront surgery or upfront gemcitabine, gem radiation, 36 gray 15 fraction, only the tumor, and then surgery followed by adjuvant gemcitabine. It was for resectable and borderline resectable pancreas cancer. It ran between 2013 and 2017, a number of centers. The initial report back in 2020, there was no overall survival benefit. There was actually improved disease-free survival, local control, TNI, LVI, lymph nodes. In the long-term follow-up, actually, there was a median overall survival, statistically significant benefit for neoadjuvant concurrent chemoradiation compared to upfront surgery. The effect of neoadjuvant chemoradiation was consistent across pre-specified groups, including resectable, borderline resectable pancreatic cancer, with a median follow-up of 59 months. That led to pre-OPANC2, which was FOLFIRINOX, which we know is a better chemotherapy than gemcitabine in pancreas cancer, compared to the winning arm of pre-OPANC1. The initial thought when I looked at these randomizations that it's not fair, right? Like comparing gemcitabine and ancient, we know it doesn't work great, to FOLFIRINOX, and expecting that radiation would make the miracle. I expected a negative result. However, the study ran between 2018 and 2021, 375 patients with a median follow-up of 41 months. Resection rates was 77% in the FOLFIRINOX arm, 75% in the chemoradiation arm, with a comparable side effects. And as you can see here, there was no difference in overall survival, 1, 2, or 3 years. So the question would be, if we used better chemotherapy, like FOLFIRINOX with neoadjuvant radiation, would we improve the R1 resection, higher likelihood of R0 resection and outcomes? Now, in the adjuvant setting, moving from neoadjuvant to adjuvant setting, we just had the results of RTOG 0848. We're waiting for the report, should be coming soon. The study was a double randomization. The initial randomization was comparing GEM to GEM plus erlotinib, which was closed early after knowing that it's not going to work. But they continued with the radiation arm. It is a very well-designed study. They accounted for all the surrogates for bad prognostic factors, nodal status, CA 19.9, surgical margins, adjuvant systemic therapy. The randomization was gemcitabine and then radiation, no radiation, the adjuvant setting. You cannot argue with these curves in the node negative. So there was clear survival benefit for actually the group of patients that historically we did not offer radiation. So those are the node negative patients after resection and completion of chemotherapy without evidence of progression. As you can see here, the median overall survival was 3 years in chemotherapy arm compared to 3.9 years, almost 4 years in the chemoradiation. Same was for progression-free survival or disease-free survival, 47% to 19%, statistically significant. There was no survival benefit in the node-positive disease, but remember, all of those patients received gemcitabine. Toward the end of the study, the authors allowed the use of FOLFIRINOX, but none of these patients received FOLFIRINOX. So again, it brings the question, with a better chemotherapy now, FOLFIRINOX, and then we in the adjuvant setting, and then we assess, and there is no evidence of disease, should we still offer chemoradiation, the node positive disease, knowing that they're gonna have better systemic control compared to the historical gemcitabine? The conclusion of the study that the addition of radiation and 5-fluorouracil in the adjuvant setting did not increase the grade 4 or 5 toxicity, did not improve overall survival for all patients. It did improve survival for node negative patients. So we know that modern chemotherapy now resulted in unprecedented outcomes with a median overall survival more than 50 months. And we believe that we should always get the patient for an R0 resection and get them to surgery as soon as we can. We should not delay or interrupt systemic therapy based on the alliance studies, which I did not include for the interest of time here. And N0 patients had most benefits of addition of radiation therapy. For the interest of time, I'm not going to go through this, but there is some evidence for intraoperative electron radiation therapy in pancreas cancer from Italy and Japan, showing possible survival benefit, actually, and definite local control benefit. In our institution, we have a phase 1 IRT study. So patients who would undergo neoadjuvant chemotherapy only or upfront surgery, they would receive IRT, intraoperative radiation, 10, 15, or 20 gray. It's a dose escalation study. You are now in the 20 gray arm, actually. And then risk stratified adjuvant radiation therapy after. So if they are to come back with positive margin, so that's my information. So we basically aim at the area around the celiac and the superior mesenteric, with which is the highest risk area usually for positive margin, plus the stump if we feel the need for the stump. We wait for a negative surgical margin frozen section first, and then we do the treatment, and then we risk stratify after. So radiation therapy rationale in the early and borderline resectable. Systemic therapy improved outcomes. R1 resection limits the progress. Local recurrence remains a problem. Radiation therapy improved local control, increased likelihood of R0 resection, likely improved quality of life. timing and dose of radiation therapy is still to be optimized. We should not interrupt neoadjuvant chemotherapy for the sake of radiation. We know that. And IRT could be an opportunity. Now, what about the locally advanced pancreas cancer? Historically, we used many like single institution data with like 50.4 gray, which did not really work great in this setting. There is data from MD Anderson about dose escalation, and that if we are able to escalate the dose safely with a BED more than 70 grays, that resulted in improved overall survival in a multivariate analysis, given the limitation of a retrospective report. Many institutions tried SPRT as well. With MRI guidance, there is like reassuring reports. You have to be careful when you do SPRT in locally advanced pancreas cancer. When we started, we treated only the tumor, and there was significant regional recurrence around the celiac and superior mesenteric nodal areas. So now I do an elective nodal volume as well. So usually if I have the MRI guided technology, I would do 50 gray in 5 fraction to the tumor, 35 gray to the elective nodal volume, including the celiac and superior mesenteric. Dose escalation without MRI guidance is challenging. Setup uncertainty, nearby organs at risk, respiratory motion, interfraction motion. And I'm not going to go through this for the interest of time, but as you can see here, you clearly can see if you can afford the technology, and if we are able to do daily adaptive treatments, which we used to do when we had the Puree machine, you can see here, actually, sometimes you are able to spare organ at risk. Sometimes actually you are able to dose escalate. Like in the prior case, there was a loop that is over of the bowel here that was overlapping with the target volume. And then as we go through here, if you don't see the constrained organ anymore, or you can adjust for the change in anatomy. As you can see, here's the difference between the stomach and again, you can spare the stomach. The way of MRI guidance is that you run a plan based on the initial anatomy, and then another plan based on today's anatomy, and then you optimize to meet your constraints. And you can get, so it beam on and beam off of it, as if you are able to see in the bottom here, beam on and beam off based on if the tumor is the target or not. Now, and there was data from our colleagues, Dr. Parag Parikh, SMART study, 50 gray in 5 fraction, with very reasonable outcomes. Again, we don't have time, but it shows that it is visible and safe to deliver ablative radiation therapy with SMART across a variety of practice settings. With a follow-up, now they are planning SMART 2, which is, or lab ablate, which is for locally advanced only, not borderline resectable, finishing for FOLFIRINOX and then randomizing to ablative 50 gray in 5 fraction. In the metastatic setting, metastasis-directed therapy is trending. I am the PI of an institutional phase 2 study, up to 5 METs after completion of systemic therapy. It mimics the EXTEND study that was published with very assuring outcomes. There is also the role for palliation in celiac plexus radiosurgery for pain that was presented in an Astro plenary a couple of years ago. So what do we do in our institution? In resectable and pancreatic cancer, adjuvant radiation therapy to node-negative disease showed survival benefit. Adjuvant radiation therapy to node-negative disease definitely showed local control. I believe with the use of FOLFIRINOX, it would likely translate to survival benefit, but that is based on no evidence. Investigational is the IRT studies that we have, and then risk-adapted adjuvant radiation therapy after. In the borderline resectable pancreatic cancer, total neoadjuvant therapy with FOLFIRINOX or gemabraxane followed by chemoradiation per the PREOPANC, modified PREOPANC because they use gemcitabine. And in the locally advanced, dose escalation really matter. If you're not able to do 50 and 5, we use 67.5 and 15 fractions sometimes. In the oligometastatic pancreas cancer, systemic therapy followed by SPRT to the metastatic sites and palliation work. And with that, exactly on time. Thank you very much.
Thank you, Prof. Tamer. for your presentation. Excellent presentation, excellent overview about the pancreatic cancer. We'll leave the question to the end. We'll move to the next lecture or next speaker is Dr. Ali Husni. He's a well-known radiation oncologist. He's an associated professor and staff radiation oncologist at Princess Margaret Cancer Center in Toronto, Canada. And he will give us an update about the role of radiotherapy for liver malignancy. Dr. Ali.
Assalamu alaikum. Thanks so much for the invitation and being part of this great meeting in Saudi Arabia. Okay, here's my disclosure. And my outline today is mainly about three main parts. The first is the evidence of SPRT for liver cancer and some technical advances for liver SPRT and moving from challenges to the future directions. So liver cancer, primarily today, about HCC as a primary disease and liver mets as metastatic disease. So HCC accounts for probably around 80 to 90% of primary liver cancer. It's the fifth most common cancer worldwide and the third most common cause of global cancer-related death. It's a bad disease. The management approach depends mainly on the extent of the disease in the liver and outside the liver function, and the status of the patient itself. And the only curative way and treatment is to do liver transplant, but we know it's definitely challenging with the long waiting time. If the liver transplant is not applicable, then we try to find a way for local therapy, either RFA and TACE, but there is a lot of technical problem with that. And probably if the tumor is large or extending beyond the liver or having a vascular invasion, we are stuck with low evidence of local management. Is SPRT the solution? It has a very promising local control for liver cancer. So in a meta-analysis of more than 30 studies, around 2,000 patients, the 1 year local control after SPRT with 86%. This is definitely a promising number. What's more interesting that at 2 and 3 years, the numbers are almost maintained, 84%. The overall survival is a different story because patient may die from the liver disease itself, 73, 58, and 48%. What's also more interesting, with more advanced in technology and radiation treatment, the chance of grade 3 plus toxicity at the liver or the GI toxicity is definitely less than 5%. So did we compare SPRT with other local therapies? Yes, there was a phase 3 randomized control trial that compared SPRT or proton therapy with RFA. They did not expect that SPRT will be good, so the design for the study was actually non-inferiority. And what happened that the SPRT was better than proton better than RFA, but we cannot say that because the design of the study was actually non-inferiorities. The difference was around 10% on local control. So there was a meta-analysis of 4 studies that compared SPRT versus TACE for HCC, and all of them favor SPRT for local control. Patients who are not eligible for TACE and RFA, SPRT with TKI, sorafenib at that point versus TKI, the RTUH1112, led by Laura Dawson, and I was lucky to be part of this trial, was presented a couple of years at Astro and Best of GI, and the paper was just published in December last year and showed improvement in overall survival when you add SPRT to sorafenib. So it's not only about the local control, SPRT for HCC is translated to have a survival benefit. Liver mets is a little bit different story because almost half of the patient with a solid tumor will have liver mets. This could be from colorectal, pancreas, stomach, esophagus, melanoma. And as we know, the main treatment is mainly systemic therapy. However, with more evidence for local therapy for oligomets, SPRT showed up. So does it provide, again, a promising local control? Probably. There is a meta-analysis of more than 30 studies, around 3,000 patients. The 1 year local control is quite similar to HCC, around 85. But you can see the decline at the 2nd and 3rd year by almost 10%. Again, the overall grade 3 plus toxicity was not very high. There's a meta-analysis also compared SPRT versus RFA for liver mets, and we found the pooled 2 year local control is 60% of RFA versus more than 80% for SPRT. So even if RFA is more successful, we usually see that in the HCC but not METS scenarios. So let's move a little bit forward. Why SPRT is working well? SPRT is working well because there was almost 20 years of technical advances that happened since 1990s, starting with better target and organ at risk identification. When we obtain the high quality CT, obtain the multi-phasic and multi-parametric MRI, and more functional imaging like PET scan, SPECT, diffusion MRI, DCI, IVIM, whatever. And also we had better motion management because the lesions is moving up and down, but we had the ABC, we had the gating, we have the tracking, and we have a 4D CT with abdominal compression to minimize the motion impact on the outcomes. And also the advanced treatment planning and delivery with IMRT, VMAT, the IGRT using 4D cone beam CT, and the IGRT with photoshields. And most interestingly, the adaptive radiation treatment, which could be offline, online, and inline. Offline means that you are doing the plan of radiation treatment. The patient had a delivery, the radiation occurs in his office, in her office, and see what's happening between the sessions. Online, the patient, before each session of the radiation treatment, you re-contour, re-edit the organs at risk and the targets and make sure that you're hitting the right spot every time. And even inline, while the beam is on, but you notice that there's some sort of breathing issues with the patient. The patient has some sort of a little bit of movement. Then you hold on, stop the treatment, replan. So this is very precise. So, and I'll give you a little bit of example of a couple of my patients who were treated with radiation treatment and how it could happen like 10 years ago versus now. A patient with a liver lesion here, and ideally I do the CT and MRSM, and if you go to the usual machine, you can find this ugly cone beam CT. But with adaptive, if you have an MR guided approach, you can easily see the lesion just prior each session of the radiation treatment. And you can even track the tumor while you are giving the radiation treatment. Or you can use it with the CT adaptive. On the right side, you can see how the lesion, you can delineate it easily using the Ethos machine and easily re-edit the contours, the organs at risk, plan optimization, plan evaluation, then radiation delivery. So it looks very promising. Why not every single patient are being treated with radiation for liver cancer? So the biggest challenge with HCC is different from the liver met. For HCC, we always worried about that the liver function itself is not good. So I cannot easily give radiation treatment for patient with a poor liver function. For liver met, it's actually the problem that we cannot give high dose of radiation most of the time because the tumor may be close to the luminous structures. And I want you to have a deep look to this slide. Remember that I told you for HCC, the 1 year local control was around 86% and it's maintained at year 2 and year 3. For liver met, it's not like that. And the question is, the higher dose always the right answer for SPRT for liver cancer? There's a meta-analysis that showed that actually the BED doesn't impact the control for HCC, but have a big impact for the liver mets. The difference probably around 30%, from 90 to 60%. So let's return one step back and speak a little bit about the HCC. Now, for example, at Princess Margaret, we published our experience a while ago for treating patients with child B7 and P8. And we found that among the 29 patients, despite we were very cautious, giving very low dose of radiation treatment, the change in the child score by 2 or more points at 3 months is 63%. Almost 2/3 of the patient will have a problem with liver function after the radiation treatment. And we updated our results using A6 and B7, and we found that the change in the child score by 2 or more points at 3 months is around half of the patient if they are B6 and B7, compared to probably around 18% for A5. So, and the slogan for HCC actually, if you live better, you live longer. If you have a good liver function, then you have a more chance to survive more. And this actually was presented in a couple of abstracts. None of them was in a real paper, but they came to abstracts in 2018 and 2023. And they showed patients who received SPRT for HCC, and they found that change the child score prior to SPRT, after SPRT, and you can see the significant difference in the overall survival. So if you have a change of 2 or more points, the median survival is 20 months. But if you have no change, the median survival is 58 months. Those patients who received all of them SPRT. And that's why the whole aim for liver HCC, when you treat with SPRT, to control the cancer, but at the same time, you need to make sure that you are maintaining the liver function. And that's how it came that instead of using the conventional radiation, we'll probably use a pulsar approach. If you are not familiar with it, it's simple. For the conventional SPRT, you give fractions daily or each other day. The overall treatment time is over 1 or 2 weeks. And if you want to do adaptive, you do geometric adaptation, simple. One size fits all. But for pulsar approach, and instead of giving the radiation once every day or once every other day, you would take a session, then take a break for 2 to 3 weeks, give another session, break to 2 to 3 weeks, another session. And this will allow you to do more geometric adaptation, or even volumetric. Maybe the cancer will shrink, and probably biologic adaptation. I can speak about that. It's very personalized. How come this is going to happen? Because for liver cancer, you can do the liver function and calculate the child classification every 2 weeks. And if there is a change in the child score, oh, that's very enough for this patient. Mean that probably you can go with a 16 gray, and that's enough for the patient. But 16 gray is very low, right? Guess what? I have a patient with HCC, bridge to transplant. We give 16 gray, went to transplant 3 months after, complete pathological response. But I just showed you earlier, based on the literature, if you give a lower dose in for HCC, you have a more chance. And that's why we are designing our phase 2 trial that will start in January 2026 for patients with HCC using a pulsar approach with a small sample size, 54 multi-institutional. And I have 3 minutes, okay. So this is something I created probably 6 months ago. We all as radiation oncologists know about the biological effective dose, that you give higher dose of radiation treatment, then you can kill the cancer. But radiation with immunotherapy for many years was not successful, right? Because what's happening that you give the radiation treatment, you try to damage the endothelium and create a case of inflammation. So the T cells and neutrophils migrates from the lymph nodes, go to the area of the tumor, try to kill it. But guess what? Radiation treatment kills the neutrophils too. So you are trying to shooting our feet. That's that simple. That's why the combination between radiation and the long conventional one with the immunotherapy doesn't work. But for pulsar, if you give a radiation treatment, cause this scenario of inflammation, bring the neutrophils, give them a break, let the T cell and neutrophils kill the cancer, then another pulse of radiation treatment, make the same scenario, then will be a synergistic impact between the radiation and the immunotherapy. And in that case, radiation will look as a vaccine. And as we knew that we created the biological effective dose, probably we should create the vaccination effective dose for each cancer. So for liver mets, a different story. We need to increase the high dose of radiation treatment. There is a significant difference in local control based on the BED. And meta-analysis showed that probably the local control could be down from 90 to 60%. And even if you get the BED of 180 over a single fraction, it can provide a good local control. So single fraction BED around 180 is 38 grade single fraction, around 127. There is actually a phase 1 study that was done at UT Southwest for patients with liver mets, and they give single fraction between 35 to 40 grade to the liver, and they found the local control is more than 96%. That's very high. So we are doing another study that already started December last year, and multi-institutional for patients with liver mets to give a single fraction 38 versus 27 at the MRI. So I always say that. So any medical oncologist here, pharma, okay, I can see a couple. So if a speaker with a medical oncologist tell them, okay, I have a magic drug for cancer patient that works for almost all cancer, very effective, very targeted, only localized side effects, no rare systemic side effects, definitely non-expensive, less than immunotherapy, and widely available. We all gonna invest in this. This is radiation and the adaptive radiation. So whether it's CT or MR guided. So here's my acknowledgement and to all my colleagues who are helping us in running clinical trials overseas. And thank you for listening.
Thank you, Dr. Ali, for this interesting topic. We'll keep the question to the end. Our next speaker, it would be through virtual meeting, Professor Dr. Lauren Hankey. She is Director of GI Service in University Hospital Case, Western Reserve, United States. She's going to highlight and address about the non-surgical management in rectal cancer.
Thank you for the invitation to present today and to be part of this. So thank you also for Astro for the invitation for this joint session. So I will be talking today about non-surgical management of rectal cancer. These are my disclosures and my employment information. So my objectives today are to first give a quick refresher on the origins of non-operative management, or NOM, as we sometimes call it, in rectal cancer. And I will use the lens of high-risk disease, which is the main setting in which we practice non-operative management in the United States, although non-operative management can be practiced in early-stage rectal cancer as well. And then I will talk about what do we know so far about how to optimize it, and what additional evolutions for non-operative management might be in the pipeline. So to start with a little background, our historic standard paradigm for treatment of rectal cancer that was long established for many years was to perform neoadjuvant long-course chemoradiation for T3 or higher or node-positive disease. And this typically consisted of a 45 gray and 28 fractions dose to the pelvis and a boost to the primary tumor with concurrent chemotherapy, followed by a break, then followed by surgery, and then after another break, adjuvant chemotherapy in patients where it was indicated as soon as patients were medically able. And this course of care had many built-in delays, particularly to chemotherapy. So I'll keep that in mind as the background. At the same time that this was the standard, non-operative management actually began by a colorectal surgeon named Habergama in Brazil in the early 2000s. And the surgeon was actually highly criticized for non-operative management at the time. In this institutional evaluation, patients there were treated with the same long-course preoperative chemoradiation, but then ahead of resection consideration, they were assessed for response at 8 weeks after chemoradiation. And what they found was that almost a third of patients had a complete clinical response, or CCR. And in those patients, operative management was avoided, and in long-term follow-up, it appeared that that resulted in very similar control rates of disease as patients who actually went to surgery and had a complete response with surgery. So in other words, patients did very, very well with non-operative management if they had a CCR. And again, this was criticized at first because it was felt to be against a longstanding dogma. And so updated results were presented many times with really similar findings of high rates of clinical complete response, almost 30%, just with long course chemoradiation. So the major shift for non-operative management, at least in the United States, came with the advent of the Rapido phase 3 randomized clinical trial, which was known, at least in the US, as the normalization of what we refer to as total neoadjuvant therapy, or TNT, for high-risk rectal cancers. So again, these patients who who have at least T3 disease, node positive disease are the cohort that we're focusing on. And in the case of Rapido, even higher risk features than that. These patients were randomized to long course chemoradiation to surgery, followed by chemotherapy, the standard arm, versus short course radiation, followed by chemotherapy, and then surgical resection. And this study established total neoadjuvant therapy as standard because it resulted in a reduced rate of disease-related treatment failure, mostly due to the reduction in distant metastases of around 7%. However, what this study also resulted in, as well as similar studies at the same time, like the PRODUCE trial, was a massive increase in the rate of pathologic complete response rate at the time of surgery. If you compare the Rapido PCR rate of about 28% versus that of the long-standing prior standard, the German rectal trial, which was 14%, this is a really large number of patients who at the time of surgery actually had no disease left. And this very reasonably raised the question of, with such high pathologic complete response rates, why are we potentially doing surgery in all of these patients? And if you consider the effects of multimodality therapy, going back in time to the Dutch trial, we have known for a long time that in patients who get multimodality treatment, like radiation and TME surgery, represented by the dark black bars here, there are higher rates of bowel dysfunction. The worst bowel quality of life happens in patients who get multimodality treatment. And this is truly symptomatic bowel dysfunction, like incontinence. So we like to avoid multimodality treatment wherever possible for our patients. So this is where non-operative management came from, these high PCR rates, these observations from Haber-Gamma in the background, and the knowledge that multimodality care is toxic. So how do we do non-operative management? How do we optimize it? One of the first indications for this was the OPRA randomized phase 2 trial conducted at Memorial Sloan Kettering. So this trial enrolled patients with distal rectal cancer, stages 2 to 3, about 320 patients, and they received total neoadjuvant therapy in 2 varieties. Both arms were considered for organ preservation if clinical complete response, as confirmed by pelvic MRI and scope, was observed. They were randomized to an induction chemotherapy arm, so a chemo first TNT approach, versus a chemoradiation first, followed by a chemotherapy approach. So this is that schema here. So distal rectal cancer is randomized to chemo first versus radiation first, followed by response assessment and pursuit of non-operative management in anybody with a complete clinical response. And what was found in both the initial findings as well as the 2023 long-term updates was that the chemoradiation first approach, so chemoradiation followed by typically 8 cycles of FOLFOX chemotherapy, was the best formula to maximize organ preservation. You can see in the A and B boxes here that the TME-free or total mesorectal excision-free survival, the rate of organ preservation, was much higher in the chemoradiation first arm, 54% versus 39%. What was also really important to note, and something that has really long-term importance in pursuing non-operative management, is that the disease-free survival was not worse in any patients managed with non-operative management. So in both arms, those patients who got non-operative management and had a CCR, if they had regrowth, they were able to be salvaged, and the DFS long-term probability was not worse with non-operative management. In other words, doing non-operative management, however it's conducted, is safe for patients. One question that is still on the horizon is, what about the use of short course radiation for non-operative management? In the United States, short course is perhaps used a bit less often in non-operative management, but it's used very commonly in Europe and other countries. And so WashU, Washington University in St. Louis, conducted a prospective, non-randomized, single institution trial using short course radiation followed by chemotherapy for evaluation for non-operative management. The same order as the winning arm in OBRA, but using short course. And what they found was that clinical complete response rates at 1 year were high, nearly 70%. And what was important also to note is that, as is common with non-operative management, there is a rate of tumor regrowth locally in patients who initially have a CCR, usually around a third of patients, and that's been historically consistent across reports. However, those patients who had regrowth, it typically happened quickly after their initial CCR, most within 2 years and mostly around the 1 year mark, and it was salvageable with TME. So again, clinical complete response can result in non-operative management and can be salvageable if regrowth occurs. So this is safe and results in high rates of TME-free survival. This has recently been evaluated in a larger trial, also run by Washington University in St. Louis, but with Mayo Clinic and Colorado and other institutions also participating, evaluating, again, short course radiation in a larger cohort of patients in a phase 2 trial. And this will be presented, the findings of this, in just a few weeks at ASCO in this year in 2025. One thing that I'm particularly interested to see is this study did evaluate for circulating tumor DNA correlates of response and TME-free survival. It can be challenging to sometimes discern post-treatment changes on MRI and scope, and so having tumor marker correlates to help to contribute to response assessments and monitoring will be very interesting. One thing that is really important to mention is that in patients who are MSI high or mismatch repair deficient, we pursue a unique path for non-operative management. And this is NCCN recommended in the United States and a standard of care on the basis of a initially small phase 2 trial at Memorial Sloan Kettering using single agent dostarlimab every 3 weeks for 6 months in rectal cancers. And initially, this trial actually intended for this immunotherapy, single agent immunotherapy, to be followed by chemo, radiation, and surgery as per a kind of standard non-operative paradigm. But what they found was that at minimum 6 months follow-up, 100% of patients who were MSI high or mismatch repair deficient had a clinical complete response to immunotherapy alone, with no need for chemotherapy, radiation, or surgery, which of course results in a high quality of bowel quality of life. And larger trials are underway. And again, as I mentioned, this is actually already NCCN recommended in the United States in standard practice. So how do we go about continuing to refine non-operative management in the United States and elsewhere in the world? A major open question is still whether or not short course or long course radiation for non-operative management matters in high-risk patients. During COVID, patients were frequently treated with short course radiation to be able to get them through treatment quickly and reduce their healthcare exposures. What was found in a retrospective study from Memorial Sloan Kettering indicated that there was potentially better long-term organ preservation with long-course chemoradiation, that there was a similar initial rate of clinical complete response, but that there was less regrowth in the long-course arm. However, I point somewhat humorously to the limitations of propensity matching, which is what was used to compare arms. It's very challenging to match patients. We know that even when we match patients exactly on their characteristics in retrospective studies, such as this comparison, again, joking between Prince Charles and Ozzy Osbourne, on paper, they are very, very similar. In reality, they're very, very different. And so we can't really conclude anything definitive based just on this study. There's some hints maybe to the answer. Just last week at ASTRO 2025, the Star Trek trial was presented, which is a phase 2 randomized trial for early intermediate stage rectal cancer with 344 patients enrolled. These were low-risk patients, so I want to really point that out. This is a different population than those where we typically practice non-operative management in the United States. So these patients had CT3B or lower disease, so non-bulky disease that was not threatening the mesorectal fascia, and they had to be node negative. Most patients were T1, T2. And they were randomized to long course chemoradiation, 50 gray and 25 fractions, versus short course, using a very small mesorectum only target. What was found was similar toxicity profiles. However, when we're looking at the radiation intervention alone, so again, these patients got no consolidative systemic chemotherapy, no FOLFOX or CAPOX. There was improved TME-free survival in favor of long course, 61% with long course versus 80% with short course. So maybe, at least with the pure radiation question alone, it may be in favor of doing long course. But it's hard to know how the addition of standalone chemotherapy will impact this. And this is also a lower risk cohort, so it may not extrapolate well to the high risk group. Fortunately, we will hopefully soon have the answer with the ACO-ARO-AIO 18.1 study out of Germany, which is randomizing patients with intermediate high-risk disease to total neoadjuvant therapy using the order shown by Oprah to be the most effective, radiation first, either short course versus long course chemoradiation, followed by consolidative chemotherapy. And we hope to soon have the answer from this study. Also up next in rectal cancer is the consideration of non-operative management with triplet chemotherapy. The PRODIGE rectal study used the intensified chemotherapy regimen of FOLFIRINOX in a study arm, and there was a survival benefit in that study. And so this led to the design of the JANUS rectal study, which is a randomized phase 2 trial in the United States with Alliance, NRG, and SWOG that opened in 2022. And essentially all patients are accrued at this point, very rapid accrual on this trial. So it will be a bit of time before it reports out, but patients were randomized both arms to long course in this study, but to consolidative FOLFOX versus intensified FOLFIRINOX. And we'll see what the impact of this chemointensification is potentially on the rates of clinical complete response. At the same time, the Ensemble trial is a very similar design, but using short course followed by a nearly identical chemotherapy question. So we hope to soon know from these trials whether chemointensification also helps. Either way, or however you pursue non-operative management, careful monitoring after treatment is very, very important. There is a high rate, again, as I mentioned, about a third of patients who have a clinical complete response will have local regrowth. And so surveillance on a regular schedule is very, very important, especially in the first 2 years. The way that we manage that at my institution is with, for the first 2 years after treatment, every 3-month pelvic MRI and flexible sigmoidoscopy to ensure there is no tumor regrowth, and then chest and abdomen imaging as per standard every 6 months. In years 3 to 5, we spread that pace out to 6 months and 12 months to very carefully monitor patients who might have regrowth so that they can be appropriately salvaged if and when that occurs. So with that, hopefully this has been a good refresher on origins and optimization of non-operative management and things that are in the pipeline to hopefully improve it in the future. So with that, thank you.
Thank you, Dr. Lauren, for the comprehensive review of the topic. I would like to call the speaker to the podium to start the discussion. We have a question here.
Thanks for the all excellent presentation. So my questions to my colleagues, especially Dr. Ali and Dr. Tamer, when you talk or we talk about the inline and online adaptive radiotherapy in our day-to-day busy schedule, including us being in brachytherapy suite or IORT or in clinic, how you do that? I mean, so do you have a dedicated team on core rota for that? Do you train your therapists? How you do that?
Every time I remember about that, I'm going to cry because it's a lot of commitment. But it's a whole teamwork. So I think each group need to organize it among each other. For example, at Princess Margaret, the GU group have a rotation when a radiation oncologist and or a fellow is working a specific day. For the GIA group, we have a different model. We have a dedicated radiation oncologist fellow who is dedicated for the MRL. On the ethos, it's easier a little bit because we have a dedicated radiation oncologist who is only for and the ethos itself. We didn't start like that. We started with when the radiation oncologist was available like 24/7, almost like that. And it was a heavy load in the start. In my opinion, everyone need to do the job and attend for at least a year until he or she master that. Then after that, they can train new generations or bring someone who has experience to be dedicated. I don't know if Dr. Tamer.
Yeah, I would agree that everyone is different, and it is very labor intense, very challenging, honestly, to run an adaptive program. So I used to run the program alone, running a clinic and program in a single center where single radiation oncologist. The only way to do that is to train your staff. We are transitioning now from a view rate to ethos. So actually, we are visiting Dr. Henke next week because she had the same experience. My plan for our program is that our therapists are now taking courses to learn how to contour normal structures, for instance. So instead of me spending 10 minutes contouring every day, they will do this, and then I'll come just to verify. Our physicists will be deeply involved with as well. I think the structure of the program depends on the logistics and the capacity of the center. We need to understand it is very labor intense, and it might not be cost effective if you do not run it in an efficient way. So it comes with tons of challenging. I'm hopeful ethos will be less intense than Bure. I will know firsthand in a few months. I have seen different models. I have seen centers where dosimetrists do the contouring. I have seen centers where therapists are involved with physics. In my center, I did everything. We started with like a patient took 45 minutes to an hour on the table. After 6 months of practice, it came down to 20 to 30 minutes. So yeah, it's challenging.
Thank you.
Thank you very much for the great presentations. Actually, I have a question to Prof. Tamer. Since you're transitioning actually from MR LINAC to ethos, and I love the idea about giving the pancreas a high dose with the lymph nodes included actually in the volume. So will you be able to do this on other machines, which is like CT based?
That's a great question, and I will tell you what I think, and then I would defer also to Lauren if she would like to add to this. But I would say that I had a site visit in WashU actually, and I got impressed with the HyperSite. So with HyperSite technology, I was able to identify the celiac and superior mesenteric. I think if I am to do dose escalation in pancreas cancer, I don't know what Lauren does, but I believe in elective nodal irradiation. I think that really helps. There is data from Cincinnati and MD Anderson was like up to 80% failure when you do SBRT without aiming at this area. So I'm hopeful we can. I'm hopeful with adaptive we're still able to do that, but I would ask Lauren, what do you think about it?
Yeah, so we have been using Ethos with HyperSite at our institution for online adaptive since we went live with our program. And we do deliver ablative radiation for pancreas. My prescription dose is 50 gray and 5 fractions to the primary and 33 and 5 fractions to an elective nodal volume, which is the periceliac, SMA, and periportal nodal regions for a pancreas head tumor. The things that are critical to be able to have high quality online adaptive treatment is really the image quality. And so having a HyperSite unit on an Ethos is, in my opinion, very important. HyperSite has been shown The scans are 6 seconds long, so there's very minimal motion artifact, so long as the patient is in a breath hold position. And it's also been shown to be accurate in terms of density for direct calculation to serve as a simulation CT. It's actually approved in the United States by the FDA for use as a primary simulation as well. So the image quality is there, but the image quality really depends on having patients in a breath hold position. If the patient breathes during that acquisition, even though it's short, there's a lot of artifact. It can be really challenging to see. One thing that's also really important in adaptive for pancreas with ablative dosing, whether you're using MR or CT guidance, is the motion management during the delivery. I would argue that that's probably as, if not maybe even more important than being able to do adaptive plan changes. And so we use exhale breath hold delivery for all patients on our ethos. And we use actually identify surface guidance along with repeat cone beam after each arc to verify that patient positioning. We found that the residual motion of using surface guidance in that setting is on the order of 2 to 3 millimeters, which is very similar to management techniques like ABC or RPM, and actually very similar to the residual motion with CNA MRI gating. And so we've found it so far to be very safe, but there's actually an ongoing phase 2 clinical trial of doing exactly that in pancreas cancer with CT guidance on ethos. That's very unsponsored. That will hopefully demonstrate the safety of that approach on a larger scale.
I can add a minor thing here that echo the same from Lauren regarding the motion management. Motion management is a very critical part for pancreas cancer specific. I'm not too much worried about the elective target visualization because the celiac and the SMA will be seen with MR or CT. This hypersight is great. What we are doing in pancreas, because we have 2 facilities, that for pancreas with MR and NAC, we have a specific image set called T2 high resolution, which is simply an average scan. So you do not need to treat the patient exhale, breathe, hold. So most of the patient, probably more than 50% of them, they are not able to do an exhale, breathe, hold. So if the patient is able to do exhale, breathe, hold, then it's ideal to go to the ethos or the CT-based adaptive. But if not, then you go with the MRL and you have the high resolution. You don't need to go at an ITV. It's just the GTV equal to CTV equal to ITV, minimizing the target. The motion is included, so everything is good and easy.
Thank you. I have a question for Prof. Tamer. So for your standard practice, will you offer neoadjuvant for resectable pancreatic cancer?
We do now. I mean, there is more and more evidence that it does help. It at least decrease the likelihood of R1 resection. And in our institution, most of the time we would offer neoadjuvant chemotherapy and then reassess the scan. And if the patient is resectable, we take them to surgery and offer them the IRT study to be followed by adjuvant radiation. If they are still borderline, we would go for concurrent chemo radiation, hoping that would make them resectable.
Okay.
Yeah. Lauren, is it different in your institution?
We do fairly similar. There is, I think, a lot of practice variation where some institutions will offer preoperative radiation in all patients going for surgery. We typically offer it in patients who are borderline resectable. In patients who are clearly resectable, we less often offer neoadjuvant radiation, although we do use adjuvant radiation in those who are ultimately node negative on pathology, as per the recent results of RTOG 0848. But for definitely all borderline resectables, we offer it on the basis of the pre-opaque data that Tamer showed.
Thank you. Question to Dr. Ali Husni. For patient with the HCC has thrombus, inferior vena cava thrombus, would you treat those patients with SBRT, or this is a contraindication?
For HC with tumor thrombus, that's one of the early indication for SBRT because you don't have any chance of RFA or TACE. We actually have an institutional protocol when we give even the lesion in the liver is too big and you're not able to give higher dose to the tumor in the liver, we use a lower dose and give the thrombus a larger dose because once you melt down this thrombus, the liver function will be better. Yeah.
Okay. And okay, Dr. Arabi.
Okay, actually, I have a question for each of our respectful doctors. So the first one, Dr. Tamer, regarding adjuvant after surgery in radiation therapy in pancreatic cancer. If it's an N1 disease, as we mentioned, it's no survival benefit. So is it weighing enough? I mean, side effects in front of local control, does it weigh enough to give radiotherapy?
So that's a great question. And it is always a conversation with the patient. So first they have to finish their adjuvant chemotherapy. And then we scan them. And a number of them will be metastatic by then, which is unfortunate, right? So it's no discussion anymore. For those who were fortunate enough that they had node positive disease, they had negative margins, they went through the adjuvant chemotherapy for FOLFIRINOX, and they remain without evidence of distant disease with CA 19.9 low. I discuss with them. I tell them there is clear local control benefit here. It comes with a cost, of course, side effects, not like a free ride, right? So the radiation is not a free ride. So to come with some side effects, but there is definite local control benefit. And with the chemotherapy you got, there might even be potential survival benefit, even if we do not have evidence to support this. And it differs from patient to patient. I would say the majority of our patients, we still treat them. Historically, we treated only node positive patients, right? It's just now, which is not strange in pancreas, right? Like every couple of years, there is a new study bringing something new. But I would argue that with FOLFIRINOX, I think from a retrospect, if more patients in this study had FOLFIRINOX in the adjuvant setting, we might have seen positive outcomes in the node positive as well.
I actually ask this question because it's a regular question in our tumor board. So I personally try to avoid radiation therapy post-operatively in this case.
Yeah.
Anyhow, so the side effects are huge, actually.
I mean, my institution, we're lucky that our medical oncologist is supportive of this. So if they got the patient through all of this and they are still without evidence of distant disease, they would like to optimize care and be aggressive in there.
Thank you, sir. Dr. Hosni, regarding the pulsar approach. Okay. Actually, regarding the radiobiological base of this idea, I find it a little bit strange because aren't you afraid of any repopulation or resistance of cells?
Well, that's a great question. So the biggest evidence for accelerated repopulation came from head and neck cancer. More evidence for squamous cell carcinoma. No data specific for the HCC. I know that the pulsar approach is being more implemented recently now, but again, I think because the high sensitivity for HCC to radiation treatment, I always feel that HCC is best fit for testing or evaluating the pulsar approach. Again, we always thought about the BED, but the other side of this coin is the VED, the vaccination effective dose, especially what we know more about the tumor microenvironment. I'm not saying that we should do that as part of a standard practice, but even it's a trial, it's a phase 2. It's for patients who are borderline liver function, either A6, B7, B8. And most of these patients, we give a radiation dose of 27.5. If you get 8 fraction 3, it's 24 and 3 equivalent BED. Most of them will finish the radiation in 5 weeks. The majority of data from accelerated population supporting it happens at week 5. So that's still reassuring for us that the patient will bring probably equivalent dose to the usual dose that we are give, even with accelerated population, if it happens for HCC.
Well, I personally think it's a little bit of a risky approach. Anyhow, we should
That's why we're doing the trial.
Because all the gap trials, they didn't show actually so. Anyhow, so my question is for Dr. Lauren regarding the non-surgical management. I think the most challenging part in this management always will be how to follow up the patient, how to make sure this patient has a recurrence or not. So is it endoscopic ultrasound, MRI, PET scan, proctoscopy? What do you use actually, and the duration, how many times?
The way that we follow these in our clinic is conservative. We get every 3 months a pelvic MRI, rectal protocol, and flexible sigmoidoscopy by the colorectal surgeon, so the same evaluator, to monitor the appearance of the scar. That is, again, a bit conservative. There are groups that will do imaging and scope evaluation every 6 months. But I think it's very important, especially in the first 2 years, to follow these patients closely. When regrowth occurs, it seems to happen primarily in that window of time, actually mostly at the 9 to 12 month after complete response timeframe. And so for especially that first year, doing a scope evaluation and pelvic MRI every 3 months is really important. In patients who have contraindication to pelvic MRI, we're very reluctant to offer non-operative management. Endoscopic ultrasound is just as sensitive for monitoring, if not more, for the primary tumor, but it has limitations for monitoring of regional nodal disease compared to MRI. And of course, that is also a really important component. So I think the most important thing of all is that if you're doing non-operative management, that these patients are tracked very closely, that you keep potentially a prospective registry so no patients are lost to follow up, and that you have a consensus approach across your multidisciplinary team where everybody understands that these patients will be followed closely, at least for the first 2 years after treatment, because these patients should be the ones that do the very best. These are the patients who have disease responsive to systemic and radiation therapy. They should be the ones that have the best long-term outcomes. And so we want to make sure that we preserve that and we're not risking their long-term cancer outcomes just for the chance at bowel function.
So the follow-up is mainly during the first 2 years. So this is all for localized or local recurrence. But do you do any imaging for any risk of any systemic recurrence?
We do systemic imaging. The schedule that we follow for that is an every 6 months CT of the chest and abdomen, which is, if you think about when patients go to surgery, typically we monitor them with every 6 months CT scans after surgery. And so we are keeping that same interval for their systemic imaging with the chest and abdomen every 6 months. So every 3 months, they get a pelvic MRI and scope, and every 6 months, they get a CT of their chest and abdomen. After that 2-year mark, we transition to every 6 months for MRI and scope, and every year for the CT imaging, as at that time point, the risk is lower, although still not zero.
Thank you. So I have a question here.
Thank you very much to all the speakers. Just going back to the HCC theme again. When you look at the guidelines, like the PCLC guidelines, SBRT sits really low on the list of options. You basically give it when no other local treatment can be given. That's the tumor board discussion normally. Mainly due to lack of level 1 evidence, lack of phase 3 randomized trials. My question is, are we likely to see a phase 3 randomized trial for SBRT versus any other local treatment like STIRT, TACE, any of those other local treatments? Are we likely to see any trial anytime soon? Thank you.
Yeah, there are a lot of trials running, and no worries about NCCN guidelines because we are working hard right now to implement that. The RTOG 11, when the RTOG 1112, which was a phase 3, we presented in Astro and ASCO GI, we were told we cannot put in the guidelines until the paper is published. Then it took us probably a year to publish the paper. Going back and forth was a pain, unfortunate. But now we are in a multiple disciplines and meetings, and we are putting it in guidelines soon. Problem with having an RFA versus SPRT trial, which is there, it happened, but it doesn't happen from Europe or North America, so that's why the implementation may be not easy during the guidelines here. You need to have a mass approval from interventional radiologists to do it, which is not easy. And everyone who's treating HCC, an older one like me, like 20 years ago, when we're trying to bring SPRT to the MCC, that was a hard discussion. Now it's much more easier. Then if you come to a competition with them to tell them SPRT is better than TACE, they will be very reluctant. Despite I'm not sure, but let's say all the evidence say that if you get SPRT versus TACE, SPRT is going to win. But it is what it is for.
Okay. Well, thank you all for excellent interactive discussion. We run past the time. I've been told to just to stop the discussion for now. So thank you all. And I think we move to the next session now. Thank you.
So we'll start now the Satellite Symposium by Vision RT. And let's welcome Mr. Irakli Martashvili. Mr. Irakli is a medical physicist and clinical application manager at Vision RT. He's going to talk about improving planned dose distribution and safety using surface-guided planning MAP RT. Welcome, Mr. Irakli.
Thank you, dear organizers, for the invitation to this wonderful Saro. I'm happy always to come back to Jeddah. Always fond memories of this nice Congress. Today, I'm going to talk a bit about the surface guidance or the evolution of the surface guidance out of the recent years. But I'm going to focus on a little bit of a different aspect. So if we talk about surface-guided radiation therapy as a new standard within the radiation therapy, most of you probably know more of a traditional part of SGRT, what we call for short, or SGRT for motion management, patient positioning, and gating. But if we look at the current definition of the surface guidance and what it envelops, is actually every step of radiotherapy workflow now. So exists of SGRT for simulation, for motion management at the sim. There exists the SGRT for treatment planning. So I'm going to focus more about this aspect of the surface guidance today. And there's, of course, the more traditional one. This is for treatment, for motion management, for gating, both for the open and the closed Borg entry solutions. And as of recently, there's an SGRT also directly for monitoring the dose delivery in real time as you're treating the patients. So all really exciting times for this technology and this technology going into the radiation therapy field. But today I'm going to talk more about the aspect of the clearance mapping and usage of SGRT for planning the treatment. So why do we want to have this type of solutions in the treatment planning process? Of course, as radiation oncologists, we can cover the tumor dose with the curative dose probably most of the time, but a lot of normal tissues go into the field. So we can, of course, can do this. We can go add more fields, go to VMAT, IMRT, and as of recently, to go to more into non-coplanar planning process. So non-coplanar is, of course, the holy grail, or personalized non-coplanar treatment is the holy grail of the radiation therapy. It offers the best, most compact dose distribution while covering the tumor with the curative dose, sparing as much of the healthy tissues around it. But there's a problem. While we produce the healthy organ sparing, we actually need a lot of things to manage. So there's a risk, there's a time, there's a skill involved delivering those types of treatments into radiation therapy. So how do we do this in a way that really focuses on the patient, as well as gives the ability to do it in the most simple way? So let me play a short video. Can you play the video? Not included? Okay, fine. All right. So what happens in the normal treatment time? So if we look at the non-coplanar treatments, right? If we do a bit of the kind of a survey, and there was a survey run by the University Hospitals Dorset. And in the survey, they looked at the different treatment sites. So they looked at multiple radiation sites of breast, cranial, SRS, lung SBRT, head and neck lymphoma, and so on and such. And if they looked at the share of those treatment sites being treated with non-coplanar radiation, really only the SRS for the cranial was the high, but a lot of other sites received a really low fraction. So majority of the patients get really normal coplanar treatments. So when we asked the customers, or we did this survey, global survey, what are the main kind of hurdles in them preventing to do this type of treatment, was many aspects given here. So whether they need an automated check for patient risk of collision risk when you rotate the couch, whether they can safely transition from one field to another field, whether there was the increase in treatment time overall, and which coplanar plans, non-coplanar fields were able to be used in the planning process, as well as publications showing automated meaningful dose improvements. So all of those kind of I would say aspects were raised within this global survey, talking about implementing a non-coplanar as a standard of treatment. Yep. Hope you like this short introductory video. So in this case, we're utilizing, again, the surface imaging solution to be able to capture the full geometry of the patient. So within the capture of the full geometry of the patient, we can actually do a full-on geometric modeling of the patient treatment. We can include the patient with all its underlying accessories into the treatment bunker. We can 3D scan your LINAC head and actually simulate the treatment for any possible gantry and the couch angles. So what does it look like in your MapRT software? So this is what you see as the clearance map. So within the clearance map, as a 2D map, you have the representation of the full phase space of the patient treatment. On the horizontal axis here, you see any possible couch angle in the middle, so from 270 to the 90-degree angle. And on the vertical axis, these are every possible gantry angles. So every dot, every pixel on this 2D map represents the combination of some combination of the gantry and the couch angle. The red zones are where you have the direct collision. So these are your risk zones, where you have collision between your patient, your gantry, your couch, and this is where you cannot safely deliver the beam. The gray areas are open areas where you can put the treatment fields to customize the non-coplanar treatment specifically tailored to this patient. You can do a few improvements here. So you can adjust your treatment isocenter to find a more collision-free space for patient treatment delivery. You can check your existing plans. As you can see here, your vertical lines represent the partial arcs, and the dots represent your 3D or IMRT fields. And you can check your treatment plan against the full clearance of the patient, meaning you don't need to do any more physical dry runs on the patient directly in the bunker. So a few things, how you utilize the software. First of all, at the simulation point, before even the scanning and the simulation is done, you can check the patient's position if it's optimal, or you will have a collisions with this kind of a positioning at the patient CT bunker. You can improve the plans in the planning process. So as you're planning, as you're trying to fit your kind of a template plan into the patient treatment course for a specific site, you can check if those fields, those clearances will be able to fit the patient, or you will have the risk of collision in the future. And as in the end, you can avoid all kinds of physical checks, dry runs, and the day one collision issues where you have to send the patient back and replan and redo the whole plan. So all of those things are going into the past. So what are the clinical benefits it gives? So we've run multiple studies. So this is the published study they did for the planning with 5 different centers involved in 5 different countries with 70 beams that we know directly have the clearances or have the collision associated with them. And we asked the planners to assess those fields, the very experienced planners, with and without the help of the MapRT. When you look at the planner assessment, we saw that planners were effective to kind of find the 90% of the fields that have collision in them through their sheer experience. But really the 10% is the one that causes the issues or the injury to the patient risk. So this one can be fully eliminated by MapRT, visualizing all the possible fields and ability to do non-coplanar as a risk-free treatment delivery. When it comes for the treatment fields, we could see that the planners were very cautious and they were able to only quantify and say that we are okay to treat and select only 2/3 of possible treatment fields. And we can see that with MapRT, we can actually extend the full extent of the full possible treatment phase, and we can set the plans and the fields where we want to get the best dose distribution. So how does it translate into the clinical data? So this is, again, a presentation from the University of Texas in Southwestern. They looked at the breast treatments, something that we don't think about non-coplanar. But by adding the non-coplanar field, so by switching to partial arcs versus the coplanar treatment, they're actually able to reduce a lot of organ at risk dose by preserving the same coverage. They were able to reduce they were able to increase the conformity index. They were able to decrease the hard dose, maximum hard dose, average hard dose, as well as decrease the dose on the LADs directly. The best part of the study, the time increase on treatment delivery was only 30 seconds versus the coplanar beams. So really, when we talk about non-coplanar, whether this increased time or would give us the more complicated treatment, it is evident now with more and more mounting evidence that with a very modest increase on treatment fraction time, we can actually gain a lot of clinical benefits. How does MapRT stack against the physical dry runs or physical checks on the patient? It turns out that physical angle checks can produce a lot of false negatives and false positives. And this is normal physical dry run. We can see about 90%, 91% success ratio versus the direct MapRT checks prior to patient coming to treatment. So it even is more beneficial than normal physical dry runs. So MapRT has a direct kind of an API communication, so you can query it and get the information into your treatment routines. Some of the treatment planning system vendors are actually getting this information data directly from MapRT into the treatment planning process. You can import the clearance map, you can see where the collision zones are, and as you are performing the field design, you can check which fields, which plans will have those types of collisions as you're designing your specific plan for the patient. So I will give you some of the clinical studies and clinical cases. So here's one of the case that was very interesting. So you can have the patient here is the post-mastectomy patient. They couldn't raise the arm completely for the chest wall nodal radiation. We don't think about chest wall and the breast as a non-coplanar case, but just by introducing the 10-degree couch kick, you can actually save a lot of those on the risk organs, both on ipsilateral lung as well as the Dmax on your heart, and the average dose on the heart can be reduced significantly just by introducing a small couch kick in your treatment process. And you can treat this patient versus coplanar arcs with, couch kick. You can actually achieve most of your clinical constraints this way. And you can treat this patient with MapRT safely, knowing that you are safe from collisions. Another case, here's the SBRT patient. If we look at the planning process, Here looks like we have one coplanar arc and one non-coplanar arc. Looks like everything is okay. So you can treat this patient safely. But one of the benefits of having the MEP-RT or actually mapping the full patient body, including all the accessories, is that you can see things that you don't have information on. So you can see here directly that the patient arm, patient body has a direct collision, not the arc for the with the rotation. Actually, the arc with the 0-degree couch has the biggest risk of collision here. So you can go ahead, you can adjust this, you can check where the collisions are happening, you can adjust your arcs, adjust your plan, and treat this patient safely without need to do a day one replan and sending the patient home and doing all of the process again. What about the other clinical studies? So this is a long-term study for 1 year. They run in the large French institution at Dijon. They looked at the 900 patients across all treatment sites. And they were like, okay, we want to do non-coplanar. We know it's beneficial for the patient, but let's take it with the baby steps. So what is the simplest non-coplanar plan we can do? And they opt out to add a single partial non-coplanar arc to their coplanar treatment. And they found out just by adding a single partial arc into the patient, introducing into treatment, they're able to improve almost the plans of almost 20% of their patients across all treatment sites. And with the MEP-RT possibility and checking of the patient for the risk of collisions, they're able to avoid 22 collisions as well as the risk of the injury to the patient. For the head and neck study, when they did the head and neck non-coplanar planning, they found out that with MEP-RT and non-coplanar, introduced the non-coplanar treatments, they were able to reduce a lot of toxicity for example, the grade 2 and grade 3 toxicities like xerostomia, as well as the chance of the hearing loss to the patient. So what does the clinical evidence say right now? It says it favors the non-coplanar. So there is truly a way forward for radiation therapy for personalized care and personalized possible best dose distributions. So there's mounting evidence with multiple publications from multiple authors saying that you have a significant reduction on the doses at the organs at risk and ability to preserve the same coverage and also ability to escalate the dose where needed. So here are some of those few ones listed here, but there are more and more and more upcoming, and there are even more mounting evidence here. So at this stage, if we look at the kind of issues or the problems globally, the radiation oncologists, medical physicists raised within those survey, what are these things preventing them to go non-coplanar? Literally, with the solution of the surface guidance within the planning process, you make sure that you check for collisions. You make sure that the couch moves safely from one field to another field, and you're actually also safe from collisions. Data shows there's minimal time increase to the treatments. There's time increase of 30 seconds or 40 seconds. We're talking per fraction. We can know which coplanar beams, non-coplanar beams we can deliver. And we already now have publications that showing there's automation and the treatment planning experience, giving about the same kind of, let's say, effort and the skill needed for non-coplanar planning as now for the normal coplanar planning process. All right. Thank you very much. Right on time. And if you have any questions, I'll be happy to answer them.
Thank you very much for the presentation, and we'll open the floor for discussion. If any questions or comments to Mr. Irakli? If not, then I have two questions from the audience. One was, what are the requirements for any department to implement such a technique? And the other question was, any challenges with QA?
Yeah, so when it comes to the implementation of this technique, what we need to know ability to have some kind of expertise to know which type of a non-coplanar configuration will be beneficial for a specific site. That usually means ability to set up the templates for different site treatments. Like you can have a template for breast, have template for head and neck, and all of those kind of a standardization of the non-coplanar treatments. And that needs some additional or initial consultation or initial expertise to set it up. After that, it's really the normal day, like at work. You have the information, you can check your plans against the clearances and you can adjust them if you need to normally. As far as the QA goes, you can perform the QA like normal IMRT or VMAT QA you can do. So you can check for those plans. And what you need to be aware of, you need to be able to check an ability to be able to track your non-coplanar treatments. So that could be also facilitated with the surface guidance. You can track that patient is staying within the same position, even if you rotate the couch, if you go to extreme angles, and that can be facilitated with the surface guidance on the treatment machine to be able to track the patient at the same time.
Thank you. If no other questions, then I guess we can conclude the session. Thank you very much.
Assalamu alaikum. We'll move on to the last session for the Saro, the young Saro session. And with my pleasure, myself and Dr. Maha Al-Idrisi and Dr. Luca Balderini will moderate the session. Give me a great pleasure to introduce my senior colleague, Dr. Maha Al-Idrisi. She is a senior consultant radiation oncology at King Abdullah Medical City in Jeddah. And Dr. Luca is not okay. So we'll introduce the first speaker, Dr. Hussein Al-Hussein. He is a consultant radiation oncologist at King Fahd Medical City in Riyadh. He is also the Secretary General Deputy for Institutional Affairs at Saudi Commission for Health Specialists. And Dr. Hussein will talk about career path and leadership and leader in radiation oncology. Dr. Hussein, welcome and looking forward to speak.
Bismillah wa-salam ala Rasulullah. It's indeed a great pleasure to shine some lights on the aspects of radiation oncologists and how can you get that balance. This probably is a talk not only for the junior staff or residents, it's a reminder to all of us. So no matter how far are we in our practice, we need to make sure that we get that right balance. In the next, sure the time is starting 15 or 20 minutes or whatever is the time, we're just going to shine some light on that. So the best scenario and the best situation is that you get as much balance of all these aspects while you are practicing and you are providing the care to the patient as a radiation oncologist, and probably all other disciplines, but I'm going to talk about radiation oncology of concern today. So we need to make sure that we are very well integrated into the education of our colleagues, training of our colleagues, and that would go to our medical students and the faculties of medicine, other specialties, and also in the residency training program of our radiation oncologists, medical physicists, the radiation therapy, medical dosimetry. So that's an important part that we have to keep into account. So I would say all of us has to keep in mind every single day of our practice, as long as we are working and even after you retire, but as long as you are in practice, probably Umar can shine some light on that. For the 25 years of working as a consultant, or over 20, almost 30 years working as a consultant radiation oncologist. So that balance is the way to go. I would kind of have the opportunity during medical school, during physics school, during your radiation therapy school, is to keep that balance, because it's not going to happen now overnight. There are people who will be so much focused on practice, and they will ignore certain part of their competencies and of their capacity and the impact that they can make as a result of that. And the other way around, there's others who would, focus on certain areas and forget others. So education training. And there's something that probably yesterday we were having some discussion about one of the issues and challenges that we are having in one of the areas that we had discussion. And one of the colleagues have mentioned, what are the incentives for me when I do this to be engaged into the training or education? And I would say, for God's sake, come on. How did you get trained, educated when you went for your scholarship? What was the incentives for those who did support you to go there? Those who approved your scholarship, those who approved your training, those who have built the program for you so that you can go in to start. Did they ask themselves that? Are we too much materialistic at this point that every single thing that we have to ask for the incentive? Whether it is for global or national requirement or workforce capacity building, I would say that question should never be asked. Incentives would come if it's kind of materialistic kind of incentives, it will come one way or the other. And if it doesn't come, this is not the way that we have been here for. And we have to remind ourselves, the more you give, the more you will have. And there are material kind of investment, and there are things that are, non-materialistic, and you will feel very much rewarded and accomplished when you do things and see how much of your workforce in your country and globally have you contributed to. The best gift you can give to yourself is to be part of making the path easier for someone. And as many as you can, as many as the blessings are going to happen. And that's what I can say. If you're going to be searching for incentives, believe me, anyone who would think that I will give something, then I will get something in return, you will be limited to the work that you're going to do. And, you're going to be keeping yourself too much busy about things that are not, going to make you any results, neither rewarding to yourselves or to the system. Research and development. I'll talk about, how busy clinicians we are, how busy whoever is in leadership or administration or in academia or whatever. You need to get to the contribution of the, knowledge and transfer of knowledge. And you cannot do so without being part of research and development. It could be a research like kind of systematic analysis, meta-analysis of work that's been done. It could be something that you're developing a new idea, you're innovating, you're being part of making something added to the practice and to the training so that's something that we have always to keep in mind. And again, I'm going to be going through that, and each one of us, he or she will do his or her self-assessment, how much I'm doing in each one of them. You don't have to be kind of 15% in each one of them, but you have to be, where am I heading and where should I be focusing on, and where is the purpose? Where am I heading? Where is my passion? And build more on that. But make sure that you contribute to each one of these aspects. And we'll be more than happy at the end of this session if, one of the colleagues who would kindly help us to add any aspect that I might have missed during the preparation of this brief talk. Practice. I would, no matter again how you go, I do have 20% of my work dedicated for clinical practice, 80% of my time dedicated for leadership, administration, and other work that I do. I will retire as a radiation oncologist. That's the thing that I always keep in mind. So again, each one of us, you would like to keep in mind, where am I heading? So some would leave the practice early after 20, 25 years, and you should have that clearly focused. Some would leave the practice at early as 5 years or 10 years. Others will stay, and we have a great example ahead of us, Dr. Prof. Yasser Bahadur, who's serving for 30 years and be part of many of these aspects that we are addressing today. So keep in mind, as a radiation oncologist, if you're not practice, if you're not doing your practice, you're not perfecting your practice. And not to say that, I will be practicing while I'm busy with these things and I will have to underachieve in my practice because I'm busy with others. You have to practice and be up to your kind of momentum as if you are having nothing else. So each one of these aspects, you have to work and do it at your best. Again, I'm reminding myself of all the things that we're talking about today. So I'm not giving a lecture to very highly regarded colleagues, but I'm always reminding myself of that, and I would have to keep it to account. Quality, whether it is quality in education, being part of accreditation or academic programs, or whatever services that will help the quality, curricula, reviews, and other of the training programs, and be part of the accreditation team or part of improving the curricula or be part of the exams and stuff, research and development, quality, and looking for innovation for areas that could contribute to the quality through an innovative ways, and the quality of practice, being part of the quality committees in your own department and others that would help to improve that practice. Administration, and I have separated between administration and leadership, and just kind of differentiate between both. There is a lot in the literature that you being a manager or being a leader or this and that, there is fine, distinguishing factors between both, but they're all actually in the same. You could be a leader without having a position, without having any kind of regarded well-known administrative role. Actually, those who lead without opposition, those who lead and move toward that cause without having, they are the strongest leaders. And actually, they are the best who can make that happen. You can do things, you can make a positive impact, positive change without even being, department chairman or that, being a part of a decision, being a part of making a move, being a part of making a good cause moving forward. That's where we are. Being administration like it is, having, to deal with routine, standard operating procedure, things that are usually running a department. This is administration, running a research center, running a medical school or residency program. That's all is part of the administration. Leading is moving forward ahead of that standard operating procedure, which is, well known that you have to run it through. And I would say, when it comes to the leadership, you need to have a cause. And I would probably try to conclude in a moment and get some time for discussion. I'll share a personal experience, but just kind of to use that as an example. I came back after I finished my residency and fellowship to my institution, King Fahd Medical City. Within less than 6 months of being there, I was asked to chair to head the administration for scholarship, postgraduate and scholarship administration. It was kind of something that happened within 6 months. I was just, after this scholarship and just settling myself back in Saudi Arabia. It was a challenge, you just want to take your deep breath after you finish your residency and fellowship. You'd like to rest for a while and then go through. But I said, this is an opportunity for me to create and help creating the same environment for training, and also the environment that I wished as a scholar when I was a scholar, as if I would hope things would have happened. So I hope that the training environment in the training center where I was asked to serve is exactly as the one that I had during my residency. And I happened to be trained in Ottawa. So the system in Canada, for example, in America and UK and the best areas, I tried to say, where can I do that work to push the training center to be in that level? And working over 3 years, I have, alhamdulillah, helped with the team, with the colleagues and program directors and department heads and others to get to that situation. Then eventually for a cause, went through, would like to look at the national training in Saudi Arabia, in the Saudi board training, would like to make sure that this is exactly or better than the best training systems globally. And that's when I was asked again by the Saudi Commission for Specialty to join them back in 2016. as a consultant of accreditation first, then executive director of accreditation. And I have worked through with my colleagues in the Saudi Commission and our colleagues in the program directors and trainers and departments and leaders of the training centers in Saudi Arabia to work through that. And alhamdulillah, shukra, the Saudi board training, the national training system, which is defined by the Saudi board, is actually competing very well to the American, to the Canadian, and to the English, and to Irish, Australian, and others, German and others, if not exceeding in certain areas. And not only entitled to ward physicians, but also for dentists, pharmacists, nurses, and others. Now, the cause that I have is to go further beyond and be excelling in the AI and the modern technology and the emerging technology and being it in the practice and the training and changing being as competitive as others, and we are well heading towards that. So having a cause, leadership with no cause is not going to make you anywhere. And moving from one step to the next is the way to go through. And again, this is not something that, again, I'm sharing to be part of educating anyone. I'm just reminding myself as part of that. So I hope that I have been able to shine some of the areas. These are not career pathways. I think that all this should be part of our career at large. You should not be, dedicated to this or that. I think the best if you can combine all these capacities and be part of every single aspect and remind ourselves each time that how much I'm doing to each one of these. Thank you so much, and I will be more than happy to take one.
Thank you so much, Dr. Hussein, for this very insightful presentation and talk. And also that Dr. Luca is here. Hi, Dr. Luca. Dr. Luca Balderini, he is the head of MR-guided external beam radiotherapy unit, Department of Imaging, Diagnostic, and Oncological Radiotherapy, came from Italy. He will share moderating the sessions with us as well.
Thank you, Mohammed. And sorry, everyone, but I did a mistake that is often made by radiation oncologists. I relied too much on technology because I've done my appointment on the iPhone that took the wrong time. So sorry.
It's okay. I'm so sorry. We'd love to have you, Dr. Luca, and thank you for coming. I think now we'll move on to the next presentations. We'll leave the discussion at the end. Dr.
السلام عليكم. أحب أن أشكركم دعوتنا to be moderator last session. نقول إن شاء الله ختامها مسك ومؤتمر رائع وموفقين جميعا. أسأل الله نكتب أجركم جميعا. Our next presenter is Prof. Tamer Rifat. We've been honored to have him. He's a professor at the University of he's a director of clinical research and director of adaptive radiation therapy, University of Loyola. And also he is the lead of the gastrointestinal and breast radiation program at Loyola University. Welcome, Dr. Rafat.
Assalamu alaikum. Thank you very much. And I think they know me very well now after like 4 lectures. Thank you very much. Dr. Muhammad, thank you very much for really making me work in this. When Dr. Muhammad Al-Dahim sent me asking to join a panel for navigating a successful career in radiation oncology, it was my pleasure. I always like to engage with young radiation oncologists. And then I was going through the program a couple of days ago and I found out it's a lecture, not a panel. So I just made this presentation from scratch. I thought the best way of doing it is just going through my story and kind of reflect how did things go through me. This is Omar and Jolene, 9 and 11-year-old, my kids. That was a couple of weeks before I come here in a White House event. So my journey, I was trained in Egypt. And then I had my doctorate degree training in France with Dr. Muhammad Al-Attar, who is really a very kind, nice brother. And I had brachytherapy training in Austria with Richard Putter, and then the US. I'll go through all of this in the next slide. Oh, sorry. Okay. So I graduated from Alexandria University in Egypt in 2001. Top students in graduation is granted a lifelong job. So I had my residency in clinical oncology. So I did both medical and radiation oncology. I had my, I don't know if the laser pointer is working or not. Yeah. So I had my master degree and then my, it's not working, my doctorate degree in Alexandria. My thesis was about MRI guided brachytherapy in cervix cancer. The pulsed dose rate arm was done in Lille in France. It was Dr. Mohamed Al-Attar and Eric Lartigot, my mentor, who actually was kind enough to come for the thesis defense that was scheduled actually for February 11, 2011. If you remember this date, that's the date when Hosni Mubarak stepped down. It was a chaotic and actually Eric Lartigot flight came from Paris straight to Lebanon instead of Egypt because of the curfew. And then he had to wait. He came from Cairo to Alexandria in a car with Dr. Hussein Khalid, who back then was the Minister of Health. He's the Dean of the NCI Cairo, who was also trapped in the ministry with protesters surrounding him, and they had to escape from the back door to come to my thesis defense. So it was a very interesting day. Moving forward, I had my second arm of training at Northwestern in Chicago. And then Northwestern sent me an email around the same time asking me if I would like to come back to start the MRI guided program for brachytherapy. And like, heck no, I bought my private clinic. I'm a professor now. I'm staying in Egypt. That's my career. And things went from bad to worse in a few months. So I sent an email saying if the offer is still valid, I might come for a year. So I went there. They offered me master in clinical investigation. That's where he sees the purple gown from Northwestern. I spent a couple of years doing clinical work in the hospital and clinical research and basic science, actually research in nanotechnology. So I went to the OR, scrubbed induced cancer in the liver of rabbits and then treated these rabbits with IMRT when they recovered and injecting them with nanoparticles. I would say I was very lucky with my mentors. So in the same time, a colleague of mine came to Northwestern. I had Bill Small, this person here with me, and she had another mentor. She didn't really learn much. Bill was presenting me to the patients as a visiting professor from Egypt. I was younger, and I remember one of the patients saying, I know the system in Egypt is too young to be a professor in Egypt, which is correct. But between Gail Woloshak, who is a very famous radiation biologist, Bharat Metal, who was the chair of radiation oncology for 30 years at Northwestern, they shaped my future. They actually came to visit that's my apartment in Alexandria, Egypt. After my initial training at Northwestern during my doctorate degree, all of them came for a conference in Alexandria. We established this relationship, and they are the ones who invited me back to Northwestern. That was my training at Lille in France. Dr. Mohamed Al-Attar is in the picture down there. We were much younger. And I also went to Vienna. Christina Kiel is my mentor at Northwestern, and she invited me to a couple of community practice in Georgia, Savannah, Georgia. And she said that when you go back to Egypt, you should know how to train in a limited resource setting. Northwestern is very fancy. What you learn, you need to practice and apply in your home country. And that's why this was in Savannah in Georgia, was a limited resource place. During my career at Northwestern and now at Loyola, I directed the clinical research based on the Master of Clinical Research I obtained from Northwestern. I now lead the breast and GI program. I led the MR guided program. Now we're transitioning to Ethos and the adaptive program. I lead the hyperthermia IRT and the global oncology recently. I have passion in global oncology. During the medical school years, I was Egyptian representative to the International Federation of Medical Students Association. As you can see the picture on top here, Egypt was running against Germany to host the annual meeting, the GA. I was the head of the OC and we won, so we beat them. And all our Arab colleagues united to support us. And this was the meeting in Hurghada, Egypt in 2005. Moving forward in Astro, I am the vice chair of the international committee in Astro, the incoming chair. This was the Pan-Arab meeting in Algeria in 2023, where we had an Astro endorsed session. I also founded the Cancer Fellows Foundation, which is a nonprofit foundation in the US, where I'm able to bring junior radiation and medical oncologists, mostly radiation oncologists, to train in the US, where I pay for their travel and accommodation. We brought 27 so far. Most of them were from Egypt, but a few from other countries as well. And this is the international committee. So what are the blocks for success in radiation oncology, which I agree with Dr. Hussein Al-Hussein, it's likely to apply in any specialty, but we'll focus on radiation oncology. Those are the pillars of success. So clinical excellence, when you graduate from an accredited training program, you would think that this program is accredited, you had the best training, you shouldn't worry about exam, you will pass the test. You should worry about being a solid, competent, clinically skilled radiation oncologist. When you apply for a job in the US as a graduating resident, nobody is gonna question if you know how to treat with radiation or not. If you graduated from Loyola or from Northwestern, or from any program, we know that you should be able to treat. So do not spend your years in training just studying for tests. Learn from every patient, learn from every colleague, even from your fellow residents. Every information you get, the only and best time for you to learn is during your residency. You will still learn throughout your life, but during your residency, that's the most important thing. Learn how to speak to patients. When I was at Northwestern, and obviously, as you can see, I have a thick accent here, I was observing the attendings. I wanted to see which one of them is the most convincing for the patients. At the end of the day, it is a business. It's going to be your business, right? You're going to earn from this business as well. So it's important to have passion, but it's important also to be convincing for your patients, to expand your programs, to build your personality based on the different character of your attending that you're learning from. Still, it's a lifelong learning. You have to be updated in radiation oncology. As I mentioned in the pancreas cancer, every couple of years, there is new data changing the entire paradigm, right? Or there is new technology. When I started the MRI guided program, I was not even able to read an MRI, right? We trained with CT. Like, what the heck is going on here? And we had to learn. It's a steep learning curve, but you learn. Every day in radiation oncology, there is a new thing. A line RT came, and now we use it very frequently. I didn't even know how to do surface-guided radiation therapy. Now we do it to all my patients. So staying updated in radiation oncology is very important. Attend conferences, take courses, join professional societies, Astro, you name it, whichever you have access to. And again, I encourage you to apply for member in training if you're still in training. Those are for free, and it comes with tons of resources and discounts for meetings. This is one of the Astro Academy, and this is the next Astro meeting. Research and innovation. One thing that Bill Small taught me when I started, and in the first couple of years at Northwestern, I published 22 papers as first author. But he came and told me, ask yourself before you start any research, if you are not an author on this paper or abstract, are you going to read it or not? Don't just do research for the purpose of publishing. If you think you are not addressing a problem, if you think that, that's not your work, you will never read it because it's not interesting, do not do it. Try to ask questions that is relevant to your practice that would solve a problem. And then that will be a high impact research, even if it's a retrospective study, like as simple as checking if scar boost in breast cancer is effective or not. Simple things that would affect everybody, and it will never happen in a prospective manner, and it will be a high impact publication. Of course, multidisciplinary teams is very important, and be reliable with visibility and ambition. Mentorship and collaboration is very, very important. I was very lucky to have Bill Small. Bill really shaped my career. He is now my current chair at Loyola. He was the vice chair at Northwestern. He's the chair of education committee. That's how I made it to Astro, and then I progressed to international committee. But I was keen throughout my career to learn from other people. Eric Lartigot in France, Richard Puter. Here is Patricia Eiffel and Dr. Zeitman. Dr. Yarishar is running for president this year in Astro. All these people really shaped my career. Now, as a mentor, and I mentor many students and residents, it does help me as well. It's not only helping them. It makes you still updated. They challenge you. It kind of sharpen your own knowledge. So even if you are a mid-career or a senior radiation oncologist, try to make sure that you are mentoring other trainees. And there is a mentor match, as I mentioned, and it comes for free. So I encourage all of you to apply for this. Taking initiative and lead by example is very important. Align your goal with patient and system needs, and stay true to your values. I'm going to be quick. So now, there will be setbacks, definitely. life is not always green. It's always greener on the other side, but it's not the case, right? So don't just give up. I had a co-resident in the second year, she had a bad day in clinic and she quit the entire radiation oncology, went for internal medicine. You shouldn't do this. Bill Small himself, he had a bad day in clinic at Northwestern. He sent to Loyola saying, hey, give me a job. I'm not staying at Northwestern anymore. And they gave him the chair position. So use your setbacks to motivate you to rise up. Learn from critique. Do not take it personally. We have chart rounds every morning. If it happened in Egypt, I promise you, كان هيبقى في كلام وحش وشتيمة مش هقولها بالإنجليزي. We critique each other. We look through the contours. We can adjust 1 millimeter here or there. I am never offended. A second eye is best. At the end of the day, your patient is your best advocate. So learning from your colleagues, allowing for them to review your work does help you. So do not take it personal. And we are a small specialty. Radiation oncology is one of the smallest specialty wherever. So we need to know each other. We need to network. This will strengthen us. I'm very happy and proud now that I have friends like Dr. Muhammad Al-Dahaim, Dr. Ibrahim, Dr. Majid, Hossein Hijazi, Muhammad Attar, Akhuya, mish friend. That's how it works. And you should expand your network whenever there is an opportunity. Consider opportunities in research, education, and outreach. Avoid burnout. Do not overdo it. I have residents who are actually on antidepressants as we speak now. Balance between your mental health, physical health, and learning. Okay, enjoy your residency, enjoy your training. Do not overdo it. Having some leadership roles or some professional involvement is important. In the US, there is Saro, which is the Association for Resident in Radiation Oncology. If there is nothing like that in Saudi Arabia, it's about the time to create something like this. Networking with your fellow residents, it teaches you how to start collaborative work, how to take some leadership in a lower scale before you are confronted with the real life situation. You are lucky in the Gulf area, right? You have better resources than other countries, clearly. So try to make best use of this. Collaborate with organizations like Estro, IAA, Aortic, all these kind of things. And define your own success. Balance work and wellness. I'm going quick now because I have only 30 seconds. Stay curious, humble, and committed. Don't be arrogant. You will never know everything. Know everything about one thing. I would argue that I think I know everything about breast and GI radiation oncology. But you should also know something about everything. I can treat prostate still. I can treat gynecology. I still can do brachytherapy, right? So you should know the standard in everything, and you should know everything about what you do or what you specialize in. And yeah, aim high, but watch your steps, okay? So set your goals high. Set your goals in the next 5 years. Where would you like to be in the next year or 5 years? Do you want to be a chair? Do you want to be in administration like Dr. Hussein Al-Hussein? Would you like to make money and create your own private practice? Nothing is wrong, by the way. Everybody has their own preference and skills, right? But define your goal. Aim at it, but be realistic and watch your steps. Don't overrun it. Don't overdo it. Don't think that what you learn in 5 years, you are able to learn in 1 year. It's not going to happen. And by that, I thank you very much. And I wish Hilal the best. I'm going to be in the game, by the way, in Miami.
You, Tamer. Thank you so much for the inspiring talk. Now we move to the last talk of the session, and I have the pleasure to introduce Lahit Mullah Hussain, who is a distinguished radiation oncologist and assistant professor in Dalhousie University in Nova Scotia, Canada, and will introduce a brand new concept of which he's, I think, the global leader, which is ethics-guided radiotherapy. So please, Lahit, stage is yours.
Thank you very much for this kind introduction. And I'm afraid that I am the last one, is the worst one, maybe. I'm not sure, but we'll try my best, especially after Hussein and after Tamer. It's really hard to compete with them, but I'll try my best. So I have nothing to disclose regarding this talk.
and the meeting. The content of this, in this like 15 minutes, I will go through some pillars of medical ethics. What is EGRT, why EGRT, and my personal timeline of EGRT progress, and what's the current questions and objectives and the methodology and the initial results of this project and so far. Take-home message. So all of us as the doctors, we know that medical ethics are having 4 pillars. The first one is the autonomy. الذاتية. So we are respecting patients' rights to make their own decisions and about their health care, even if they are sometimes against the reality or against the proper decision, but this is the autonomy. For example, if the patient is refusing a treatment and the treatment is something recommended, but he has the right to refuse the treatment. Non-maleficence, do no harm. So avoiding treatments or interventions that may cause unnecessary harm or suffering. But this doesn't mean that there's like treatment without any risk. Every treatment can be associated with some acceptable risk. At least you need to disclose this risk to the patient, and the patient will decide whether he will take this percentage of risk of 5%, 10%, 50% sometimes, because this is the serious situation and you need to take a serious decision. Beneficence, الفائدة, acting in the best interest of the patient by promoting their well-being. Like, عامل الناس كما تحب أن يعاملوك. Put yourself on the shoes of the patient, for example. What you prefer if you are like in this position to take this decision. And the justice, العدالة, ensuring fairness in medical decisions and distribution of resources. And this is also come to the like policy makers and decision makers. When we are like distributing the resources, when we are like putting the staffing, when we are distributing the funds for the medical services, we need to understand what is the situation, and then we allocate the resources and put the staffing or send the scholarships. And if we are not dealing with the like people in a justice way, then we are dealing, we are doing something unethical. So this is the concept of the medical ethics. How we can integrate these concepts in the radiation oncology. So like a few years ago, I started to think about, we are always doing image-guided radiation therapy or surface-guided radiation therapy. So why not to do something ethics-guided radiation therapy? So it is referring to the practice of administering radiation treatment in a manner that aligns with radiation oncology ethical principles and standards. This approach ensures that patient care is conducted with respect and compassion and integrity, while considering the patient's values, preferences, and best interest. Like starting from the informed consent, it should be like detailed informed consent. If this is the choice, what will be the possible complications? What are the alternative choices, for example? Shared decision-making, transparency in communication, whether if you are like working in the private sector or in the public sector, balancing treatments, potential benefits and risks, multidisciplinary concepts, promote the patient's overall well-being. So why we are in need for these like EGRT principles? Sometimes we are in an ethical dilemma. When multiple treatment options exist with comparable clinical outcomes, but different interests to the care providers or different burden on the patients or system. If you are working in the public sector, sometimes we are promoting for hypofractionation, 40/15 breast fractionation, or 26/5 breast fractionation. While if we are working in the private sector, we are promoting for 50/25 fractionation. And we are in the same, I am the same person, but in the morning, I'm working in the public, and in the afternoon, I'm working in the private. So this is something like you need to put ourselves in the shoes of the patients. Like, are you like willing to be dealt like this or not? Avoid financial conflicts. Potential biases are
arise when financial interests intersect with the advancements in radiation technologies. For example, yesterday I noticed in the posters there's a preference, for example, in multiple treatments for palliative radiation therapy, and interest for the single radiation therapy is not that great here in this country. So, and we know that from the evidence now they are comparable. So why not also transfer this philosophy? Referral system, I noticed in one of the posters that the patients coming from within the same institution, they are having a better access and faster access, while the patients coming from outside, they have like more delay in the treatment, which is something we are not willing to have this like delay because of the health system. Improve shared decision-making, balancing clinical recommendations with the patient preferences presents a challenge. I remember one of the patients referred to me, and she was a single presented with endometrial cancer. They offered her like external beam radiation therapy after early stage endometrial cancer. And when I saw her, that was in the private sector in 2019, I told her, okay, there is a free treatment, but you are a virgin lady, and we need to insert like brachytherapy cylinder for 3 sessions, for example. So, and this is a free available in that facility. My facility that I'm currently working is only offering external beam, and it costs, for example, $4,000 US. And it like to my pocket, it will be like 25%. So I will have 1,000 to my pocket if I will treat her with the EBRT external beam. But I like found myself that I need to counsel with her about other alternatives that produce the equivalent outcome in the adjuvant radiation therapy for early stage endometrial cancer. And then she told me, you know, I am a virgin. I need to counsel my brothers. And she's like 50 plus, underwent hysterectomy. And then next day, she told me, my family agreed and will do with this like cylinder brachytherapy. So although that I lost a patient, but I feel myself that I was like happy because I provided a proper counsel to the patient, and the patient will be like not having financial toxicity, for example, because the patient need to pay for the external beam, not for the brachytherapy. And another story I always like remember, I was doing a fellowship and they told me to do a contour for multiple brain metastasis, 30 plus lesion, because they have fee for service, and this fee for service, when you are doing CyberKnife, we are like having more fee. I told the mentor, I told him, no, this is not suitable case for the CyberKnife. Just offer her whole brain radiation therapy plus minus hippocampus avoidance. He said, no, I will go with this. So I told him, I will not do the contour. Ask anyone do it for you. And then the patient got received the CyberKnife for 30 plus lesion, and the patient after 2 weeks in the ICU, she expired. And when I like looked into myself, like this treatment, like put the patient in a lot of toxicity because of the radiation induced brain edema, and the patient was in the ICU and the patient died. And the reason because the benefit of the treatment for the treating physician is more than the benefit for the whole brain radiation therapy, which is really sad. When I looked into the literature, doing mesh PubMed search, I just found 58 articles in radiotherapy and ethics. And then when I looked carefully, just found like a handful papers in this. So I decided to initiate this project and submit it for the ethics board review. Only have 5 minutes. So the personal timeline of this EGRT started in 2013 when I wrote a paper about rights of the cancer patients in the Arab communities. Then in 2018, I wrote the lessons to improve the quality of care in the global radiation and global oncology care. And then in 2021, I decided to go to the level of education and to improve how we can have better competent radiation oncologists for the trainers and for the trainees. And then in 2023, I wrote the editorial about AGRT, the necessity. And then I submitted the proposal for the House for Nova Scotia Ethics Board. And then also last year, I presented this concept at the UICC World Cancer Congress in Geneva. And this year, after finishing the first phase of distributing the survey, I am presenting the initial results at the Saro now. And then next month in Vienna at the ICARO meeting, International Conference of Advances in Radiation Oncology by the IAEA. Also, it will be presented at the Canadian Radiation Oncology Society, Canadian Association of Radiation Oncology, and at the ASTRO. And hopefully it will be later on published as a manuscript and after the full analysis, because it's not ready for the full analysis. Hopefully next year, we'll go into phase 2 of this initiative by doing Delphi structured questions. And then we can formulate certain guidelines, and that can be hopefully endorsed by other like large professional authorities like ASTRO or ISTRO or IAEA, UICC, and also we can conduct some educational courses over some time, whether on-site or online, about like principles of AGRT. I'm happy that I'm helping now the IAEA as a reviewer of the next year syllabus that will come out, inshallah. So the first phase is to understand the CAP, the knowledge, attitude, and practice of EGRT across the radiation oncology globally. So we formulated a questionnaire and we sent it for validation to 5 experts in radiation oncology. And after the validation, we designed a platform, and then we decided to recruit about 175 as a minimum radiation oncologist physicians, and to have their opinion about the knowledge, about the attitude, about the practice. And also there's part of qualitative questions, and I'm not presenting the qualitative questions today. So we are still in the quantitative analysis, data integration and data analysis. We are still like in the doing some statistical testing, but today I will just present the descriptive data. The idea is to see how the radiation oncologists are aware about the EGRT, the principles. We put some questions, and from these questions, we will understand how will be their knowledge, and also how will be their attitude, and how will be their practice. So we achieved a good recruitment from the target of 175. We achieved 310 participants, and 264 participants completed the survey. So we bypassed the target. The participants like across the globe from the 6 continents. The most participant country is from the United States, over 30 participants. In the middle, in terms of continents, the most people are from Asia, which is obvious because the Asia is the most popular continent. But also we have participants from Africa, from Europe, and from North America. Gender majority are male, which can be also expected because maybe the manpower is more in this regard for the males more than females. In terms of age, they are well distributed. 2/3 of the participants under the age of 50. Also, we are here describing the years of practice, and whether less than 5 years or less than between 5 to 10, and then 10 to 20, and more than 20 years of practice after certification. and also based on the number of the patients that they are seeing, and the whether the practice is only for adults or adults plus pediatrics. And we went also through the income of the practicing radiation oncologist, whether this is like for fee for service or fixed salary or mixed, and also the setup, whether this is an academic or a public or a mixed setup. This is just like فاصل ونواصل. صورة كانت تجمعني مع الأحبة دكتور حسين ودكتور المغربي ودكتور إبراهيم، كانت قبل تقريبا 12 سنة، ودكتور عدنان الحبشي قبل 10 سنوات. والعالم صغير ونعود ونلتقي إن شاء الله. ما شاء الله الآن الشباب أصبحوا في مواقع قيادية، دكتور حسين ودكتور إبراهيم والجميع ما شاء الله ما عليهم قصرة. دكتور هاني، دكتور فايز، ثقافي. طيب, if we come to assess the knowledge, I'm over time. So in general, we have good knowledge of EGRT among the people, of the participants, 81%. In the attitude, we have about 79%. In the practice, we have about score of 67.5%. And overall, it's a moderate cap of EGRT, 77%. When we are asked them whether they are understanding that EGRT can be part of the intent of the treatment, whether this is palliative treatment or curative treatment, is EGRT as a concept can be part of it? 96, yes. And also to the definition of the target volume, whether if we are increasing the target volume or decreasing the target volume, is this is also can be applied as part of the EGRT, because when we are increasing the volume, we are also increasing the toxicity, and this can be unnecessary toxicity. So you need to be like on the spot. But some people may ask, okay, I will be more generous because I want to make sure that I'm not missing. Okay, if you have the technology of hyperside and adaptive, you need to be precise. But if you don't have the technology, for example, okay, you can be reasonably generous, not over generous, because otherwise we will be like in the back of like 2D treatment era. We are just treating more area in order not to miss the target. The dose and fractionation, good, like 96% of the participants thinking that EGRT is also can be part of the dose and fractionation to adapt the radiation therapy treatment if we have the facility, and also in parallel with the ALARA principles as low as reasonably achievable. And knowing the EGRT will lead you to be more consistent with the quality assurance and peer review protocols, and also to think about the EGRT. Is it easier to implement it in the public sector or in the private sector? So 60% they think that it is easier, which I think is right, but 40% they are think no, it shouldn't be easier, it should be the same. Regular patient checkups. Sometimes I'm seeing doctors like asking to see the patients every month for follow-up and every 3 months for investigations, which is sometimes it is not necessary based on the guidelines, but they are doing this for more like visits, more income generation, which also sometimes it's not matching with the EGRT. If we come to the like attitude, good, 91% they think that EGRT will keep you maintaining the standards of care, will keep you in guiding the resource decisions to inform staffing plans. We need to think ahead, like after 5 years, our population will be this number. We need this staff.
Sorry, just one more minute.
Okay, 1 minute. So I will just skip the rest and practice. 62% of the people are involved in the peer review, which need to be improved. The adherence to the guidelines, balance of the radiation oncology decisions, and engage in CME or CPD, and also quality assurance. This is picture from the best of ASTRO that we arranged in Iraq in 2015 and 2016. The next is to complete the analysis and to move to the next phase. And take-home messages that there is moderate to adequate knowledge, attitude, and practice of EGRT among radiation oncologists globally. High theoretical support exists for core principles of EGRT, particularly in relation to safety, consent, and evidence-based practice. Engagement in supportive activities like CME, quality assurance, peer review is inconsistent, potentially undermining the systemization of EGRT. Cultural resistance and interpersonal conflict can be significant barriers to implementation, and underscoring the need for effective leadership support, improved communication strategies, and collaborative teamwork. And I have to thank the co-investigators across the globe. We are like from over 10 countries and a total of 25. And thank you for your attention.
Please.
Thank you very much. I have a few comments. First of all, I'd like to say that when we planned for this Young Saro session, it was very challenging because last year this session was very good and they raised the bar very high. So we decided we should really pick important topics, excellent presenters. And I have to say, I'm happy. We've really picked excellent presenters. Thank you all very much for your presentations. And thanks to the audience who stuck around for the last session of the day. One thing, before this session, we were looking around and thinking there are few residents. Most of us are not young by definition anymore. So we were kind of worried that this might not go as well as we would like it to be. But I have to say, each and every one of these presentations were an excellent, gave me excellent knowledge, information, advices. I really benefited from these presentation. I'd like to point one thing on each presentation, if you'd allow me. So Dr. Hussein, I have to tell you, he's my senior in residency. And everywhere I go, I keep saying, I know Dr. Hussein, he was my senior. I have to be proud. I remember our program director told me that Hussein wants to be a leader one day. So it doesn't start after residency. It starts from day one. You know where you want to be. We're not all going to be leaders, but those of us who know they want to be leaders will end up doing it if you just do it right. So mashallah, you did it. Congratulations. Dr. Rafat, during your presentation, I noted that you're actually giving more messages for us as mentors, educators, than you are for the residents. It is very important for us to notice that every word we say to our residents, every advice will shape their futures. So we have to be very careful in selecting those words and advices. I think during your presentation, you kept saying this mentor said and that mentor said this or that. I think it's very important for all of us to make sure we know what to say and when to say it, and we don't end up being the mentor or educators who lead to people quitting programs or doing other things. For the ethical presentation, excellent presentation. Thank you very much also. I think for those of us who end up in the in leading positions, it's important to help people not be in very difficult ethical positions. So instead of paying by fraction, it is sometimes easier if you pay by course, or we're all human and we try to do the best for our patient and to keep being ethical as a top of our, but we're all human, and sometimes you can justify to yourself that, no, I'm not doing this because it's more fraction, I'm doing it because there's more evidence, etc. So if the payment was done for a course or for a larger number of fraction that accounts for all, and this is what we do actually in our center, when instead of saying one fraction, for 5 fraction breast, you get paid this much, or we do 1 to 15. So it all kind of fractionation that we use fall into one course. So we don't feel like we have to take this decision for financial reasons. Those were all my points. Thank you very much.
Thank you very much. My name is Atlal Abu Sanad. I'm professor of medical oncology. I'm not a radiation oncologist, but I cannot tell you how much I enjoyed this session. It falls right away into what I'm working on and what I'm caring for. I call it a very large survey, the first on burnout from the region. Dr. Mullah Hussein is one of my co-author, and Dr. Imad Shash from Egypt is another co-author as well. The burnout is very high in our region. Of course, the majority of the participants were 2/3 were medical oncologists, 1/3 were radiation oncologists, and the burnout prevalence was 68%. This is the first multinational trial from the region, or actually study. I would invite you really to look it up. It was published in 2021. It's called BOMENA, BO for burnout, and MENA for the Middle East and North Africa. The beautiful thing about this, which I loved, the wheel diagram you presented is amazing, and I loved each part of it. But we need to tell our resident and also ourselves, we don't have to be all of this, okay? Find out what is your best fit. Maybe you want to do some personality assessment test. There are available online, paid, unpaid, such as Berkman. I took a test recently just to understand myself, perhaps in a better way, to understand my strength, to understand how I deal under stress and how I'm seen through people's eyes. It's a beautiful test. It tells you loads about yourself. The other thing mentioned by Dr. Prof. Tamer is mentorship. It's not only mentorship, because we need also to encourage sponsorship. Mentorship is guiding, but sponsorship is supporting. You have your junior, you present them to your community, you introduce them, you give them the power to be visible. We need to do this. You said very beautiful sentence. We need to make the path easier for the ones after. Thank you very much, because I personally, as a medical oncologist, للأسف السعودية الميديكال أونكولوجي بالذات الفيميل ميديكال أونكولوجيست we're only 20. أنا ما أعرف الريشيو عندنا معكوس. الراديشن أونكولوجيست ما شاء الله أكثر بكثير. بس definitely I faced a lot of challenges coming back from Canada, transitioning to Saudi Arabia in 2014. It's been almost 11 years now, but I found my way. Okay, the hard way. And I don't want this to happen to the next medical oncologist or radiation oncologist. Thank you very much. I want to be part of this, please, because unfortunately in medical oncology, we don't have this. Okay.
Thank you very much for this insightful and motivating talk. So I'm Ghader Al-Garni, a medical intern and aspiring radiation oncologist, inshallah. So this talk was all what I needed right now. Thank you, and thank you for the organizing committee. So I really appreciate the perspective on the diverse domains radiation oncologist or a physician needs to put into consideration their career. My question was, I was wondering, Dr. Hussein, when in your career do you think is the most appropriate time to address opportunities outside the direct clinical practice, especially if opportunities are available and a person believes she or he has the interest and capabilities of them? Thank you.
يعطيك العافية. أول شيء موفقة وبإذن الله إن شاء الله you realize being a radiation oncologist and we will be very proud to see you بإذن الله الأحد. So لكل وقت له احتياجات. So Dr. rightfully have mentioned and addressed the talk or the point and Dr. Laith of the burnout. There are things that you would start while you're in the medical school. So being part of teaching, training your colleagues, those in the same level or those who are kind of more junior to you. And all these aspects, I'm not going to go through all these domains. So all of these aspects, there's parts that you can do it, but keep in mind, what is the primary focus? In medical school, your primary focus is to be a well-rounded, competent general physician. Then when you go to residency, or actually the transition between medical school and residency, you would like to match to the specialty that you aspire to. You will match to radiation oncology when you work hard to make that. Then you would like, the other priority when you're in residency, you would like to work hard to acquire all the skills, competencies to be a competent radiation oncologist. But keep in mind while you're there in medical school and in the transition and in the radiation oncology residency, and after you finish, that you try to keep all these core competencies and core areas in your mind without jeopardizing on the burnout. The only thing that's going to stop you is two things, I will tell you. Burnout, physical, mental, or kind of psychological, لا قدر الله, I don't want to use it. No, I don't, social as well, yes. But I don't want to use the word addiction. Some people would get addicted to لا قدر الله drugs in order to deal with issues during that. And we have seen in certain specialties more than others, and that's something that we have to keep in mind. So you need to keep that into the focus. So if you jeopardize yourself through your health, burnout, and others, you would not be able to make what you wanted. That's number one. Number two, conflicts. Some people have been very successful, smart, they take a good care, but they have been into conflicts, unnecessary conflicts that will help, that will not help you. You don't have to go to a fight. So eventually it's good to get you out of the residency training program or get you out of your practice or other things. So these are the things. Dr. Ibrahim Al-Umar is not here. Ibrahim Al-Umar is a radiation oncologist in National Guard Health Affairs in Jeddah. He told me in 2006 when I came to do the residency interview, and then I get accepted, Gal, I will have only one advice to you. When I get accepted and just going back to Riyadh, I was in Ottawa that day, flying back to Riyadh on that day. Tell me, Hassan, you get accepted, and I knew that you would not have a problem doing the interview. But I'll tell you one thing that I would be assured that you will pass through the residency. Don't make a complaint to anyone. Matter if you have heard that from anyone before, don't complain on anyone. There are people that just, keep complaining, keep making fights, and I keep this in all my mind. Do you think in my residency there was not issues that I had to make complaints? And Reem, by the way, she was talking. She was one of the outstanding colleagues that came through Ottawa. Ottawa continued to have residents throughout the years, and keeping in mind that making conflicts, that unnecessarily you have to do it, trying to have your threshold to make a problem, just keep on that. So these are the two things. Make sure that you work hard, burn out, watch out for it, and don't make complaints. You have sometimes to do so, but each time it requires certain capacity. Now I'm ready right now to make problem with anyone. I will tell you who stops radiation oncology residency program, who stops medical physics residency program for diagnostic, for therapeutic, for nuclear medicine, or stops in advancing other careers, that we will be always in shortage. Right now, yesterday I had a very tough discussion with colleagues that, God's sake, medical physics, diagnostic, radiology, and medical physics for therapeutic radiation, and medical physics for nuclear medicine is coming. And we need to work also for dosimetry, medical dosimetry, by the way. And we have to, the conclusion of this conference, any residence, or actually any department of radiation oncology that does not submit for their accreditation, if they have even one requirement for one training rotation, I'm not talking that you have to be having the program fully accredited. There is full accreditation, there is partial accreditation, and there is as a shared program, and as a training unit. So we have to put the resources together because we cannot live forever short in medical physics. We cannot live with that. And there's no one who's going to benefit. And don't tell me that we don't have trainers, we don't have this, we don't have that. If you don't have a trainer, that means that you have short sight. We don't keep the strategy so that in 3 years from now, we'll have more physicists, 6 years from now, you're going to double. 9 years from now, you're going to have. Because that will help. Because we can run short. Safety, national health, security, and from all points of view, we are running short of that. So you get the idea. So there are areas that with certain capacity, and again, I cannot go into conflicts like going on, but within professional manner, trying to push through, trying to go through. So that's what we are willing. So each one of you have a responsibility when you go back for your department. Please ask your department chairperson, where is medical physics residency? In Jeddah and Riyadh and Dammam and other ways, where is it happening? Why we are gonna stay short of medical physics for this? And don't tell me we are too busy. Don't tell me what are the incentives, because this is not acceptable excuse. That's what I can say. And here we are. So take it at ease, and at each stage you have certain things. And I totally agree. These keep it in as a target, but you're not gonna happen between one night and the other.
Thank you. Thank you for highlighting that. I'm really happy to hear the discussion on mental health coming up in a training session. I think what's been said about burnout is really important to keep in mind, particularly for people who are so motivated and have demonstrated early on that they're hardworking and committed to improving patient care. But I have a personal interest in burnout, and I've investigated from the medical physics side. So what I noticed is that a lot of the onus seems to be put on the individual and less responsibility on the institutions and people or the systems. So I think since we're having this discussion about education and training, there's a responsibility on the trainers or the members of the program directors to also keep that in mind and to try to create systems that help individuals maintain their mental health and serve patients, because at the end of the day, we are all human, and if you don't take care of yourself, you will not be able to take care of your patients. So that's what I wanted to add.
I think that I would say in the ethics point, I would like to mention that the greatest actual presentation Dr. Laith have presented. I'm just gonna get a case that have happened just before Ramadan. I do head and neck and CNS stereotactic radiosurgery. There was this 13 years old boy from, he's not a Saudi citizen, who came through the business center to be treated for AVM SRS, and in the discussion, he had been recommended to go for SRS. He's 13 years old. Had a very large AVM that has to be done in multiple courses. And eventually the patient had embolization with some occlusion, and then he's referred for the remainder of the AVM to be treated with SRS. I had a very lengthy discussion over an hour with the patient, and eventually came out to the conclusion that to the patient, this is not in your best interest. There is a way that we can go surgically through this, and the neurocognitive dysfunction that we're going to have is going to be devastating and it's going to be lifelong. We had that, and I referred him to the neurosurgeon who's I trust. And after reviewing his images, he said, yes, we can do it. We can go after it surgically, and we can avoid the radiation part of the patient and the neurocognitive dysfunction. Eventually, the patient went abroad, back to one country that he have been seen. Within 1 week, he had his SRS session done. That's something that we have to remind ourselves, And I know, and in certain places of the world, finances will drive treatment. It's better that for me to get this $50,000 worth of treatment than others getting it. I told the patient before the end of the conclusion, if anyone tells you that to go for SRS, please run away, because I know that he would probably have that. Unfortunately, he did that. And it was funded by a humanitarian fund. Eventually, the payment went to the pocket of that hospital, with the cancer center and the radiation oncologist. And the patient is going to be left with the damage that could be avoided through surgical intervention. So we have to keep all in mind. I got luck, or whatever. No, it's not that way. We have to be very careful of that. Unfortunately, commercial aspect of healthcare is devastating to the health professions and to our integrity and to the community. So I can't commend on the work that you do, Abu Yahya, on the great work that you're doing. Allah يعطيكم العافية.
Any further question؟ أعتقد ما شاء الله يعني hot topic. ما شاء الله الجميع مصحصح على خير. جزاكم الله خير صراحة جميعا، أسأل الله أنه يكتب أجركم جميعا. يمكن نحن كده خلصنا هذه وننقل
So we now come to the end of this meeting. I hope you enjoyed it as much as I did. I thank you all, speakers, moderators, great audience for engaging and for participating. If this conference is only as good as people engage, and we've had great engagement. So thank you all very much. Thank you for sticking till the end, for those group of you who are still here. And I thank, especially the medical oncologists, special applause for the medical oncologists in the group. I hope, again, you enjoyed it, and I thank you all very much. That's all I have to say. And if you don't mind, we'll get a group photo. To the stage, and I forgot it. I really would like to thank Dr. Majid Al-Ghamdi for giving me this opportunity and for being very supportive. I have to say he did most of the work. I was just chairperson, just on papers. And Dr. Ibrahim Al-Attan, you can't see him, he probably, and Dr. Yusuf Katib. Really, of course, everyone else. The scientific and organizing committees were great as well. Thank you all very much.